and it is my pleasure to invite to give the ISU USI lecture by Dr. Mallikarjun from India. Good morning, Dr. Mallikarjun.
Morning, sir. Morning, sir. It's my pleasure and it's been honored to be giving this lecture. I think, good morning, Dr. Vaidya. Good morning, Dr. Agarwal.
Good morning, Doctor.
It's a wonderful morning. I think my recorded presentation is there.
Good morning. We can see you now.
Thank you, sir. Thank you, and very good morning to you all, Dr. Vaidya and Dr. Agarwal. It's my pleasure and honor to be delivering this lecture today to the Nepal Urological Association of Urological Surgeons. Well, I think I've recorded my presentation. I think they have to play that. And I'm happy to answer the questions after that.
Yes, sir, we are playing it.
Yep.
Just 1 minute, sir.
Dr. Mallikarjun brings the best wishes from Urological Society of India. Thanks for giving me this opportunity to give this lecture in your annual NAUS conference. And my topic today is minimally invasive management of renal hilar tumors. Well, renal hilar tumors are supposed to be the most complex tumors of all. You need to assess the complexity of the renal hilar tumors. There are many scoring systems to show the complexity, and majority of the scoring systems show that it is the most complex tumor to operate. But I really don't believe it, not arrogant, but I think each case has to be managed individually. What factors makes it complex? There's so many factors which make them complex. One is poison, another is smoke, human heredity.
Good morning, Dr. Mallikarjuna.
Morning, sir.
Is it working for you?
No, sir. We are not able to see. It got jammed.
Yeah. There. I wanted to be sure that it's not my own problem.
No.
I think it should be.
Yeah, I think it's
beginning
coming
from
now.
the beginning. Yeah. Okay.
Yes. Results and the tumor anterior lip of the kidney.
Sorry for the problem, sir.
Are going to be clipped and divided.
We are going to restart with the audio. Sir, we are having technical difficulty loading your file. Do you have your file with you right now? Can we do it live? So you need to be unmuted first.
Yeah, I'll just load it off from my share screen. Give me just 10 seconds.
Sure, sir.
Somebody has to stop share screening, please.
You can share your screen now.
Yep. Done. I'm just looking for my. Good morning, everyone. Greetings from Urological Society of India. Dr. Malika. Thanks for giving me this opportunity to give this lecture with the annual last conference. My topic today is evaluation marriage. Well, general highlight tumors are supposed to be the most common form. The complex system of highlight. There are many variants show the complex. The majority of the stories
We cannot hear you, sir.
we can't.
Malik, you have to remove the earphones from there, perhaps.
Annual Nurse Conference, and my topic today is minor invasive.
Are you able to hear me?
Well, the renal tumors are supposed to be the most complex tumors of all. We need to assess the complexity of the renal tumors. There are many scoring systems to show the complexity, and majority of the scoring systems show that it is the most complex tumor to operate. But I really don't believe it, not arrogant, but I think each case has to be managed individually. What factors makes it complex? There's so many factors which make them complex. One is surgery, another is host, tumor, anything. So it is not tumor alone which makes it complex. Surgical experience and the host factors also make it complex. Radiology is an integral part in analyzing these cases and planning the excision. You should know the vascular supply, whether the margins are well defined or not, or there's any sinus accumulation, it is a very pseudo capsule is there all around it or not. The relation to the PCS is that going to be anterior to it or posterior to it, and the clinical reconstruction in a CT will always help you in getting the complete information. It is thought to be very, very difficult, but I think it is quite not so difficult. Once you are told that there is no relation of fiber structures, you will know the relation between the segmental vessels and the pelvic system. There is a natural opening which exists inside the sinus, that is a hilum, that is a sac inside the hilum will give a pelvis for dissection. The good radiological assessment, as said, is very important. What is most important is margins, ischemia, and complications have to be decreased so that you should understand your feasibility and competence. There is no compromise in putting the ports or planning the procedure. So you should be very, very confident in doing those procedures. You need to know the technical feasibility, oncological clearance, perioperative safety, and surgical capability in doing these procedures as mentioned. Where all they can be in the or completely inside the hilum or related to the square part of the hilum or inside part of the hilum. Tips for hereditary operations is
Are you able to hear or no?
so that the vein is distinct.
Can you mute yourself? The video sound will come better.
It is full of echo, and we hardly can understand anything at all.
Okay.
I'm sorry. So I think we may have to take a short break, say
Okay.
for 5-10 minutes, and let the technician adjust it better.
Okay, sir.
Thank you, Dr. Mallikarjun. Please be patient with us.
Good morning, everyone. Greetings from UROCON, India. Good morning, everyone.
Welcome back,
Good morning, everyone. Greetings from Urological
Dr.
Society of India.
Mallikarjun. I think the sound is better now. Still some echo is there. Shall we start then? Okay. There is a green signal from the technical side. Shall we restart now? Sorry.
Good morning, everyone. Greetings from Urological Society of India. I, Dr. Mallikarjun, brings the best wishes from Urological Society of India. Thanks for giving me this opportunity to give this lecture in your annual NAOS conference. And my topic today is minimally invasive management of renal hilar tumors. Well, the renal hilar tumors are supposed to be the most complex tumors of all. You need to assess the complexity of the renal hilar tumors. There are many scoring systems to show the complexity, and majority of the scoring systems show that it is the most complex tumor to operate. But I really don't believe it, not arrogant, but I think each case has to be managed individually. What factors makes it complex? There's so many factors which make them complex. One is surgeon, another is host, tumor, everything. So it is not tumor alone which makes it complex. Surgical experience and the host factors also make it complex. Radiology is an integral part in analyzing these cases and planning the excision. You should know the vascular supply, whether the margins are well defined or not, or there's any sinus fat invasion. It is a very pseudo capsule is there all around it or not. Relation to the PCS, is it going to be anterior to it or posterior to it? And a 3D reconstruction in a CT will always help you in getting the complete information. It is thought to be very, very difficult, but I think it is quite not so difficult. once you are clear that there is no invasion of hilar structures, you know the relation between the segmental vessels and the pelvic alical system. There is a natural plane which exists inside the sinus, that is the hilum, that is the fat inside the hilum will give a plane for dissection. A good radiological assessment, as said, is very important. What is most important is margins, ischemia, and complications have to be decreased, so that you should understand your feasibility and competence. There is no compromise in putting the ports or planning the procedure. So you should be very, very confident in doing those procedures. We need to know our technical feasibility, oncological clearance, perioperative safety, and surgical capability in doing these procedures as mentioned. Where all they can be in the anterior lip of the hilum, posterior lip, or inside the hilum too, or completely inside the hilum, or related to the superior part of the hilum or inferior part of the hilum. Tips for hilar tumor operations is avoid vein clamping in the anterior tumors so that the vein is distended. You know where you are injuring the vein. A Gilvenred plane is very essential, very useful in posterior tumors. A polar resection is possible in superior or inferior relation with hilum, and intrahilar tumors requires radial nephrotomy, which will show how to demonstrate them. Anterior hilar tumor is a nice anterior hilar tumor case which is being dissected. The initial dissection happens between the vessels and the tumor, anterior lip of the kidney. See the feeding vessels which are going to be clipped and divided. I don't advocate keep the vein open or distended at the same point of time. Don't clip the hilum at this post dissection when it is happening inside the sinus. It will make you understand where the vessels are there and where the bleeding is going to happen. So this dissection, which is very, very important. At one point, it cannot be proceeded further. Then you clamp the artery and start dissecting. I don't advocate venous clamping. So that is an incision made into the parenchyma, and now you deepen the incision into the parenchyma and you will reach the hilum directly. A part of the dissection is already made in the posterior aspect, so you will start to realize the rest of the dissection is being done under direct vision. You can see the calyces which are getting opened and small vessels which are getting supply into the tumor, which are dissected and divided. So that is a division which is going to happen. And that is a small vessel which is supplying the upper part of the tumor, which is clipped. So having done this, a majority of the vascular supply to that area has been taken care of. So you have taken care of the vascular supply at the source, and now you are left with a raw area. So you're going to have, you don't take a deep bites here because that's going to injure the rest of the vessels going to the kidney. Make a very shallow bites with 30 Vicryl, which is good enough, and small bites in the edge of the parenchyma where these veins which are going to bleed. After this, the rhinorrhaphy is done if it is possible by keeping a fat pad which covers these clips and then closing the renal cut area surface. So keeping this fat will prevent in this erosion of these clips or erosion of the clips into the veins. That's an anterior hilar tumor which is completed. This is a posterior hilar tumor, supposed to be the most difficult thing to do, but it appears to be much easier when you start looking at a polar flip technique which you have published. That is, after mobilizing the kidney, after completely mobilizing the kidney, you twist the kidney. The lower pole goes medially and the upper pole comes laterally, so that the posterior surface of the kidney is completely in front of you. That's a mobilization of the kidney which is done. And that is a flipping of the kidney and a polar flip which happens. The lower pole going medially and the upper pole coming laterally, and their posterior surface is completely exposed. Now you start dissecting in the Gilvenred plane what you have done for a pylolithotomies. Steady dissection under the surface of the tumor will show the posterior segmental artery, which can be easily clipped, and a good control of the vasculature is going to be there. Once done, you now the clamp either with your Satinsky or with a bulldog, and then excising that posterior segment completely. So now you have already made the dissection inside the hilum. Now you make a incision all around the tumor in exactly at the borders of the posterior segment, and then excise it. And there's nothing to worry about. In fact, anterior tumors are difficult, posterior tumors are much easier because there's no major vessels. It is only the pelvic system which comes into place, and that is the tumor. You can see that is the calyx which is going into the tumor area, and you are quite clear away from the tumor, and you are going to clip those calyces which are entering into that part of the tumor. The same sort of a stitch is going to be made just at the edge of the parenchyma, creating a small good control of the vasculature. The majority of the vasculature is taken care of by clipping the segmental artery, posterior segmental artery. So now you sutured this rhinography and positioned back the kidney into the same position after declamping and checked for the hemostasis. That's a very simple way of doing a posterior hilar tumor, and mobilizing the kidney and flipping the kidney is going to be the best way. Now having unclamped it, checking the posterior surface and then repositioning and fixing the kidney, rhinography is done. Nephropexy is done. Towards the pole of the kidney, sometimes tumors are there which can be done by doing a lower polar tumor on the right side, which can be taken care of by excising the lower pole. That's a polar nephrectomy which is being done transhilar way. You get into the hilum, that will be able to give you the plane where you need to see. You can see the tumor stretching the inferior calyces, which is being separated away, and the tumor is enucleated away from the hilum, and the lower pole is taken care of. Simple way to excise the lower pole or enucleating this tumor without excising that lower pole is going to be a very, very difficult task. So that is a better way to do it, of excising, closing the inferior calyx, and then doing a rhinography. So lower polar nephrectomy is the best way to do in this sort of a tumors which are very near to the hilum and large tumor. Completely inside the sinus, it's an MRI in a CKD patient which shows an intrahilar tumor which is completely inside the hilum, posterior to the PCS, that is posterior to the pelvic calyceal system. So what we started doing is, we started excising this tumor by doing after mobilizing the kidney. That's an isolation of the tumor. That's a tumor very well seen. After mobilizing and clipping the kidney, we made a posterior radial nephrotomy. That's a nephrotomy made in the posterior radial surface between the upper pole and between the posterior segment and the lower segment, which corresponds to the line of the inferior calyx. This is what we used to do when we used to do a nephropylolithotomies for large Targon stones once upon a time. That gives opening of the hilum completely, and you start enucleating the tumor inside the hilum. Majority of the vessels to this tumor is supplied on the anterior surface. The posterior surface mostly don't have any vessels. It can be very well enucleated. There's a pseudocapsule which is seen very well. And during enucleation, in the anterior surface, you see that vessels which supply this tumor which are divided. So that's how opening up of the hilum or the sinus will make this enucleation of this tumor, which is completely intrahilar. And that is the hilar tumor which has been completely enucleated. And you see the small vessels which are supplied from the anterior surface, which taken care of by simple small 3-0 small interrupted sutures. Don't do a continuous suturing here. The small vessels can be taken off with an interrupted suture. Following which you do a repair of the rhinography without any surgical or anything, which is not necessary nowadays. So that's how a posterior radial nephrotomy will help in enucleating these tumors. So robotic hilar tumor is no way different. It is going to be the same, and I don't have any specific way of doing it. The way of doing it is going to be the same. There's nothing, but probably the precision is going to be much better in this. And the same way I just replicate when I start doing this robotic tumors. That's the way, and excising it and doing it. And doing a rhinography in open. Don't clip the vein, that will keep the vein open, and you know where it is going to, where it has been injured. So to know that the conclusions are, principles of surgery are same, whether you do it minimal invasive or open or robotic. Proper anatomical assessment is mandatory. Intraoperative ultrasound will help in knowing the tumor, the extent of tumor. Mobilization dissection has to be perfect. Open, whether you do an open, lap or robotic, good result matters. All the best to all of you. Thank you very much. Good morning, everyone.
Thank you, Dr. Mallikarjun. Can we see him live?
Yes, sir.
Okay. It was excellent. We know you've got a very fine pair of hands, and both in laparoscopic as well as robotic. So it looks easy, but it will be technically, I would have thought, very difficult. And at some point, I see that it is like a enucleation of the tumor. Now, if you, in the biopsy shows that there is some tumor margin positive, what would be your suggestion? Is it like doing open and clinically you thought you have removed all the tumor, then you wait and see because the long-term result is no different. Does it apply the same here?
Fantastic question, sir. The question is two things. The three steps to the same question. Number one is preoperative, intraoperative, and postoperative. Preoperative, I think the most important crux of it is understanding the radiology. I would attempt this sort of a surgeries only when there is a nice tumor encapsulation. If there is no encapsulation, it will end up in a wedge resection of that polar tumor. It's very uncommon for renal tumors to get out of that pseudocapsule and invading the sinus fat. But if the pseudocapsule is not well defined on a CT scan, don't attempt these tumors for a renal preservative surgery, that is renal conservation. So that is the first step. So you need to have a nice pseudocapsule preoperatively to understand that these tumors can be excised in this fashion. Intraoperative, whenever you have a doubt that you're going through the tumor, next step is to be upgraded. There is no other choice. There is nothing like wait and see policy. Occasionally, it is only in those cases where the postoperative, the margin becomes positive. In that case, I would say if there is no gross violation, it's only a microscopic disease, low-grade disease, I would still wait and see in these patients and see very carefully follow up whether a requirement for a radical conversion is necessary or not. I think I answered this question. But one thing, whenever we think about an enucleation, you should know that the tumor is amenable for enucleation.
Thank you, Dr. Vimarjan. Now let me welcome Professor Gewali to the chairman's seat. He is keen to ask you one question.
Sure, sir.
Dr. Mallikarjun, good morning.
Hi,
This
Prem.
is Prem.
Hi, Prem.
Hi. Because of you, I can say proudly in this forum, because of you, we have started laparoscopic surgery in Nepal. Thank you very much. How you encouraged me to start with the laparoscopic donor nephrectomy also. My question is that now in Nepal, we are doing the regularly all kind of the laparoscopic urology surgery. But in partial nephrectomy, we are still reluctant. If it is partial, usually we go for the open surgery. Do you have any suggestion for the novice or beginners who are starting such type of the surgery first time or very rare surgery for us? Can you suggest how should the surgeon should go like in this field?
I think Prem, the simple answer is the learning curve for everyone, every human being in this world is almost the same. It may be 20 cases for one person, another is 30 cases, nothing more than that. But the question is, how many you have done before that makes it easy? It is not a surgery for novices. Like people who have not done a 50 radical nephrectomies should not even attempt of or think about doing a partial nephrectomy. So it is one thing which we need to understand. I would say if somebody wants to do a laparoscopic partial nephrectomy, I would say that he should have done an open partial nephrectomy at least 10 times to understand the tissue texture, the plane of dissection, how does it look like, how much resistance it will have, how much retraction it will require, etc., etc. Without that, directly attempting on a visual memory of a video on a laparoscopic partial is not advisable. The easiest thing is to do an open partial nephrectomy 10 to 15, 20 times and then think about a laparoscopic partial. And before that, again, think about doing 50 laparoscopic surgeries before even thinking about attempting a partial nephrectomy. But well, there is always a case that you end up in a problem, you convert into a radical, you convert into an open intraoperatively, postoperative bleeding, requiring radical nephrectomy, etc., etc. They are part of the game in the initial days.
Thank you.
My pleasure.
Thank you, Mallikarjun, Dr. Saib. And because we are running
Sure, please, sir.
slightly late due to technical problem,
Sure.
now Professor Agarwal will invite another speaker.
Thank you, sir. Thank you for the
Thank you, sir. Now we invite for a Malaysian Urological Association lecture that is on how prevent is prostate cancer in Asia, identifying the data in Malaysia. I request Ong Tang Ek to deliver this prestigious lecture.
Hello, I am Dr. Teng Ek Ong, the current president of the Malaysian Urological Association. Hello, I am Dr. Teng Ek Ong, the current president of the Malaysian Urological Association. Today I will present on the topic of how prevalence is prostate cancer in Asia, specifically talking about how we collect data on prostate cancer in Malaysia. Well, then we can share some experience. With that, I would like to thank the Nepal Association of Urological Surgeons for organizing the UROCON and giving us the opportunity to give a lecture. Well, how far is Nepal from Malaysia? So if we drive, it probably take more than 3 days. Yeah, I'm not sure if that route actually exists, for us to drive from Kuala Lumpur to Kathmandu. But anyway, most of us will fly either from Kathmandu to Malaysia or from Malaysia to Kathmandu, and that will take 4.5 hours. That's how far it is. Malaysia is from Nepal. Well, this is a picture taken from the Nepal embassy in Malaysia. So it's a picture showing the ambassador giving the credential to our current king of Malaysia. Of course, if we search the literature, we do have data on prostate cancer in Nepal, and we know that the prevalence is low. Okay, for Malaysia, yep. So the incidence is about 7.7 per 100,000 population based on our latest cancer registry. It ranks number 3 amongst the cancer in males after colorectal and the lung. Well, something remarkable that was being highlighted many times is that a high proportion of patients presents with metastatic disease. So if you look at the yellow bar, 53% of patients were diagnosed as stage 4 when they first presented to the physician. Well, we also have selected survivor data. Prostate cancer but it's not too bad. We know a lot of patients live pretty long. Here is a picture showing the prevalence. Yep, and also the survivor. The survival is quite poor actually for stage 4. So the 5-year survival is only 43%, whereas the survivors are more than 90% in 5 years for the other stages. So if the patient is of stage 4, the 5-year survival is less than 50%. So that's the data we have from Malaysia. Well, those are the officially collected data, basically based on the voluntary basis from all the doctors in the country. Of course, we try to collect prospective data. So we joined the ACAP database, which was anchored by Professor Hideyuki Akaza of the University of Tokyo. So there is ACAP, which consists of more than 10 Asian countries, and everybody sit together and work out a formula to collect data prospectively on the incidence and prevalence of prostate cancer in their respective country. So for Malaysia, it is MCAP, yeah, M for Malaysia. So we from the University of Malaya, where I work, so we gather experts around the country. This is a picture taken in 2016. So we gather all the head of divisions of urology in the whole country of Malaysia. So we sit together and get everybody to cooperate to provide data for the MCAP database. So beside that, we also pay a lot of in-person visit at that time. That was pre-COVID time. We were able to fly to various hospitals and clinics and to encourage their participation in the MCAP database. So with that effort, we actually managed to capture 90% of the hospital under the public service for 3 years. We managed to gather the prospective data on the prostate cancer, yeah, for all the hospital under the public sector. So this is a list of all the hospital involved. Well, this is the ethnic profile. As we can see, 45% of the patients are Chinese, followed by the Malay of 38%, and the other ethnic group. The age of diagnosis, the mean age is 69 years old, almost 70 years old. And we can see here again, yep, consistent with the official National Cancer Registry. Well, more than half of the patients will have metastatic disease when they first presented to the doctors. So there's something that we need to take note of, and something of concern, of which the health authority and various patient advocates would like to see this figure being reduced. Okay, here is a chart showing the pattern of the initial treatment for prostate cancer. Of course, stage 1, actually a significant portion of the patient will go for active surveillance, yep, for surgery. And for stage 3 disease, locally therapy would be the mainstay of treatment for metastatic disease. And there are various degree of acceptance of additional therapy like chemotherapy or abiraterone, enzalutamide, or the other new androgen pathway inhibitors. Well, based on this latest MCAP database we have, 25% of the patient had developed CRPC. Up to now, yeah, we have follow up to 2021, and the mean time to the development of mCRPC for patients who have metastatic hormone-sensitive prostate cancer to start with, the mean time is about 10 months. So it is pretty short, yeah. So on 2 of them would have passed away due to prostate cancer. Okay, so this is from a mean follow-up of 23 months. So of course, this high proportion of metastatic disease has generated a lot of interest and concern. So there are advocates group who come to us, come to the health authority, and want to push for more prostate cancer awareness. Yep. So one key opinion leader in Malaysia have pushed for a campaign last year, #OnlyManCan campaign 2020, and have went on media blast. Yep. So they also organize a public awareness national TV show. Yep, I was there in the picture as well. And of course, we gather doctor from various discipline, yeah, urologists, oncologists, primary care physician, and also physician, so they can be prepared, yeah, to look after patient with a high PSA and to advise patient which aim to reduce the proportion of patient with metastatic disease. We have a awareness campaign that we want to do this every year. We will start with a GP educational module soon after the middle of this year, and potentially on more widespread use of PSA testing in high-risk patient. So in summary, there is a high percentage of prostate cancer patient who presented with stage 4 disease. That's a fact. So there is an ongoing awareness campaign. Yep. Hopefully we can detect the disease earlier. And the role of screening, of course, yeah, it is still yet to be determined in Malaysia and in the world, of course. Yep. I think the current trend is to focus on specific screening for a selected group of high-risk patients. So with that, I'd like to thank NAUS again, and also thank my association, the Malaysian Urological Association, for this opportunity to collaborate with our Nepalese colleague. So we wish UROCON all the best. Thank you very much.
I think the next speaker is Christopher Chappell. He's from United Kingdom. It is 3 o'clock in the morning. Probably he's not online. So I would like to start his pre-recorded video where he's talking about the recent update in surgery for urethral stricture. Christopher Chappell from United Kingdom.
Dear Dr. Chalice and colleagues at the Nepal Urology Association, thank you very much indeed for giving me the opportunity to present to you at your meeting. It's a great honor for me to be able to do that. Without more ado, I will come on to my presentation. I bring you greetings, first of all, from your colleagues at the European Association of Urology. And here you can see my colleagues on the executive sending their greetings. Our association has a simple aim. It's to act as a representative body of European urology and to facilitate the continued development of urology and all of its subspecialties, and by fostering the highest standards of urology and education to benefit our patients. We have over 18,000 members worldwide, and we provide support across all of the super-specialty areas of urology. And you can see we've got 14 sections. We have the most up-to-date practice guidelines in the world, and here you can see the latest update from 2021. We have it translated into more than 30 languages and 74 endorsements from national associations. We have an extensive publication portfolio. You can see here European Urology, the highest ranked journal in the field of urology, and a portfolio of other journals. 3 of them you see here. We also provide online education, and all of this is stored on our UROSource platform. We provide our uro-oncology meetings. And of course, don't forget our annual meeting. I hope you'll join us this year at our virtual meeting in July. I do hope that you will think about joining the European Association of Urology, and you can access us on all of the standard media. The surgical treatment of urethral strictures. I have no disclosures relating to this. It's first important to define what we're talking about. We first have sphincter stenosis, commonly seen now following prostatectomy for both benign and malignant disease. And of course, here you've got no bladder neck mechanism, so continence is dependent on the integrity of the distal sphincter. It is not, so it's best just to dilate the stricture and then keep it open by self-dilatation. Of course, we also have disruption injuries where there's no absolute loss of urethra and where an anastomotic procedure can be used in the majority of cases. And if you look at this, you can see, of course, on the left-hand side, a fall stride injury, on the right, a pelvic fracture, urethral distraction injury. So with a short stricture, of course, you can tell which is the blood supplied area by the color of the mucosa. If it's a bit ischemic, you can see it's gray. So this is best, in my view, done at the time of surgery. And this area of ischemic spongiofibrosis. We must also bear in mind the anatomy of the urethra, whereas if you're going from the bulbar urethra, just here, backwards, up into the bladder, you can see here the sphincteric area, very little corpus spongiosum. As one advances down the urethra, though, you can see here ventrally, very thick corpus spongiosum in the bulbar urethra, and in the penile urethra, very thin. You can see it shown here on a urethrogram endoscopically, but in this case, you can see quite a good flow rate. So until the caliber of the urethra is down to 11 French or less, you won't see a reduction in flow. And that was described by Joe Smith in the mid-60s from London. And this may be useful in assessing a patient's response to treatment. Of course, optical urethrotomy or dilatation, which are equivalent, which we now know from a previous randomized study, can be used as first line, and the success rate for short bulbar stricture is around 50%. Repeated urethrotomies or dilatation only improve the situation by 10 to 20%, and in the longer term may not be successful and may just lengthen. Preliminary evidence suggesting that there may be a good benefit from this, and you can see here from a meta-analysis, but there are no randomized studies. But you can see there is some favor in view of mitomycin from these studies with review of the evidence. The urethra at the site of the stricture, and then also releases paclitaxel, an agent akin to mitomycin in terms of inhibiting fibroblasts and scarring. It's positive, but we await the publication of the latest data from North America, although preliminary view of this suggests excellent outcomes. So this may certainly be a way forward, this approach to lessen fibrosis after dilatation or urethrotomy. The next out of the whole literature, which were adequate for assessment, all based on animal work and no translation into the human at this stage. So coming on to the surgical management of patients, I think it's very important to use transillumination of the urethra. You can see the distal end of the stricture. And I always find that passing a guide wire is enormously beneficial. Subsequently, when you do the urethroplasty, to actually be able to find the lumen easily by cutting onto the guide wire. And you can see by placing a suture at the distal end of the stricture, you avoid having to open up the urethra unnecessarily or at the wrong place, because you can then, obviously, if you open it too widely, commute a possible anastomotic urethroplasty into a substitution. Successfully, indeed, you can also cut out the area of stenosis, leaving behind the overlying covering of the urethra and anastomose it successfully. What about longer strictures? Well, of course, an augmentation or substitution may prove necessary. And in that context, the question again is where to incise the urethra. I personally don't like going ventrally because of damage to blood supply and prefer to go laterally or dorsally. Of course, one can use flaps, but as Dubey showed from a randomized study from India, the morbidity is far higher because of having to close the penile shaft where the skin has been harvested from. Of course, oral mucosa, whether from the tongue area, you can see there, from the lip or from the cheek, can be used, most commonly from the cheek for the majority of patients. A company from Germany has followed that work and developed a artificial graft with end tissue. What about the hyperspadiac deformity where there's been previous surgery? Again, another surgical challenge, often lengthy stenoses, so there's an anatomical problem, there's a functional problem because of the stricture, and often, in addition to the cosmetic issues, there's psychological factors for these patients. The anatomy, as in the male, is dorsal or ventral. A recent publication from our group in European Urology emphasizes we should get the terminology right. I personally feel that if one's operating on the female urethra, one can use two particular approaches. One is the jackknife position, where you can see putting the patient in this position is very effective at looking at the anterior wall of the vagina, and here you can see the urethral diverticulum. Don't forget and don't damage the nerves. It's a very effective way of getting access to the anterior part, in other words, the dorsal part of the urethra. And you can see that access, and the Parkes anal retractor is an excellent vaginal retractor. Here you can see, as I showed earlier, the Turner-Warwick retractor, which is a modified pediatric retractor, the Dennis Brown, with knobs on, which allows you to put stay stitches on. And you can see that shown operatively here. So, in vascularized tissue, filling dead space and draining and defunctioning, and be aware of the surgical options. There's no single operation. Remember, every operation is a take it to bits before you put it together. So please do join us at our virtual congress between the 9th and 12th of July. Unfortunately, we're not able to hold it physically this year in Milan, which we were hoping to do. I wish you all the success for your meeting and look forward to you joining us at ours. All very best wishes to you, and I hope to meet up with you soon.
Thank you, Christopher. Now we proceed with another lecture, UA lecture on Peyronie's disease by Frazin Solomon Jate from Iran, is it?
Hello, good morning, dear colleagues in Nepal. I'm Dr. Fazin Soleimanzadeh, reconstructive urologist from Iran, Tabriz, the secretary of Asian Pacific Society of Andrologic and Reconstructive Urology Surgeons. Thanks to UAA for providing this opportunity for me, and thanks to Apsaros, and also my dear colleagues, Professor Agrawal, Professor Pawan, and Professor Adhikari. I'm going to talk about Peyronie's disease in patients without refractory erectile dysfunction who need surgical treatment. First, I'm going to refer to this nice recent publication by Eric Chung and colleagues who have tried to merge clinical guidelines on Peyronie's disease to give a pathway for the management of Peyronie's disease. Interestingly, they have provided a flow chart. As you see here on the left side, they have discussed patients in acute phase of Peyronie's disease, which is characterized by penile pain, duration less than 6 months, and evolving curvature, which is not going to be discussed here in this talk. But on the right side also, we have a population of patients with different conditions. I am going to focus on the patients who have good erectile function, but with different degrees of curvature and deformities who need surgical treatment. So This is the map of where and which population we're going to talk. Due to Peyronie's disease and somewhere in the shaft of the penis. The next photo, you see angulation more than 60 degrees, and finally you see hinge effect, which is characterized by ability of bending on the arrow point. Maximal angulation point in erection phase. Are plenty of different techniques with rather minor differences with each other. The most famous of them maybe is Nesbit technique, depicted here by EAU publication very nicely. You see that this contains a removal of a special part of tunica albuginea and the repair of the area, which results in a correction of the angulation. The other equivalents are also available. For example, in left bottom, you can see the techniques known mainly as Heineke-Mikulicz technique, which is used in different types of reconstruction techniques and can alleviate some kinds of angulations. And the right side, you see the technique known as 16-dot technique, which does not contain incision or excision of a part on tunica albuginea, but rather is a simple plication regarding the severity of the angulation. What I usually do is pinching the tunica albuginea using Alice clamps and do a repeat erection to find out whether the correction is quite sufficient. Here you see that we have elevated the neurovascular bundle, the dorsal aspect, and the correction is, seems good. Or non-autologous, different types of graft material. Garcia Gomez, Ralph, and other colleagues have evaluated 69 papers showing results of different types of grafts and flaps, and finally they found that it's not possible to draw any definitive conclusion whether any of these material in the long term are superior to the others. So more homogeneous prospective studies are necessary to be buccal mucosa graft, both of which are autologous grafts. This is not costly and usually easy to harvest, especially buccal mucosa is quite easy to harvest for a reconstructive urologist. Depending on the situation, on the width of the area you are going to replace the tissue, you can use any of these techniques. The incision here is rather unusual, and it is because of the special shape of the plaque in this patient. It's not normally seen like this in an L-shaped incision, but in this case, we had to choose a special incision. Sometimes, based on the condition and the shape of the defect, you have to choose and adjust your incision and the area of grafting. A collagen fleece may be somehow superior to pericardium or SIS material, which are two of the most frequently used material as graft in Peyronie's disease patients. One superiority can be seen in this photo published in another publication by the same author. You see that a tecocele is being replaced here, but not necessarily sutured delicately edge to edge. I mean, it's just covered, and it does not necessarily need fixation by suturing. And it can be a superiority to SIS, which is necessarily expected to be circumferentially sutured in a watertight manner. So the operation time can be reduced, and it can potentially result in better results in terms of post-operative infection. But in my two last slides, I will mention that non-surgical treatments are potentially able to affect the indications of surgical treatments in the future. Intralesional injection of collagen Clostridium histolyticum was approved about 8 years ago, and in the first years there appeared to be a kind of very huge plenty of hope that this therapeutic option can replace many of the treatments currently done for patients. But as you see here in this publication, the curvature improvement is expected to be only about 30% on average, and many of these patients still will need surgical intervention. So there is a room for searching for other non-surgical treatment options, which in a better understanding of the results and long-term usages, they can alter our understanding about which patient needs surgical treatment. So therapies with collagenase Clostridium histolyticum injection and long-term results, and considering a rather high cost of this treatment, which restricts its availability in all countries with all economical conditions. The second option is stem cell-based treatments, which is still a young option. Current condition is not even clearly defined whether it is effective or not. There are some promising results, but it's not clear. But in the future, they may alter some of the indications of surgical intervention, especially in this population of normal erectile function patients. And at the end, vacuum devices and our better understanding on vacuum device can change the indications and the patients needing surgical treatment in Peyronie's disease. Thank you again for your attention.
Thank you, Rajin, for your excellent lecture. Now we go on to Dr. James Thompson, Yusan's lecture, Advances in Multiparametric MRI and Biopsy for Prostate Cancer Diagnosis. Thank you.
James Thompson, urologist from Sydney, Australia, and it's my great pleasure to be invited to present to you on behalf of the Urological Society of Australia and New Zealand on the evidence for MRI in prostate cancer. So let's get into it. Well, first of all, what are the problems in prostate cancer? The first problem is that prostate cancer is asymptomatic until it's incurable. In other words, the first symptoms that one has are usually when it's already spread to the bone or caused locally advanced T4 obstruction and is thus incurable. The best threshold, such as 3 to 4, only around 30% or less of patients will have prostate cancer. So if we biopsy everyone with a PSA of 3 to 4 or above, at least 2/3 to 3/4 of biopsies are unnecessary because those patients don't have cancer. Until recently, we've had no reliable imaging tool. Ultrasound and CT cannot detect prostate cancer reliably. Therefore, biopsy has involved random sampling, where we put needles into various areas of the prostate and hope that by chance we hit the cancer, if it's there at all. This can often lead to false negative biopsies where the cancer is missed. It consists of 3 scans: a T2 weighted scan, which shows up as a dark signal here in areas of tumor, like in this axial image on the right side posteriorly of the prostate. The DWI, or diffusion weighted imaging, which looks at water movement within the prostate. And again, because water movement is restricted in areas of high cellularity, such as high-grade cancer, and where there's disruption of the normal interstitial tissue membranes, the area will show up as a dark spot on the ADC map, as a red spot. So, how do we use MRI? Well, here's a nice example of an anterior tumor at the front of the prostate, which would have been missed by biopsy. But we used a study where we enrolled 400 men in Australia, all men who were undergoing a biopsy for abnormal PSA or DRE. We performed a multiparametric MRI, had an expert prostate MRI radiologist look at the scan and give it a score from 1 to 5 using the PIRADS, PIR-ADS scoring system. We were able to then perform a transperineal saturation prostate biopsy with around 30 cores on average, including targeted biopsies of any MRI suspicious lesions. And what we found was quite revolutionary for us, which is that if the score was 1 to 2 on the MRI, we did not need to perform a biopsy. And if we did that, we had a 95% negative predictive value and a 50% positive predictive value for PIRADS 3 to 5. Around 1/3 of men who did not have cancer could avoid an unnecessary biopsy. And we reduced over-detection of insignificant low-grade tumours by 1/3. If the PIVE, there was a 95% or more chance, almost 100% of cancer. 100 men, almost identical results, with a 90% negative predictive value and 50% positive predictive value of MRI for significant cancer. They also showed that the standard 12-core transrectal biopsy had poor sensitivity and accuracy. They followed up with another study, the Precision study. Now, this is a randomized trial published in the New England Journal of Medicine a couple of years ago. This showed in 500 men that if you randomize them to MRI as opposed to 12-core biopsy, that those in the MRI arm had a better chance of detecting cancer, 38% versus 26% in the control arm. There was less over-detection of insignificant cancers, and around 30% avoided biopsy altogether. Helped with a decision tool to apply these trials to decide who should have a biopsy. In this nomogram that we created, we found that if you put together all of the variables, age, PSA, prostate volume, family history, DRE examination, previous biopsy history, and MRI score 1 to 5, we could predict with 90% accuracy whether the patient would or would not have cancer. So a patient who, in this example, has a score of 210 points would have an 80% risk and clearly needs a biopsy. Whereas likewise, if the risk was less than 10%, we would advise against a biopsy. This has been externally validated extensively around the world, this calculator. We went both transperineal saturation template biopsy and a targeted biopsy we're using MR ultrasound fusion. And we found that using the targeted biopsy alone was not enough. The template biopsy detected an additional 9% of clinically significant cancers. So that was 49% versus 40%. We thought that that's enough that we should not avoid template biopsy, and that's still our practice. In the picture trial, they found identical findings, 49% for combined template plus targeted biopsy versus 40% detection of significant cancer for targeted alone. It's a small improvement, but it's important. We don't want to miss those 9% of significant cancers. Another trial by Radke et al. Out of Germany showed the same thing, better cancer with detection with the combined approach. And all studies showed that you detect more insignificant cancers, unfortunately, with the combined approach. And that's the trade-off. Biopsy, because we know a transrectal biopsy is a less sensitive reference test, so you're going to miss more cancers. So, just in giving your best guess of where to go on the ultrasound, fusion, where you use software to combine the two images, or using in-bore or in-gantry biopsy, which is where you actually take the patient into the MRI machine and perform the biopsy within the MRI machine with real-time MRI guidance. Well, the basic answer to that question is they're all the same on an all-comers basis. There's no difference. This was best demonstrated by the FUTURE trial published recently in European Urology. It was a randomized trial of more than 600 men who all underwent targeted biopsy via any of the three techniques, and there was no difference in the detection rate for significant cancer. Now, a recent meta-analysis found the same thing, and basically the only difference is that some studies who have looked into this in more detail have shown that in a smaller MRI lesion or a lesion in a difficult to access location or in a very big prostate, that there probably is an advantage of using either a fusion, which is probably the most pragmatic approach, the most practical, or if possible, an in gantry, in MRI bore biopsy does have a better chance than cognitive, just for those difficult lesions, the ones that are more at risk of being missed by a cognitive approach. But it's not routinely necessary. The other point is for a difficult target, another study showed that increasing the number of cores with cognitive biopsy will improve the detection rate. So at least 4 to 5 cores is necessary. Just the harms from overtreatment. But there are a couple of problems. What if the biopsy misses an evasive tumor? What about the frequent biopsies needed every year or 2 or 3? And patient anxiety about missing the cancer and missing the window of curability. So MRI, we published the MARIAS trial last year in Journal of Urology, showing that MRI has a 90% chance of being able to rule out significant cancer in the surveillance setting. And that was also supported by the ASSIST trial by Klotz and colleagues, who found that the MRI arm had a better detection rate of significant cancer and less risk of later progression. So MRI is now standard of care in active surveillance, certainly in Australia. You can see here in the image, PSMA PET lights up using a gallium-68 bound to a PSMA molecule on the surface of prostate cells. And this basically, in our study, which we're about to release the results, shows that in those small number of men where the MRI misses the cancer, or in some of those false positives on MRI, the PSMA is usually able to set us in the right direction. So the combination of MRI and PSMA looks to be even more accurate than MRI alone, and I think will become the standard of care in future. Finally, artificial intelligence. We're in collaboration with centers in the US, looking at deep learning computer methods to do voxel and pixel-based analysis and compare serial MRIs over time to pick up subtle changes. As you can see in this image here, we're teaching the computer where the tumor is based on the radical prostatectomy specimen and comparing that to the various diffusion and T2 weighted images, so the computer can learn how to spot cancer by itself. And finally, there are novel parameters being used, such as kurtosis, which improves grading of tumor on MRI, and also fractional diffusion scans such as the verdict, which is a type of scan incorporating more complex physics of diffusion to give us more accurate information. And here's a standard diffusion scan showing a vague fuzzy nodule in this area where the arrow points on a standard diffusion. And here's the vertic scan, which lights up nicely, showing us that high-grade tumor. So that's all from me. Thanks again for inviting us, and happy to take any questions. Thank you.
You are muted, Dr. Prem.
Sorry. Here, the next lecture will be the from Sri Lanka Association of Urological Surgeons lecture. Dr. Balagobi will talk about the oligometastatic renal cancer. Metastasectomy, is it standard? Dr. Balagobi.
Hello, welcome to Slav's lecture on oligometastatic renal cancer. Metastasectomy, is it a standard? I'm Dr. Balagobi, Senior Lecturer and Consultant Urological Surgeon attached to the Department of Surgery, University of Jaffna, Sri Lanka. We know that metastatic RCC is quite common. Roughly around 40% of cancer workload in renal cancer, it's metastatic RCC. Oligometastasis is defined as less than 5 metastases according to the ESMO. According to the NCCN, that says limited mets. Clinician point of view, they say either single mets or multi-mets. Oligometastasis can occur synchronously with the primary tumor or maybe a metachronous tumor. Treatment of oligometastatic RCC is challenging and depending on multiple factors. This population-based analysis indicates the lungs, bone, and lymph node and liver are the common metastatic site from the renal cancer population. Because younger population have proportionally more multi-metastatic sites. If the performance score is poor, then we have to treat with other treatment modalities like conventional radiotherapy, hyperfractionated radiotherapy, stereotactic radiotherapy, or stereotactic radiosurgery, or cyberknife treatment. The problem with the local treatments are they have more chance of recurrence, and the overall survival is, when compared to the complete surgical resection, is poor. When we are, if you want to get a cure. As we all know that if organ confined renal cancer, radical surgery is a curation. But when the patient comes with a diffuse metastasis, the medical management is the answer. When the patient have oligometastasis, surgery of both primary and mets plays a vital role with the adjuvant, targeted, or immunotherapy. And more combination therapies are coming to the treatment modality. So metastatic cancer survival is increasing. This Canadian analysis indicates the 5-year overall survival is better with the metastasectomy rather than non-surgical management. Metastasis rather than non-surgical management. Of metastasis rather than incomplete resection, overall survival is far better. So overall survival in complete resection is range from 36.5 months to 142 months, but in incomplete resection, 8.4 months to 27 months. They also discovered even there is a multiple meds or non-solitary meds, if we can go for a complete surgical resection, overall survival is better. And lung-only metastases perform benefited better than the other sites metastases, rather than the non-surgical group. Well, in metastatectomy group rather than the non-surgical group. And overall survival is better even for multiple metastases patient, where we can go for a complete resection. It can be synchronous, it can be a metachronous. Both group, there is a beneficial. So cancer-specific survival is better in surgical resected group, and overall survival is better with this complete surgical resection group. And lung-only meds perform better than the other metastatic group, the no resection in case of oligometastatic renal cancer. So the goal should be the complete resection of both primary tumor and all metastatic tumors. Less number of metastases, less organs are involved, and absence of lymph node meds. And lung meds are better than the bone meds, and bone meds are better than the visceral organ meds, and visceral organ meds are better than the brain meds. And metachronous lesions are better than the synchronous lesion. Obviously, if we can go for a complete resection, that's favorable than the incomplete resection. Also, tumor biology plays a role. Low-grade tumor and absence of sarcomatoid changes and clear cell histology are the favorable factor. Peripheral meds are better than the central meds. So there are organ-specific factors also plays a role in deciding the prognosis. We discuss in the multidisciplinary team, and then the decision should be taken. But the problem is most of the evidence are retrospective evidence and done for a solitary lesion rather than the multiple metastases. And most of the meds resected were lung-only meds. And these findings were published in the era of pre-immunotherapy or combination therapy era. And there are selection bias because healthier patients are selected for surgery. So obviously the overall survival will be better. So we need a better randomized controlled trial to come to this conclusion. By doing a complete metastatectomy in metastatic RCC. If the patient have a solitary meds or oligomeds, where the lesion, both primary and secondary, should be completely resectable. Then go for a surgery, and we may have to give a medical treatment either before or after. We don't know exclusively when to give. So if a patient performance score is good, primary tumor is resectable, meds are resectable, then we have to go for a surgery, completely resect the both primary and metastasis. In conclusion, surgical metastatectomy more likely to increase overall survival in well-selected patients. Ideal patients are fit patient with small volume metastasis with the favorable tumor biology. Decision making is challenging. We need more evidence in the era of advanced medical treatment for metastatic RCC. Thank you.
Now we are towards the end, and the final lecture is by Gibbus Society. Gibbus lecture, that is on diagnosing interstitial cystitis and bladder pain syndrome. Please start the recorded video.
Good morning, everybody. Thank you very much, Dr. Pawan Chalise and the Nepal Association of Urological Surgeons, to have given me this opportunity to speak about the diagnosis of interstitial cystitis or bladder pain syndrome. I bring with me greetings from the capital of country, New Delhi, and this is the hospital where I work, Apollo Hospital, New Delhi. That yes, there are so many terminologies. There is interstitial cystitis, bladder pain syndrome. We are sticking on to the bladder pain syndrome and the interstitial cystitis because as of now, it is difficult to clinically differentiate between these two. Before we say how to diagnose bladder pain syndrome or interstitial cystitis, we should know what we are looking for. So this is what we are looking for. Pain or discomfort in lower abdomen and or urogenital area of more than 3 months duration, which is worst on full bladder, along with one or more urinary tract irritative symptoms like frequency, urgency, and nocturia, with or without standard stigmata on cystoscopy, provided another discernible pathology which is likely to cause these symptoms has been excluded. So the pain can come from any of these dermatomes coming from or the nerve supplies from the suprapubic to inner thigh to the posterior thigh, and of course this is the area, but many people would also call it pain around anus or burning sensation around anus, which is again typically we have seen which is associated with bladder pain syndrome. Then we should ask, are there any aggravating or relieving factors? When is the pain maximum in relation to micturition cycle? Is there any relationship with menstrual cycle? Is there dyspareunia, whether it is superficial or deep? Is there a relationship with ejaculation or a relationship with posture? So most of the time patients come to us and they say there is a burning sensation. So if it is in the lower abdomen, perineum, vulva, and rectum, then of course we are looking at something which is closer to bladder pain syndrome. Is it occurring all the time or is it related to the micturition cycle? Unless it is related to the micturition cycle, I would not be keen to call this as coming from the urinary tract. But there are exceptions, of course. So pain is worse just before passing urine. Pain is worse. That means it is originating from the bladder, and perhaps it is related to the filling of bladder. And as soon as the bladder is being empty, the patient feels some relief in pain. If there is no pain till the patient starts passing urine, then it is perhaps urethritis. And then if there is pain which starts towards the end of urination and persists for some time, then in a woman, we would think perhaps there is excoriation around the urethral meatus in the vaginal wall. It could be simply senile vaginitis or senile urethritis. But of course, one should not forget stone stuck in terminal ureter or uretrovesical junction or submucosal ureter can also give rise to pain, which tends to persist for some time after passage of urine. But of course, that's not going to stay for 3 months by and large. Coming to dyspareunia, it could be superficial or deep. Superficial dyspareunia is usually due to a mucosal lesion around the vaginal introitus, and the deep one is related to inflammation either in the bladder, posterior wall of the bladder, or the uterus or internal genitalia of the female. So when we come to the differential diagnosis, the closest is, of course, overactive bladder. But if you see that overactive bladder very rarely has bladder pain. Both have urgency, frequency, nocturia. And of course, there could be a fear of incontinence. So if I have to differentiate, ask this question to the patient. If you have a desire to pass urine and there is no facility available, will you have pain or will you be scared of a leak? If the patient says that she has a scare of leak, then perhaps we are dealing with something like overactive bladder. And if it is pain that is causing that she's scared of, then of course we are looking at a bladder pain syndrome. And another leading question is that when you wake up from sleep to pass urine, is it the full bladder sensation or is it the pain that wakes you up? So if the patient says, no, I don't have pain, I just wake up because my bladder is full and is troubling me, so that's good enough, I go and pass urine, but there's certainly no pain. So obviously this is an overactive bladder. And if the patient wakes up with pain, then perhaps it's bladder pain syndrome. And many of these patients will tell you that they're scared to go off to sleep because if they go off to sleep, if they fall asleep, their bladder feels beyond a particular sensation and they wake up with excruciating pain in the pelvis and they have to rush to the washroom to pass urine. And of course, we have a horde of the confusable disorders, which we need to exclude on the basis of history. And of course, an examination, if there are scars of the previous surgery, if the scars are bad on the skin and the parietes, of course, there could be scars intrapelvic. That means there could be a scarring of the bladder along with other organs, and that can mimic something like a pain which varies with micturition cycle. And one should be careful for such patients. And of course, local examination becomes imperative, like we go for an examination as an MD gynae or a student is taught, we must see, we must feel, we must examine all the steps of the pelvic examination as in female and in male. Any areas of perineal tenderness have to be seen. We have to make a note of the tone of the pelvic floor. If there are any trigger points, we need to assess that. And any myofascial bands must be looked for because they are once you have seen one myofascial band, you can never miss it. But you must see first one before you can be confident of picking them up. A focused neurological examination must be done in case you feel that there's a need or there's a history which points towards that. Coming to a word about pelvic floor spasm, it could be secondary or it could be primary. It can be secondary to the pain itself, or it is the primary cause of pain, then sometimes it may be difficult to differentiate between the two. But of course, if there is a history that the pain increases with change in posture, then perhaps it is primarily coming from the lower back pathology causing spasm in the perineal muscles. Differentiating from chronic prostatitis could be difficult, but I can tell you that if the pain starts at the beginning of the urination and stays for some time, it is likely to be chronic prostatitis. And on examination, suprapubic tenderness is more commonly seen in a bladder pain syndrome, and a DRE may show a tender prostate in a male in such a patient. And if there is still some doubt, we can instill intravesical lignocaine. If it takes away pain instantly, then perhaps the pain is coming from the bladder. The test that I would recommend is, of course, there is no doubt that we have to have a clinical history, physical examination, frequency volume chart, ultrasonography, and urine analysis. These are must. If there are leukocyte esterase, nitrates, and pus cells in the urine, we are looking at an infective cystitis, even if the urine culture is sterile, because presence of any of these means there is infection. Ultrasonography, because we remain in an area which has endemic stone disease, and of course we have a high incidence of tuberculosis, so ultrasonography should be mandatory in our subgroup of patients. Cystoscopy, again, we must have an opportunity to look and exclude serious diseases, and bladder biopsy has to be taken. Unless if there are any of the signs of infection on routine analysis, culture can be done. Or if there is a reason, we can do a cytology. Symptom scorings and quality of life scoring should be done, especially if you are doing an academic exercise. Urodynamics is rarely indicated in bladder pain syndrome. So cystoscopy is not essential for diagnosis of ICBPS. In clinically diagnosed case, it may be just normal, and it should not be preferably performed under local anesthesia. It is painful to give more pain to the patient who's already suffering from bladder pain. And one need to look into a patient as because sometimes the bladder may seem normal to begin with, but if you look for a longer period, you may find some stigmata there. And it gives an opportunity to do hydrodistension under anesthesia. And if you find Hunner's lesion, you can ablate them. This is a typical Hunner's lesion that I brought. So it is a pale interior with radiating capillaries, parallel capillaries radiating. And rest of the bladder, if you notice, appear to be reasonably normal. So there is a localized area, and this is an early Hunner's lesion that you can see. And when you distend them, they can just crack and cause raining of blood. So this is what is called raining of blood. And here is a small video, if the time permits, that there are multiple Hunner's lesions. And these lesions, you can see rest of the bladder is normal, and they appear to be, sometimes they can be connected with fine strands, sometimes they can be kissing lesions, one over the other, and you can see that on distension, they become more pale and they just crack down. The Hunner's lesion is getting cracked, and when you decompress the bladder, there is raining of blood. Note that the bleeding occurs only from this area. Rest of the bladder is not bleeding. So this is very important when you're doing a cystoscopy. There's a localized area which is bleeding. There are two Hunner's lesions here. They were kissing lesions in this case. It is largely a clinical diagnosis. Spend time while talking to the patient, and that is the key. And usually it is the patient who spells the diagnosis. Thank you very much for your kind attention. If there are any questions, I'll be very happy to answer. Thank you.
Thank you, Dr. Taneja. Now this international lecture series is over. Back to the conveners.
Good morning, everyone. Welcome to today's next session of guest lecture session. Without further ado, we just start because we are late on schedule. So for the next guest lecture sessions, we would like to invite Professor Dr. Uttam Kumar Sharma to the dais, please. Dr. Mahesh Bahadur Adhikari and Professor Dr. Bhairav Kumar K. Amal is probably will be on virtual live. So we hand over the mic to the chairpersons for the.
Very good morning. Now we are going to start the next session, guest lecture. This is, I'm going to invite Arun Chawla from India. He's talking on non-transecting urethroplasty. Very difficult subjects, very fascinating subjects. He's going to talk on these topics shortly.
Good morning, everybody. Greetings from Manipur, India. Thanks to NOS for giving me the opportunity to be part of this program. I'll be talking about non-transecting urethroplasty in bulbar urethral stricture. Transecting urethroplasty involves the division of whole of urethra along with the corpus spongiosum, and these are usually accompanied with end-to-end anastomosis. In non-transecting urethroplasty, the corpus spongiosum is not removed or partially removed. Corpus spongiosum should not be considered as a mere tube for the transit of urine in the semen. It is a very important vascular and neuronal structure which takes important role in the erectile function of the individual. And the strictures are the scar or fibrosis in the urethral mucosa involving a part or whole of the corpus spongiosum. The non-traumatic urethral strictures are the one where the urethroplasty can be performed by non-transecting techniques. It was in year 2005 when Professor Santosi presented a result in AUA meeting and compared the results between the transecting and the non-transecting techniques. The differences were quite obvious. The superior success rate was observed in the only urethroplasty, which is a sort of non-transecting urethroplasty, and there was no incident of sexual dysfunction as compared to the urethroplasty with the transecting techniques. Tony Mundy in year 2011 presented his initial report on a non-transecting anastomotic bulbar urethroplasty. After initial imaging by ASU and MCU, he described the technique as the patient being placed in social orthotomy under anesthesia, and doing a perioperative urethoscopy to assess the urethral characteristics, placing the guide wire, complete bulbar urethral mobilization, and a dorsal incision at 12 o'clock over the catheter up to the stricture, extending the ureterotomy, and then making an intraoperative assessment. The complete assessment is made about the location of the stricture, the length of the stricture, and the degree of spongiofibrosis. And either of the 4 options of non-transecting urethroplasty surgeon, the strictureplasty or the Mikulicz procedure, the non-transecting anastomotic bulbar urethroplasty, the augmented one, and just the placement of the onlay graft at the dorsal position. The Mikulicz urethroplasty is usually for the stricture less than 5 millimeter, and where the dorsal incision is closed by transverse closure. While the stricture varying between 1 to 2 centimeter, it is the dorsal incision and the intraoperative assessment, the assessment of the spongiofibrosis, and this spongiofibrosis is removed partially with the reconstruction of the ventral spongiosum by interrupted sutures, and the dorsal ureterotomy is then closed by transferally placed interrupted sutures. The augmented non-transecting anastomotic urethroplasty is like a previous technique. However, the dorsal ureterotomy is usually longer in these strictures, and it cannot be closed transversely. In this dorsal longitudinal ureterotomy at 12 o'clock is augmented by placement of graft at the dorsal position. In the onlay, purely onlay techniques, which is usually for a long non-obliterative strictures, it is the placement of the dorsal graft after dorsal longitudinal and assessment of the strictures. In his initial series of 65 patients, he reported a very low incidence, 6.5% incidence of erectile dysfunction, and he concluded that there's no need to excise whole of the corpus spongiosum. In usually non-traumatic strictures, the corpus spongiosum is involved in 10 to 30% of its thickness, and there's absolutely no need to excise the healthy corpus spongiosum, which usually preserves the retrograde blood flow and may be important in elderly men with vascular diseases, with previous urethroplasties, and may be needed for the sphincter placement in future, maybe after radical prostatectomy with incontinence. Non-transecting reported varying types of erectile and ejaculatory dysfunction, cold glands, the soft glands, the decreased gland sensitivity, the erectile dysfunction in transecting technique as compared to the non-transecting techniques. Length of 1.6 centimeter of bulbar urethral strictures. The success rate in terms of flow rates were almost similar in both the techniques. However, it was the incidence of sexual dysfunction which was glaring. 14.3% incidence of sexual dysfunction in transecting technique as compared to just 4.3% of sexual function in the non-transecting techniques. Listing the video clips of the various type of non-transecting anastomotic urethroplasties. This urethoscopy showing a nearly operative strictures, the bulbar urethral mobilization and incision at 12 o'clock position, the extending the ureterotomy into the normal urethra, assessment of the strictures, and this longitudinal ureterotomy, which is placed at 12 o'clock, is then closed by placement of interrupted sutures. This is akin to the Mikulicz procedure, which is done in various gastrointestinal surgeries. This definition: longitudinal ureterotomy and the excision of the partial spongiofibrosis. And after the excision of the partial spongiofibrosis or the narrowed part of the urethral stricture, the ventral corpus spongiosum is closed by placement of interrupted sutures. The dorsal longitudinal ureterotomy is then closed transversely by the placement of interrupted sutures. Wound is then closed primarily without the placement of the tray. The procedure is same as in the second case. with the mobilization of bulbar urethra, assessment of the stricture limits, the excision of the corpus spongiosum in its narrowed part or the obliterative part, the reconstruction of this corpus spongiosum by the placement of interpret suture. However, in this case, the dorsal thoracotomy being long cannot be closed transversely, and this is usually completed by the placement of graft at the dorsal position, at your clock position, and this is called augmented non-transecting anastomotic urethroplasty. Or the sharp membrane stricture, which fails on VIU, initial VIU, and the stricture varying between the length of 1 to 2 centimeter. It is the dorsal thoracotomy with the excision of scar and ventral spongioplasty, followed by horizontal closure or the transverse closure of the dorsal thoracotomy. In stricture which are long, more than 2 centimeter, it is the dorsal thoracotomy, assessment of the stricture, followed by augmented non-transecting anastomotic urethroplasty, or just the placement of graft on the dorsal. To conclude, non-transecting techniques give the similar success rate as compared to transecting techniques, with the preservation of better sexual function and increased satisfaction rates. Thank you very much.
Arun Chawla. So we are already behind the time, so we'd like to proceed to another speaker. Laparoscopic urology is starting in Nepal, and then looks like there's a new milestone by laparoscopic surgery, laparoscopic cystectomy. Dr. Paras Manish Resta.
With three window technique. As we know, almond as radical cystectomy is a treatment of choice in high risk, recurrent, and some of the superficial and invasive bladder cancer. Now, with the growing technology, laparoscopic radical cystectomy is an attractive, minimally invasive alternative to the conventional open technique, which is equally good with the outcome and with a short hospital stay and decreased blood loss. First, LRC was carried out in 1993, and we are going to discuss a simple technique described by Dr. Sopan Sood from Patel Hospital, Jalandhar. This particular video was carried out in a patient, 55 years of male, with TURBT histopath T2A disease, high-grade disease. Patient position exaggerated Trendelberg, 5-port, as in all pelvic surgeries we do. And they are basically, we have to know that we have to control two major vessels, superior and inferior vesical arteries, which is the branch of internal iliac artery. And so basically we have to know these three avascular zones and three windows on the east side. First avascular zone is posterior avascular zone, posterior to the inferior vesical pedicle, middle avascular zone between inferior and superior vesical pedicle, and anterior avascular zone, which is actually the space of Regius, which is anterior to the superior vesical pedicle. So we have to know these three windows. As you can see, superior inferior vesical arteries on the two sides and three windows. So the first step is to dissect the anterior to the ureter, and finding the vas crossing the ureter. Dissection is posterior to the vas and medial to the ureter to develop the posterior surface of inferior pedicle. Step 2 would be dissection of the ureter and dissection lateral to the ureter and develop and divide inferior vesical pedicle after the levator ani. And the step 3 is the dissection of window 3, anterior vascular zone, which is lateral to the medial umbilical ligament and medial to the vas, dividing the ureter and dividing the superior vesical pedicle up to the levator ani. So first step is to dissect the window 1. So you're dissecting the ureter in the pelvis, anterior to the ureter, as well as basically to the medial to the ureter. In this case, you can see a lot of adhesions on the right side. So we're dissecting medial to the ureter, and whatever comes posterior to it, we we dissect out and we carry out the same step on the other side, medial to the ureter. And when we go deep posterior to the ureter, medial and posterior to the ureter, we can find the posterior vesical artery, which you can clip, or as these vessels are not so big, you can even use a shearing device like ligashore or Olympus device. So these can easily control the vessel. And if you go on further, then we join these two areas and we dissect posterior to the bladder in front of rectum. As you can see, two sides there. They are the levator ani on the both sides. And we dissect up to the seminal vesicle. This is how we complete the window 1. And now we dissect lateral to the medial umbilical ligament. So this is quite a vascular area, creating window 1, that is space of Riccius. So this is window 3, basically window 3. We go deep up to the pelvic fascia, reaching the levator ani. So once we leave at ani, you don't have to go further deep. So these are the tissues in between window 1 and window 3 and window 2. So this is how it looks if you dissect on the both sides of window 3. And we can start with division of ureter and control of the superior vesical arteries. These arteries may be controlled with the clips as well as a shearing vessel device. So whatever comes in front of or lateral to the ureter, we can just use a vessel seal device and control the arteries. And now comes a part where we can start from the urachus, bringing down the bladder anteriorly and creating the space of Riccius, dissection completing down to the dorsal venous plexus. And these plexus can be controlled with the suture as conventionally, but we can also control with some patients with a shearing device like Thunderbeat. Here we use Thunderbeat, and also ligashore can control this. And once you have control of the vessel, dorsal venous plexus, we can divide the urethra anteriorly. And this is how we complete the cystectomy picture. We can put the catheter through the urethra, which can use as a drain, and whatever hanging tissue at the back, and the specimen is out of the picture. This is how it looks at the end of cystectomy completion. Now comes the part of pelvic node dissection. So while doing pelvic node dissection, we just completely negate out the iliac vessels, vein as well as artery, and also going down up to the internal ring. This is obturator nerve, making completely naked. This is how it looks at the end of the pelvic node dissection, and that comes the part where we retract the specimen. First, the lymph nodes in different bags, and we can mark it with different staplers so that we don't get confused. And this is after the completion, taking out the specimen, reconstruction iliac conduit. This is a final look of the incision, and these are the specimen. This is the patient's first post-op-day happy face, and the histopath comes out to be T3B with 7 nodes positive out of 18 dissected. So conclusion is laparoscopic radical cystectomy seems to be very complex surgery for most of us, because it can be easily executed by this 3-window technique, which can be carried out by the neurosurgeons. We are beginners, but with some upper tract experience and understand pelvic anatomy, we can easily execute this procedure. Thank you.
Thank you, Professor Paras Manishrestha, for elaborating the laparoscopic radical cystectomy. So I would like to invite now next speaker. So one of our chairperson, whether he has got anything to say about this thing, Bhairav Kumar Homa, if he's online, please.
Thank you very much for asking. And I'm unable to attend physically for an obvious reason, but I have full faith on my co-chairpersons. And it's very delighting to listen to the very experienced urologist. I think some of these topics can be adopted in our setting right away. And probably even robotic thing can also be started in the country after we have an approach to the robotic uro arm. Thank you very much. Please carry on comfortably. I am happy to be spectator from a distance. Thank you.
Okay, thank you very much, sir. So without delay, I would like to invite Himesh Gandhi from India. He's talking on robotic kidney recipient surgery, the new way forward in the existing situation.
I'm Dr. Himesh Gandhi from Ruby Hall Clinic, Pune. I am a robotic uro-oncologist and a transplant surgeon. And today I will be discussing about robotic assisted kidney recipient transplant surgery, the new way forward. I sincerely thank all the office bearers of UROCON 2021. And without wasting much time, I start with my presentation. I come from a place called Pune. I work in Ruby Hall Clinic. Pune is 180 kilometers from Mumbai. And this is our center. I have non-disclosures. So for perioperative complications, the transplant recipients normally should be provided with the benefit of minimal invasive surgery. As we see with the history of transplant, it started in 1954 with the open surgery. However, it was open surgery in certain risk population is associated with the more majority of surgical site infections, and those recipients mainly with obesity, diabetes, critical illness, and immunosuppressions have a higher risk. Laparoscopy never became popular due to technical difficulties. However, robotic transplant started first in 2002, and initially it was the corporeal robotic transplant with regional hypothermia. So who are the ideal patients with robotic kidney transplant? So the ideal patients with robotic kidney transplants are mainly with a higher BMI, young patient who wants improved cosmesis, and those patients should be highly motivated patients with accepting all the complications and the risk of open conversion. What are the contraindications for a robotic transplant? There are, actually speaking, none, but some are. Some like significant atherosclerotic disease becomes more of a relative contraindication. Patients with previous major abdominal surgeries also become relative contraindications. And when we are contemplating simultaneously or dual organ transplant, it is a relative contraindication. Multiple techniques have been described, multiple port placement and incisions prostatectomy. So to start the discussion, we start with the lab donor nephrectomy, and we retrieve the kidney from the phalansteal incision of the donor. And once the kidney is retrieved, we do a bench dissection where we properly skeletonize the vessels and defect the kidney. And then we put the kidney into a gauze jacket, which is filled with slush of ice. Some people tend to put the ureter during this, degestant in the ureter during this step, but we hardly do it. This is how the gauze jacket is prepared, and the vessels are pulled out of the hole, and the kidney is packed with ice slush and placed for delivery inside the recipient. Some modified tumi syringes are in still area, and this is the docking of the robot between the legs of the patient. The tender number, what we normally put is around 15 to 20 degrees. The instruments are same as what we use for a robotic radical prostatectomy, except this black diamond needle holder, which we use specifically for the transplant surgery. And we prefer to use Gore-Tex 60 and 70 sutures for the anastomosis. So this is the gel point port being prepared, kidney being placed inside the body of the recipient, and then the gel point port is closed and the surgery is commenced. So this is a brief video which I would like to show. So first, this is the positioning of the robot and how it is done. This is the phenyl incision with the gel point port for delivery of the kidney and the ice flush. And the step begins with a bladder drop. So this is the bladder drop, and this same incision we carry it down and skeletonize the vessel and take it retroperitoneal. So the kidney will lie in this fossa. So once this is done, we start skeletonizing the external iliac artery and the external iliac vein. So here the important point is that we just need to skeletonize 3 to 4 centimeters of the vessels. We don't need to completely defat the vessels, and this avoids the post-operative lymphoria. So once this is done, we try to prepare a ureteroneocystostomy site on the partially distended bladder, and we would like to do this step at this moment so that once the kidney is placed, we don't have to go searching for the site. And once this is site is done, we just tag the site with a suture so that after the kidney is in position, this identification becomes easy for the ureteric reimplantation. So this is how it is tagged. Now the kidney is dropped through the phenyl incision gel point port, and we start clamping the vein. So vein is clamped distally first and then proximally. Then we use the cold scissors to cut and do a venotomy in the external iliac vein, and then hemosis of the main renal vein with the external iliac vein in an end-to-side fashion using Gore-Tex 60. So this is a 2-suture technique where we use one suture for the posterior wall and another suture for the anterior wall. In between, we can use a ureteric catheter to flush the lumen and check the patency of the lumen. So once the posterior wall is done, this is the anterior wall, which we are doing again with a separate suture. The length of this suture is around 6 to 8 inches. So the handling becomes easy, and we start closing the anterior wall. So once the anastomosis is done of the vein, we close the main renal vein, and then we declamp the external iliac vein. So this is this allows and shows us whether there is any leak or around the anastomosis. Once this is done, we come to the artery and we clamp the external iliac artery. First on the proximal side and then on the distal side. Then we use a cold shears and just do a small arteriotomy. But this is so this arteriotomy, once it is done, we use a robotic aortic punch. This is a 3 mm size punch, and we create a proper hole for the anastomosis of the artery. So this anastomosis is done, and this anastomosis is started on the posterior wall first using a Gore-Tex 60 suture. And then once the posterior wall is finished, we start with the anterior wall and the anastomosis is completed. So this is the second suture, 2-suture technique, what we are using for the anterior wall. And again, the anastomosis is started and it is almost completed. In between, HEPA flush is used. So once the anastomosis is completed, we clamp the main renal artery and remove the clamps to seek for to look for any arterial bleeding. Once it is confirmed that there is no bleeding, we are ready to perfuse the kidney, and then we can first we remove the jacket of the kidney, and then we come for ureteric reimplantation. Here you can clearly notice the nice spot of urine coming from the ureter, and the ureteric reimplantation is started. And this is the tunneling of the ureter. So this Leach-Greger technique, what we use, and we use a 40 barb sutures for anastomosis. So once this is done, we use a intracorporeal Doppler ultrasound probe and look for the RI. So RI in this case was done, and this is the skin incision and the scar what the patient gets. So the cosmesis wise also, from open surgery, now the robotic surgery cosmesis is many times much better. The important thing is to be avoided is that the arterial anastomosis should be at 90 degrees rather than an acute angle to avoid restenosis and thrombosis risk. So the robotic surgery definitely gives us a better cosmetic results, lower complication risk, lower post-operative pain, and early hospital discharge. However, it is a bit costly and ischemia time is a bit longer than that of open surgery. There are multiple studies showing comparison between robotic and open surgery. The results of the graft function in both the series is same, with lower post-operative complications and improved patient comfort. Similarly, a meta-analysis is also done, which shows that the graft function is similar with a lower risk of surgical site infection in robotic group. Long-term studies of 10 years is also available and clearly shows that there is no difference between the function and functional difference between the graft function of the robotic and the open group. And it definitely at 10 years also, the robotic kidney transplant had a good, excellent graft function rate with the minimal complications. So take-home message is that the robotic assisted organ transplant is an advanced application of the technique. We ourselves did at least 200 cases of conventional uro-oncology robotically, and then we venture into the transplant. So a certain level of expertise is definitely required, and more transplants you do, the warm ischemia time is bound to get lesser and lesser as compared to the open surgery. However, more prospective data is required to finalize the real benefits of robot-assisted kidney transplant surgeries. By this, I would like to end my presentation. Thank you.
Thank you, Dr. Himes, for such a nice presentation, nice demonstration how the newer technology, robotics has made our life easier and easier to the patient, easier to the surgeons also. I don't know how easier to the surgeons, but it is easier and good for the patient. So is there any questions from the floor? I think he's on live now in line. Questions, then I would like to conclude the today's sessions on this morning sessions. Thank you very much for all the participants for participating in this conference. Thank you very much.
Thank you. Thank you very much, everybody.
Good morning, everyone. So as we are already short of time, I would like to commence the next session. As conveyors, Dr. Anil Shrestha and myself, Dr. Atul Kasaju, would like to welcome you to the Stone session. We have a distinguished list of chairpersons and very well-renowned speakers, both national and international, for this part. We have got two thematic halves to this session. The first half will be dealt on PCNL, and the second half will be on flexible ureteroscopy and lasers. So for the first part, as chairpersons, I would like to welcome on the dais Professor Dr. Parasmani Shrestha and Dr. Sanjay Kharki, who are in person for this session. And also on Zoom Live, we have Dr. Madhusudan Agarwal. So please take the dais. So I would like to request the chairpersons to now take over the session.
Well, friends.
Good morning, Dr. Madhu. This is Sanjay.
Yeah. Good morning, Sanjay and Dr. Shresth. It is a pleasure to be part of this meeting, and I welcome you to please carry on with the session.
Welcome all to this Stone session. So we have a first speaker, Professor Madhu Agarwal. He is one of the world famous in PCNL, and he does not need any introduction in our urology society. So I request Professor Madhu to talk on how additional suction is changing the way percutaneous surgery works.
Greetings. My friend Dr. Janak Desai has tried to show that suction is not required in stone management, but I'm going to tell you how it is the reality in today's time, and it's going to stay. This is the new normal. See, in the past, things keep changing and things keep evolving. We cannot remain stuck to the past.
there was a time when we were doing open surgeries for stone. And there was a time when we were doing big 30 French PCNLs for the stone. And we were removing large stack-on stones using 30 French sheets and even larger sheets. But we have realized that intrarenal pressure in today's time makes a difference. There have been a number of studies demonstrating the importance of the pressure within the kidney during PCNL. And suction works for the new procedure, that is the mini PCNL, as well as for standard PCNL. And I'll show you how. Nagele, who's done seminal work on mini PCNL, used suction even through a ureteric catheter in his earlier publications on mini, what he called MIP-XS. We in India did a lot of original seminal work on using suction in mini PCNL, and our colleague Dr. Kaushik Shah developed this Shah sheath, and this was our first publication on this subject. And you can see this design, how efficiently this suction works, that irrigation goes through one channel and suction comes out through another channel, keeping the intrarenal pressure low. And you can see that even when the sheath is almost vertical, how efficiently the stone fragments can be pulled out using the suction, in addition to the standard Hoover effect or the water jet effect. So the suction adds to the vacuum cleaner effect by actually offering a vacuum cleaner in addition to the water jet. At the same time, when we were doing the Shah sheath in India, our friend in China, Dr. Zheng, developed a similar technique called what he called super mini perc or SMP, which is very similar to the technique that we have been using in India. But the principle is the same, that using suction keeps the intrarenal pressure down. And this is the SMP, which is being used extensively in the world now as the Clearpetra sheath. And all over Europe now, Clearpetra sheath is becoming more and more popular. And there have been many studies, and this is a very recent study where there has been detailed work on intrarenal pressure. And the conclusion is that the vacuum in the Clearpetra sheath keeps the intrarenal pressure down and prevents many complications and increases the safety of the mini PCNL procedure. So suction offers multiple advantages, gives a clear field, reduces fragmentation times, reduces operating time. No grasping devices are required for retrieval of stone fragments because everything, the dust, the fragments, they clear out spontaneously. The stone migration, retropulsion, is reduced significantly, resulting in improved stone-free rates, reducing reoperation rates, and keeping the intrarenal pressure low. The complication rate is much less. Coming to the larger stones, the use of trilogy, which uses suction, it has been clearly demonstrated, reduces the operating time and improves the efficacy. The large bore of the trilogy helps in sucking out the water and the stone fragments, and now trilogy is becoming increasingly popular internationally. There is ample evidence and in the literature as well showing the efficacy of the suction in intracorporeal lithotripsy in addition to the standard pneumatic approach. And similar device is the shock pulse from Olympus, which also combines the pneumatic and ultrasonic device with suction, which improves the efficacy of stone fragmentation and retrieval, and has a very short clip again showing you how you can very efficiently fragment and as well as clear up the stone by in large volume stones by using suction. So there is no reason to dispute the efficacy of suction in intracorporeal lithotripsy because it only adds to your comfort. It reduces the need for retrieval of stone using graspers, and it cleans up the field, leaving a very clean and dust-free, fragment-free, improving stone-free rates in the end. Now, people have gone a step further and started using suction even in flexible ureteroscopy, and studies have started coming showing improved stone-free rates and lower incidence of infectious complications with use of suction sheath in flexible ureteroscopy. And these, my friends, are very recent reports demonstrating improvement in results and safety parameters with the use of suction in endourological procedures. And this is a very recent report from Current Urology, and this is actually still in print, going to be published in 2 months' time, where it's an overview of recent publications showing that in PCNL, suction is a definite advantage, and it's going to stay in coming times.
Madhu, thank you very much. It's a nice presentation. Maybe I can ask the audience if they have any questions regarding the suction device. Okay. Madhu, I have one question to you.
Yeah.
How much energy required to suck these stones? Do you have any particular pressure to suck these stones?
See, people have measured pressures, but I think you have to just balance the inflow and the outflow in a way that it allows the clear field and does not collapse the pelvic ileal system. Because in the beginning, it actually takes a little bit of experience and practice. Because if the suction is too strong, it will cause collapse of the pelvic ileal system, which should not be allowed. So you have to maintain that balance, and you have to have a suction mechanism where you can control the pressure. We have not actually done much work on measuring the suction pressures, but there have been studies where they've put irrigation pressure at 200 centimeters of water and irrigation and suction at 100 centimeters of water. So I'm not too sure about the actual exact figures, but the basic principle is to keep the intrarenal pressures low, but not too low.
Okay, as you mentioned that you have to control yourself, the pressure, but is there any connection to control this pressure in your device?
Yeah, I think most suction devices have the controls. They allow you to increase or decrease the suction pressure.
Okay, thank you very much.
Thank you once again, Professor Madhu. Now, I would like to call upon our next speaker. We all know him very well. He is our new honorary member of NAUS, Dr. Ravindra Sabnis, currently Chairman and HOD of Department of Urology in MPUS Nadiad. He's a president in West Zone USI and president-elect of USI. So he is mentor for everybody, including me. I would consider him as my teacher. And a lot of young urologists should follow his work. Especially, I would like to mention his new book. I think it's the second edition, if I'm not wrong. It's called Urology Instrumentation, a Comprehensive Guide. I urge all the young urologists to get this book. You can also get it in Amazon. I just checked it. Without delay, then I would like to ask Dr. Rabindra to present his presentation. Thank you.
I would like to thank the organizers of NOWS for giving me this opportunity to be the part of this annual conference, UROCON 2021. Well, I have established an excellent rapport with almost every member of NOWS, and therefore for me, it's a special privilege, and I consider this as my home conference. Well, I'm going to talk today about the instruments for PCNL and RIRS. Well, when we talk of instrument for PCNL, it can be divided broadly into 4 categories: the conventional or large size instrument, the smaller than that, the slender with the big accessories. Third category is mini perk, and the smaller than that mini perk is the extra small instrument. So I will describe these instruments into these 4 categories because they are from the practical utility point of view. When we consider the large size PCNL instruments, the first thing that comes into our mind is the STARS 24 or 26 size sheath and the nephroscope. This is an instrument which is extremely popular, which has been used for decades since the time the PCNL started. But the biggest disadvantage of this design is that this nephroscope cannot be used in isolation without sheath. And therefore, on this instrument, nephroscope, you have to put this 24 or 26 size sheath, then only it becomes complete. And then correspondingly, bigger implants has to be used. Whereas the nephroscope, which is manufactured by Wolf, the design is such that the nephroscope itself becomes the independent unit. And therefore, if you put a irrigation from here, you don't have to actually use the sheath which they provide, which again can be 24 or 27 size sheath. It can be used in the still smaller implants because it is a single unit which is independent. That's a basic design between these two. Otherwise, both of them have a very large channel size, and you can use this with the shock pulse, triology, lithoclast, lithovac, everything you can use it. Big size forceps can be used, triflange, biflange, and that's a conventional PCNL. Well, the smaller instrument than that is now can be categorized as slender instruments, and 2 instruments come in our mind and which are being popular, which is very widely used, is a Wolf Dresden model, which is the 18 French here as shown, very ergonomic design, 10 French channel size, so all adult accessories can be put, and it can be used either in the 12, 20 French or any other implant bigger than that. Now, STARS now has come out with MIP series. The bigger one is the MIP-L. So this is the MIP-L nephroscope, which is 19.5 French size. The channel size is 12 French. So any adult accessories can be inserted. And the beauty is that any implants which is bigger than the 2022 can be used with this. STARS, of course, gives its own sheath also. That also can be used, and adult size accessories can be used. The next one is the mini perk, which is a very, very common instrument nowadays. It's a most popular instrument. The manufactured by STARS, Wolf, Olympus, almost all are 12 French size with a 6 French channel, and you can use small shock pulse, small triology, small lithoclast, everything can be used. And laser, of course, is the most common material used for the disintegration of stone through mini perk. So there is no difference, almost all are same. Now STARS has come out with the sheets which are quite popular. Now for mini perk, it is 16 French, 17.5 and 22 outer diameter sheet. Of course, Wolf also can be used with this same sheet. But Wolf does not give a separate sheet. Any implants can be used, which again is available from 16 French, any size. The STARS has 15 centimeter 2 sizes. Now, if you see here, this is 15, this is 18. It is longer is used for the supine PCNL, where it tends to be a longer track, and therefore there is a longer design. Previously, the nephroscope sheets were having irrigation channel. Over a period of time, it is you realize that this is of no use, and therefore newer instruments are without channel. So this is a Storz typical sheets. The smaller instruments than that, there are many PCNL procedures which are described by different names. The commonest is UMP, ultra mini perk, which again has a telescope, which is a 3 French size, a rigid telescope, nephroscope, which is 7.5, and telescope is inserted to a nephroscope, and the whole assembly then is inserted into 13 French size amplats, which is a specific for the UMP. You see here the irrigation channel through which the saline is to be injected, and it comes out with the from the tip like this. The idea is to create a whirlpool effect, and the fragments are to be sucked out or have to come out from the sheath. The disadvantage is that 3 French is a very, very delicate instrument, wear and tear is more, and therefore over a period of time, the popularity of this instrument has gone down. And why it has gone down? Because the better instrument has have come, and this is much better variety. That's a Storz MIP access system. This is a nephroscope of a 7.5 French. The beauty is that in spite of 7.5, it has got 2 separate channels, 3 French and 2 French. The one is for the irrigation and one is for the instrument. So the benefit is that when you put an instrument, the irrigation does not go down, which is a problem with all smaller instruments. And this is the advantage in that. Again, it is available in 2 sizes sheath. You can have the 12 French diameter sheath or a 9.5. So that becomes a too small, very, very small, again 15 and 18 centimeter size. So overall, this becomes a very, very sturdy instrument. If you have to really do a very, very extra small sheath, then you have a 9.5 sheath through which nephroscope can be passed, laser can be used, and that is how the pediatric or the MIP access can be done. The next design is with the suction. This is the nephroscope sheath. It varies from 10 French to 24 French, called as Super Perk sheath, manufactured by Indian Dr. Kaushik Shah. And it has got its own dilator. Any nephroscope can be inserted, whichever you want to use it as per the size of the sheath. Now, similar to that is the Chinese variety, which is Super Mini Perk, which is very commonly nomenclature SMT. And the sheath available is 10 to 14 French. It provides its own nephroscope, which can be inserted. The disadvantage is that both this system in principle are same. It has got a suction at the right angle. It has got a suction which is oblique, which ergonomically they claim to be a better for the sucking the fragment. But the disadvantage is that both systems, because of the suction, are the closed system, and it has got its own disadvantage. So this is the Super Perk sheath. Next is the Micro Perk, which is again a completely different variety of instrument. It has got 16 gauge sheath, which is a 4.85 French size. Then it has got a telescope, which is a flexible telescope, which is again a 0.9 mm irrigation channel for the pressure irrigation, and 200 micron fiber can be inserted. So in the small 16 gauge needle, everything is inserted. It is a completely different procedure itself, as it's a one-step procedure, meaning thereby you just put a nephroscope, puncture the axis with this sheath, no guide wire, no dilatation, you just put a telescope and start breaking the stone. Now, when you have all this variety, how to make a choice? If you want to buy, which one to buy? Now, that becomes a very critical question. And I'll just give you a brief idea as to how to make a choice. Conventional PCNL nowadays, it is going down because you need to have much bigger size implants, which is not required. And therefore, even when you are doing stagon stone or bulky stones, the slender instruments are far better. I would prefer Dresden simply because it is ergonomically much better. Holding is proper, much cheaper in variety, and far better vision. And it can be used with any implants. In Mini Perk, you have Storz, Bull, Olympus. Actually, there is nothing much to suggest. Whichever you want to make a choice, you can use it. Sheath, again, you can use Super Perk. Those who wish to have the suction, They can use super perk sheath, otherwise MPLATs or the sheath provided by stores is fair enough. If you want to go smaller than that, then you have UMP, you have micro perk, and you have MIP access by stores. And I will definitely advise for the MIP access system simply because it is quite sturdy and wear and tear is much less. Now coming to the flexible ureteroscope, basically there are now two categories, reusable and single use. Now if you see reusable, again there are two categories, the fiber optic, which is FlexX2, and the digital, which is FlexX-C and V2 by Olympus, and P7 fiber optic. Now if you see the differences and the comparison, the fiber optic, the stars, actually the tip is misleading. Now this is what is a misleading nomenclature. You have to see the shaft, because that is what is going to decide which size access sheet you are going to use and how much dilatation is required. In stars, the tip is 7.5, although we call it 7.5, the shaft is 8.4. The Olympus P7 is the thinnest, which has got a shaft of 8 French. The Wolf Viper is 8.8, quite big. Wolf Cobra, which is the only dual channel, which has got 2 channels, but it is a very, very big size ureteroscope. And if you see these two digital, FlexX-C and Olympus V2, both have 8.5, so they are bigger one. But if you see whatever is the size, the channel is same, 3.6 French channel size, and all scopes length is almost the same, that is 67 centimeters length. Now, if you see the single-use instruments, a flexible ureteroscope, which is now becoming more and more popular, and why they are popular? Because they are also in the different types which are available. Boston manufactures LithoView, which has got a shaft of 9.5, duration of 4 hours. Usan will again 9.5. It has got 2 types, 9.5. It will also last only for 4 hours. Yeah, and they have another variety which is 7.5. The hybrid or the Indian manufacturing is the Indovasive, which is multiple use. 2 varieties, 9.5, 7.5. And you see here the use is 21 hours. So it can be used multiple times. All are digital. That's a big, big benefit of single use. And even though the smaller size instrument, it has got a 360.6 French channel. Now, if you see Boston, it comes with its own monitor and its own processor. The Busan and the Biorad has only the processor. You can use your own monitor, which you already have, so you don't have to spend money on that. And when you do RIRS, the whole thing revolves, the choice, how you make a choice revolves around the cost and the durability. Now, if your use is stores FlexX2, reusable, and if your average use is 100 cases with one instrument, then you tend to spend 4,000 rupees per case. Now, if your use is less and less, then you obviously tend to spend more. Olympus being the costly instrument, you spend more. LithoView, the cost is more, but you tend to use 11 because it lasts only for 4 hours. I'm talking of reusing the instrument of the single use. Then you spend 11,000. But in this Biorad scores, because being the 21 hours use, it can be used for several times, and the cost can be as low as 2,000 rupees. So when you are making a choice, I feel the next era is of a single-use ureteroscope, which actually can be used more and more time with the proper precautions and with proper sterilization. So this is in short about the instruments for PCNL RIRS. Thank you very much. At the outset.
Thank you, Dr. Sabnis, for highlighting extensively within a very short period of time about all the gadgets of PCNL and how we should look at it, because different people has a different preferences. I think I would like to open the floor for 1 or 2 questions. Yeah, Dr. Anil.
Thank you, Sabnis sir, for accepting kind invitation. My small question is, the flexible scopes, reusable scopes are changing day by day these days, and good scopes are coming from this part of the world. So what do you think, how in future, what do you think, what are the betterment that we expect in flexible, so-called disposable scopes for in terms of cost and quality?
Okay, I think that's a very nice question, and that's a question which is there in everybody's mind. I think very clearly that the future era is for the disposable scope. Now, disposable, I mean, is not strictly one use and throw away. What we do is that now in our part, as you rightly said, more and more scopes are coming, more and more companies are coming with a hybrid variety, meaning thereby they are of a digital variety, they are of a single use type, but at the same time, they are for the multiple use. So it is not a single use, but it's a limited use nephroscope, which is a hybrid variety. And I think the future is only of that, because you get the digital quality, even if by chance, if you tend to do more and more stones in the lower calyx, even if you are aggressive in PCNL, doesn't matter even if it gets damaged, because strictly speaking, it doesn't cost much. You just have to spend more money on the processor, and then the ureteroscopes are not all that costly. So more and more indications are there, more and more aggressive RIRS can be possible. And therefore, I feel from the durability point of view, from the cost point of view, from the indications point of view, disposable, limited use flexible ureteroscope is the future.
Thank you, Dr. Sabnis. I think we should move on to the next speaker.
Thank you. Thank you.
Well, we have next speaker, Dr. Chandramohan. Well, Dr. Chandramohan is a pioneer in supine PCNL, and he is the master in all. Like, he does RIRS, he does laparoscopic urology. I hope by few months he will come with the robotic surgery. Chandramohan, good morning.
Good morning, sir. Thank you for the opportunity. Very nice to see hybrid conference, state national conference, sir.
Chandramohan, you can start your presentation.
Yes, sir.
Outset, I thank Dr. Anil Shrestha and Nepal Association of Urological Surgeons for giving me this opportunity to talk briefly on supine screen. As you all know,
Zoom go on second.
is not recent. Long back, after that supine PCNL lesson, at the outset, I thank Dr. Anil Shrestha and Nepal Association of Urological Surgeons for giving me this opportunity to talk briefly on supine PCNL. I'll share my screen. As you all know, supine PCNL is not recent. Long back, it was started by Valdivia sir in 1987. We all know him through the Facebook. Now also is active. ECIRS is promoted by Scafon. After that, supine PCNL has come back to its position. This is the basics of supine PCNL, posterior axillary line, which has to be drawn when the arm is not by the side of it, and iliac crest and 12th rib. Depending on the flexion of the opposite leg, straight of the ipsilateral leg, modified Valdivia position, Bart's flank pre-position, Gusti's position, where leg is straight, is done. Basic positioning is you mark a line, iliac crest, posterior axillary line, and then this is important. Once this line is drawn like this, After that, position is kept, tilted the patient that side 45 degrees, and two bolsters are kept, one at below the shoulder only, another at below the gluteus, and then position is ready. Then we can mark the rib like this, and then iliac crest, and then ipsilateral leg, opposite leg normal lithotomy position, ipsilateral leg almost straight with minimal flexion. That finishes the position of the patient, where you can get access to the renal area. You can sit like this and then do the surgery. Regarding the C-arm, any patient, first we keep in 0 degree this way. If it is going in 30 degree cranial, when C-arm is kept, if it is going towards the head end, that means needle is posterior, that means towards the table. If 30 cranial needle moves caudally, then it is anterior. On the other way around, if the C-arm is tilted towards you, like in prone PCNL, if the needle goes up towards the surgeon, that means away from the spine, it is more posterior. If it goes towards the spine, unlike in prone PCNL, it is anterior. This is 0 degree needle position. This is on the stone, it appears, but when we move to 30 degree above, this has gone down needle, that means it is anterior, not good. When it is moved towards you, it has gone too much spinal, that means anterior, it is not good. That means now I am keeping posteriorly, see how it looks like. Still it is on the needle in 0 degree. When you tilt to 30 degree head end, then the needle goes towards the head end. Very simple. If you keep 30 degrees towards you, the needle goes away from the stone. This is the simple slide which tells everything about the puncture. Simple supine PCNL, this is a position of the patient, posterior axillary line, inferior calyx, position like this, needle directed anteriorly, and then guide wire passed, and then the stone is removed. Advantage is gravity, and all the pieces see the track well away from the column, very clearly away from the column and the liver. Different case scenarios, matrix stone video, where you see the same principles. When the needle is kept and contrast is injected, you can take help of the flexible scope and inject the contrast properly in the calyces. See how beautifully the calyceal system is appreciated, and because the suction, it can suck it out. Young child, where RIRS is planned, extravasation has happened, 9 months child, same principle, ultrasound may help. This is published. Horseshoe kidney, people think prone is better, but supine, see how in the lateral angle all the calyces are seen. Under C-arm guidance, same principle, it can be done. Bifid system supracostal, it can be done. Elderly high risk, where patient cannot be tilted and with obesity, 78 years, bilateral stagger, it can be done. Supine PCNL lumbar hernia, again you see here, if you go more posteriorly and tilt the patient opposite side, taking care that the needle is not very simple lower calyceal stone, then stone is removed. Matrix stone in 5-year-old child with PUJ kink, RIRS attempted, failed, then supine PCNL is done in this position and all the stones are cleared. So advantages are, you can use in prone, you can use ureteric catheter, you can use FUS. The contrast installation in desired calyx can be done. Added benefits, safety and stability of the patient, less risk of tract loss, better vision, fragments wash out. So monitor the needle entry. You can clearly see where needle is entering. Right side is wrong, left side is correct. Anesthesia advantage beyond doubt proven that cardiovascular pulmonary management is easy. Central and peripheral nervous system not damaged. Tracheal compression will not happen. Ocular damage will not be there. Thromboembolism risk is less. Inferior cable is better in high risk patient, heart failure, obese like this patient we have done. No patient repositioning is needed. Accessible to the lower calyces is upper pole accessibility from lower calyx is 80% in spone. Upper pole you can easily reach so that supracostal tracts can be avoided. In supine it comes from the side tract, whereas it can prone it comes vertically down. This is the difference. Better stone management, wash out without forceps. If you wash, all the stones will be coming out. Same disadvantage, the water may be less risk of sepsis because all the water will come out. Ergonomical advantage because you can sit and do it. Less risk of colonic injury if you carefully plan posterior axillary line. These are the various CT films where, as you people think that it may be close to colon, we have done CTs around 10-15 patients. It's very away from the colon. Less radiation exposure. And you can do ECIRS and SBS. ECIRS is endoscopic combined intrarenal surgery, SBS. If this is a stone, this is a stone, this is a picture, definitely you need 2-3 punctures in PCNL. Whereas in RIRS, you go inside, the RIRS person will bring the stone like this. The superior calyx is not able to go, then RIR person is giving the stone to the supine PCNL patient. Flexible scope. To remove the stone in parallel calyx also you can do RIRS. This is ECIRS. Complete stone clearance chances will increase. SBS is simultaneous endoscopic bilateral surgery. One side small stone, another side big stone. If you think that the patient is sick enough to have to do the surgery very fast, you can do one RIRS. Once the puncture is done like this, if it is puncture is done, then supine PCNL done. Opposite side you can do the similarly RIRS, no problem. So this right side is RIRS, left side is PCNL. Disadvantages are limited space of renal puncture, upper pole calyx more medial and challenging, more complex dilatation due to high kidney mobility, increased risk of spleen or liver injury if not properly taken care, decreased filling of the collecting system, spinal interposition, X-ray projections, longer tract length. How to overcome these disadvantages? Abdominal compression, through guide wire, ureteral access sheet, smaller ampulla sheet. Hypermobility of the kidney can be solved like this by keeping the hand a few seconds, and then see this is hypermobility. If you put the hand, its hypermobility will go, and you have to do in short dilatations like this, counter abdominal pressure. Less vision, underfilling, you can use the pump from below or above so that the pressure will be compensated. Limited operative field, ECIR is better approachable to the upper calyx. Multiple tracks are also possible in supine PCNL. We can remove the stones. Irrigation pump and additional retrograde irrigation. To conclude, less operative time in supine PCNL, better in multiple lower pole stones, high risk, obese, added advantage of ECIRS. Change is constant, embrace it. Thank you.
Very nice presentation, Chandramohan.
Thank
Maybe
you,
we can take 1 or 2 questions from the floor, if any. Chandramohan.
sir.
Many people have concern about the posterior or anterior calyx.
Sir.
While doing supine PCNL, how much you are worried about posterior anterior calyx?
Sir, definitely, as you many times demonstrate, in the middle calyx, anterior and posterior are widely separated. So when you are going for middle calyx, this point is very important. So in prone PCNL, most of the times we go to posterior. We usually don't go to anterior because it is relatively vertical tract from the back. Whereas in supine, you go into the parenchyma in the lateral angle with a larger length of the tract. In the last minute, you can go to the anterior or posterior. But the principle of puncturing anterior and posterior is same. You have to identify which is anterior and posterior. That's why 2 planes are essential. The calyx which is anterior will be definitely in different position in middle calyx. Whereas inferior calyx, it is tricky. Experience like the people, Subnisar and you, can identify which is more posterior and puncture. Whereas in supine PCNL, it is little difficult. So you have to get little bit of margin, 10 degrees only, to go to the anterior and posterior. Same thing applies to the superior calyx. where anterior posterior may not be there, medial lateral, we try to go lateral. So in supine also, we try to go lateral.
Thank you very much. General consensus is that if you do supine PCNL, you have a very less chance of colonic injuries. Kindly share your experience. Did you have face any colonic injuries in supine PCNL?
Yes, sir. My fifth case, I injured colon. The major mistake I have done is wrong drawing of the posterior axillary line, and I have gone anteriorly. Even though colon is more anterior in supine PCNL, chances will be very high for the juniors. One should be careful because in prone PCNL, rib and paraspinal is fixed. You need not see. Whereas supine, many things are not fixed. Your posterior axillary line is not fixed. Your drawing line is a long line. You can draw anteriorly and safely go anterior. Definitely it will go into colon. So I feel chances of colonic injury is slightly more with after having both surgeries done for few years. I feel that one should be more careful in supine PCNL because if you go anterior, you will definitely go into colon. Whereas in prone, you cannot go that much lateral. Even the junior will try to be medial than too much lateral because it protrudes out. The intestine protrudes out, you will have fear. Whereas in supine, we feel that everything is falling that side. You tend to go anteriorly, you may injure the colon. That is my feeling, but literature says colonic injury is less in supine PCNL. Everything is experience.
Thank you very much, Chandamohan.
Thank you, sir.
Thank you, Dr. Chandamohan. Before we move on to the next speaker, there's a very special guest who would like to join us and greet us to the dais. Welcome, Dr. Oliver Trexler, virtually. Dr. Anil will convey the talk to him.
Professor Trexler, can you hear us?
Yes, Anil. Perfect. And
welcome.
You?
Yes.
Is it okay?
Welcome. Yes, we can hear you.
Excellent.
Thank you. We'll move on to next presentation and we'll continue. Thank you.
So, welcome, Dr. Oliver Trexler, for your gracious presence. Next speaker will be Dr. Dipesh Kumar Gupta. He's Associate Professor in Nepalkal Medical College. He'll be talking on pediatric mini PCNL.
Giving me this opportunity to talk on pediatric PCNL. I'll be talking on how is it different than in adult. So renal stone diseases in children, they are uncommon but poses a clinical management dilemma due to the size of the urinary tract. Different environmental and dietary factors, maybe their anatomic and metabolic abnormalities or infectious diseases may have to be considered whenever we are managing such cases. The majority have high lifetime risk of recurrence. A child may have approximately up to 50% of recurrence according to newer studies. Whenever we talk about the treatment part, open surgery have been there previously, but now coming up is the minimally invasive modalities which have got decreased morbidity and higher stone-free rate even in complex cases. Even if there is reoperation, there is less trauma to the kidney. Previously, the mode of preference, the mode of treatment that was preferred was ESWL, especially in children. And later on, when PCNL was established in 1976, that came up, and when it was introduced in 1985 in pediatric population, it came up very rapidly. And with the introduction of miniaturization of PCNL especially, so that led to quite rapid evolvement of this procedure in pediatric population. Along with that, recent advancements in flexible ureteroscopy that has also been very much applicable in pediatric population. So percutaneous nephrolithotomy established itself as a good mode of treatment for such cases because of good SFR rate and good lower complication rates. So when we talk in pediatric population for such renal stone diseases, so which one is better? So I always say that PCNL exhibits a higher stone-free rate and efficient quotient. However, there are a few concerns like with the size of the instruments or with the energy sources. Is pediatric patient really a mini adult? There have been concerns over blood loss and other complications. So you always have to go for metabolic evaluation, and risk of recurrence has to be explained to the patient. Specific training and education is required. Children are not just small adults. Anatomy and physiology is different. For that purpose, a gentle approach is needed, and miniaturization has helped a lot. When we talk about miniaturization, so mini PCNL is quite popular these days. Along with that, there are other advancements up to micro PCNL, where all-C needle can, with the help of which there is like a use of lesser than 5 French of outer sheath. So such cases have seen significantly lower blood loss with equal SFR rate. What are the peculiarities in technique? So pre-op evaluation basically will be same when we talk about pediatric or adult population. And when we talk about retrograde ureteric catheterization during PCNL technique, you have to choose appropriate size ureteric catheter because of lower size of the ureter size. So 4 French may be appropriate in very preschool children, or even like later on, even adult size like 6 French sized ureteric catheter may be used. So whenever we talk about perioperative positioning, so prone versus supine position, we always know that urologists have been very comfortable with prone position during PCNL. However, supine positioning has got its own advantages, like an easy upper calyceal access through the lower calyceal tract and low incidence of fluid absorption and hypothermia, and easy anesthesia monitoring. So that is also coming up very rapidly. So during puncture, fluoroscopy versus ultrasound guided, whenever we can take the help of ultrasound, that will reduce radiation hazard, especially in pediatric population. That is important to remember. While making tract, the words of caution would be that if there is more, the tract size, if it is more, that will exert more axial force per unit of kidney surface area without an abundant counterforce. That is important. So larger the sheath, the greater the risk for stress and damage. That has to be considered. Tract formation, always like this is the 15 French metallic sheath. I always use this. I'm very fond of this. And stone fragmentation and evacuation, pneumatic versus laser. So in children especially, laser could be quite helpful because of the miniaturization in the technique, and because the pelvis might not be that much relenting for the pneumatic lithotripsy. A few incidences of pelvic injuries have been there because during dealing with the hard stones. So, and the exit strategy remains same. So we can see very small scar with a happy patient. So our experience in more than 1,500 patients, more than that of that. So we have used mini PCNL more often than the standard one. And in our pediatric percutaneous PCNL cases also, we have had a good stone-free rate with minimal complications. So preference of modality, as I already talked, SWL in most pediatric cases would be preferred because of its less invasiveness. However, a few drawbacks are there, like recessions or lower SFR may be achieved. So mini PCNL has its plus points. Percutaneous nephrotomy in children is matter. Actually, whenever we compare preschool children versus older children, so we can see it is as safe and effective in both age group. So it can be considered very well even in very small children. And even for complex renal calculi diseases, even if you require 2 stage or more stage procedures, so such procedure may be quite helpful. So even such mini PCNL may be done in pediatric complex renal calculi cases as also. Why mini? We have seen so many advantages of a standard PCNL. Smaller tract will lead to lesser complications. and there is comparable pain score, SFR, and hospital stay. Miniaturized PCNL is a valuable tool that offers good outcome that we already talked. What we have to know, however, that always smaller is not better. So it does not work always. So you have to choose the case appropriately. In a grossly hydronephrotic case, while you go for a standard PCNL, so however, in most of the cases, miniaturization would help. Choosing the optimal subtract size with an effective fragmentation is the state of the art. Thank you very much.
Thank you, Dr. Dipesh, for your presentation. And without further delay, we would like to move on to the next speaker.
Next speaker is Dr. Bojras.
Respected, am I audible?
Yeah, please.
Okay. No. Respected chairpersons, my gurus on front line, and dear colleagues, a very good morning to you all. I have took this topic for management of complex nephrolithiasis, the practical consideration. I'll be talking more on how to make a decision rather than how to do the operation. Because for having the operation, you need to have the mentorship and some teamwork, team effort. But decision making is very important. If decision making is good, then outcome will be definitely good. Basic objectives of my presentation is that what makes the stone more complicated one, how to investigate them systematically, and how to manage those complex stones and post-op management and follow-up. I'll be more focusing on principal aspect or philosophy on the stone management. Yes, all of us know that stone disease in developed world may be just quality of life threatening, but in our parts, it's life threatening as well. All of us know that all nephrolithiasis are not same, and daily we encounter a variety of complexities like complete stagon or stones in this anomalous kidney or all those things. So this presentation primarily focuses on simplified practical approach to patients presenting with complex nephrolithiasis. How to define complex nephrolithiasis? There is no consensus guidelines. It started in Holmes in 1993, and he has mentioned that the stone may be considered as complex if the size is more than 2.5 centimeter or any anatomical abnormality or solitary kidney, or because of the composition of the stone, it might be cystine or hysterocyte or other one. That has been added by Rashwiller et al. In 2000, that due to the variety of conditions, the stone may be complicated due to its burden and distribution, stone composition, renal function, and associated UTI. On top of that, we can add the transplant kidney or stones in reconstructed systems. These also fall into a complex category. These are the examples of complex nephrolithiasis based on the stone burden and distribution: stagon, diverticular or infundibulary stenosis, congenital or acquired anatomical variations. Stone composition, I have already highlighted that: hysterocyte, matrix, cystine, and bursite. And UTI, especially with the urease splitting organisms like Porteous. And stones in already established CKD is also a complicated one. And chronicity, those stones, they are recurrent, or those who have propensity of recurrence, these are also complicated one. How to investigate? First and foremost is that our approach should be kidney-centric. Can we salvage the kidney or not? How is the renal function? Start with that question, just like sitting in the OPD, send urine routine and RFT, and in selected cases, DTPA or MAC3 you have to send. The reason is that DTPA scan, I am talking that many of the times, preoperatively, you do not do this split function. Later on with hydronephrotic kidney, you do the DTPA, the function may be GFR may be 7 or 10, then lots of buzz from the patient side, you might need to listen. So at the beginning, if there is any doubt that compromised function of the kidney, better to do DTPA scan beforehand, and do it later on also, no problem. But you have the baseline data there. That will speak, not you, on behalf of you. Is there any proteinuria or not, deranged RFT or not? Document that. This is for saving you. Second question is that, how is the stone burden and distribution, or is there any anomaly or not? For that, we have highlighted already that CT KUVs, CT urography or CT 3D reconstruction whatever is possible, you do that. That will give us the idea about stone volume, composition, density, stone to stone density, distance, and then morphometry scores and so forth. Remember that while analyzing the anatomy of the kidney and stones, very, very minute way you need to focus on the anatomy of the minor calyx, major calyx, pelvic calyxal system, everything. Not only that, many of the patients with stone with especially this staghorn calculi or some metabolic abnormality, these patients might have slight rim of nephrocalcinosis on the border area outline in renal parenchyma. You should understand this before. These kidneys are going to be compromised in sooner future. Most important is that this will give us the roadmap to the treatment and status of the contralateral kidney as well. So I have already highlighted that any anomaly or another important thing is that relation of the kidney to the surrounding organs, especially retrorenal colon on the left side or right side, whatever is there, hepatomegaly, splenomegaly, these also matter a lot. What to look for the PCS anatomy, minor calyx, how many calyxes are there? Is there any megacalycosis or not? Fornix, anterior versus posterior calyceal orientation, single versus compound, drainage pattern, everything you have to remember. If you have the idea of the Sampaya grading also, you just have a look there in meticulous way. After minor calyx, you go to the infundibulum that connects the minor calyx to the major calyx. All of us know how is the angle, how is the length, and how is the width, everything you need to have a look. And polarity, if you are going to approach by percutaneous approach, which pole to choose for percutaneous axis, then this will give the idea. Pelvic anatomy also you have to see whether there is single pelvis. Out of the single type 1 and type 2, there are many varieties are there, like box type, cylinder type, linear type, internal pelvis, external pelvis, so many things. Still in endourology, these common principles our professors used to teach us, this also applies in endourology, keep it in mind. Bifid pelvis, of course, whether it is partial bifid or complete bifid or Y type or U type or B type, whatever is there, this you have to see. How many ureters are there, these also you should know, because at times you have duplex system, you are not seeing anything in CT KOB. You go one side and put the ureteric catheter, stone is another system, totally you will be lost. Does patient have UTI or bacteriuria? This also you have to decide beforehand. Urine routine and urine culture are very important, medical, legally, and practically also. Alkaline urine pH above 7, you think of that might be some urea splitting organism, pyuria and bacteriuria, all those things beforehand we have to treat before proceeding for any stone treatment. What is the composition of the stone and what is the recurrence chance or potential to have recurrence also? This also you have to decide beforehand. For that, stone analysis is must in almost all patients. Extensive metabolic evaluation along with qualitative cystine we have to do, because this gives the holistic approach for management of the complicated cases. Keep in mind that stone with propensity for recurrence, already I have highlighted that matrix, histobite, cystine, these help to tailor the individualized therapy for stone management. How to manage the complex nephrolithiasis, the philosophy was long back given by Joe Segura already. Read the stones using the most effective, minimally invasive, and least morbid method. Trifecta of stone management, what is that? Stone clearance, reduced perioperative complications or morbidity, and preservation of the renal function. Along with, we have to minimize the rates of recurrence and infection. This is the philosophy of stone treatment. There is paradigm shifts in management of the nephrolithiasis, even endourologically also. Many of the times, monotherapy has been shifted towards multimodal therapy. And unidirectional therapy, like either you go for RIRS or PCNL, that is antegrade or retrograde. Now combined approach is coming, that is antegrade and retrograde combined. ECIRS is coming, endoscopic combined internal surgery, or sometimes bilateral simultaneous endoscopic surgery is also coming up. And tailored surgical stone management, what is that tailored surgical stone management? A little bit I'll be talking about that, but more than that is that to prevent the recurrence and future damage of the kidney, the concept of metabolic evaluation and treatment accordingly, that is metaphylaxis is also a new term that you need to understand. Tailored or individualized treatment of the nephrolithiasis depends upon the patient factors, stone-related factors, and outcome synthesis. So that based on that, you can tailor the appropriate management options through surgical and technology and expertise. This was given by Hiller and Khurshid Ghani from Michigan. So tailored surgical management, already I have highlighted that patient factors you have there. Age factor, comorbidity, BMI, patient preparedness, all those things. Then outcome is very important. Surgical morbidity, quality of life, cost, efficiency quotient, and then hospital revisit. And what technology you have that you have to tailor. Do you have lasers? Do you have ESWL? Then shockwaves, then lithoclast, and other PCNL, RIRS, ECRS, lab, robot, open, all those armamentarium while managing the complicated one, you should be aware of the things. What is the current surgical management of staghorn calculi? The aim should be 0 residual stones, because any residue will lead to recurrence and progression. Partial one, that is occupying less than 2 calyces and pelvis, below 80%, partial one, then standard PCNL or standard plus mini, or you can go for mini with suction and all those pump mechanisms are there. But by and large, for staghorn calculi, PCNL is the straightforward one. For complete one, multi-track, single or multi-stage PCNL, or combined with ECIRS, or if you do not have those armamentarium or it's not feasible, multiple sessions are going to take. Extended pyelolithotomy or anatrophic pyelolithotomy, these operations are also still viable if you do good surgery. There is no harm in patients, especially in our part of the world. Other management modalities are much simpler, but renal diverticular calculi, RIRS, PCNL, and LAP all are optional. Then UPGO with renal calculi, I think laparoscopy stands first. Then other modalities. Nephrolithiasis in horseshoe kidney, attempt with RIRS, but be ready for PCNL also based on the stone volume or staged RIRS. Nephrolithiasis in pelvic kidney, if the volume is less than RIRS, then if large one, then lap pyelolithotomy is very, very useful adjunct. Or stage RIRS or open pyelolithotomy, also no harm. The nephrolithiasis in crossed pituitary, again, it is RIRS is the choice, then lap assisted PCNL or lap pyelolithotomy. This way I want to summarize the decision-making process. Postoperative management and follow-up is very important. Be vigilant for bleeding, sepsis, and organ injuries. Use USG abdomen or low-dose CT protocol with rigid and stringent annual follow-up is required. Check for stone clearance in 1 to 3 months. Remember that complex renal stones are benign disease with malignant nature of recurrence and progression. This is what I would like to highlight. Renal stone disease itself is benign disease, everybody knows. But recurrence and progression is malignant. Be aware of that. Antibiotic chemoprophylaxis, especially for steroid and matrix stone, 4 to 6 weeks duration, and metaphylaxis, of course, based on the stone analysis and metabolic profile. By this, I would like to come to conclusion that the management of complex renal stones revolves around 4 pillars: defining the extent of the complexity, objective-oriented evaluation, tailored or individualized surgical management, and vigilant post-op management and stringent follow-up with metaphylaxis. Thank you very much.
Thank you very much, Dr. Gosdas, for elaborating on management of complex renal stones. I think due to limited time, we are going to the next session.
Thank you, sir.
Thank you very much.
Thank you all chairpersons and speaker of PCNL session. Now, we are moving to second part of stone session, that is session of flexible uteroscopy and laser. For this session, I would like to call a set of chairpersons. First, I would like to call Professor Jael Baide for chairing this session. And I would also like to call Dr. Ravindra Sabnis from Zoom as a chairperson.
Thank you. I have joined. Thank you.
Thank you, sir. And Professor Prem Gewali to join Dr. Baide in chairing this session. So Dr. Bhatta would like to announce something before starting the session. Sir, please.
Good morning to everyone. Don't forget that now's election 2021-23 is on progress since 10 a.m. Don't forget to cast your votes. I would like to memorize that we have 9 candidates for 2 positions, and we have to choose out of 9, 6 only. Thank you.
Thank you, sir. The session to chairpersons.
Thank you. We are running late by about half an hour. I would like to welcome Sabnis ji to the chair. And we have got very important lecture by Oliver Taxer, keynote presentation on thulium laser. Are you there? Can you hear me, Oliver?
Yes, I can hear you. And you? You can hear me?
You are loud and clear.
Excellent. I'm sorry that. I'm
tell a
sorry that.
short biography about the Oliver Traxler. Dr. Oliver, I'm Prem. Professor Traxler is in the University of Sorbonne, Paris, France. He is director of minimally invasive surgery department of Tenon Hospital, Paris. He is awarded with the Arthur Smith Award in Chicago 2010. He was 36th president of World Congress of Endourology, Paris in 2018. More than 300 publications in PubMed, more than 500 oral presentation. He is mentor, guide of many endourologists across the globe. He had visited Nepal 2 or 3 times. He is a very well-known figure in our setup also. Yes, Professor Oliver Traxler, you can start.
Okay, excellent. Can you see my slides?
Yes, we can.
You can see. Okay, just perfect. Thank you for the invitation. I would like to give a very special thank you to my good friend Anil. I just remember 1 year ago, I was in Kathmandu with Anil, a fantastic, fantastic trip. It's such a pain actually to, due to this pandemic, not being able to be with you, but I'm sure that a good time will come back and that we will meet again. But really thank you to invite me to participate to this excellent meeting. I was also very happy to listen a few minutes ago that Dr. Ravindra Sabnis said that now there's more and more place for aggressive flexible ureteroscopy. I cannot believe that, but just excellent. Okay, so I will just start talking about this new technology, this thulium fiber. You know that it's actually since a few years, and it was mainly due to the Russian and Indian colleagues that we learn about this new technology, the thulium fiber. And this is really actually the new player. And it seems that this new laser will become the new gold standard for endourology, at least for stone treatment. Oops. Okay. Oh, okay. That's my disclosure. Keep in mind that I'm a consultant for IPG Medical, but also for Olympus. And you know that both of them, they are actually producing this thulium fiber technology. Very quickly, because you know this slide, but I always like to remember that holmium and thulium is coming from this Swedish guy. As you know, holmium means Stockholm in Latin word, and thulium means Scandinavia in a Greek word. Something I think we have to be back to some basics, because I think that with holmium YAG, we forget a little bit to talk about the power in watts. Most of the time we are talking in terms of energy in joules and frequency in hertz. But I think it's time now to come back to the basics. When you are talking to engineers specialized in laser technology, they are not talking about energy and frequency. They are talking about power in watts, total power, and energy in joules. And if you know both of them, you can, of course, obtain the frequency. But I must say that in urology, in endourology, most of the people, we are talking about this energy and frequency. And as you know, some companies actually, they are making some information regarding high frequency possibilities. To me, this is a mistake. And especially when we are using now this very high power technology. like holmium, high power, but also thulium fiber, which also high power system because it goes to more than 60 watts actually. So I think that we need to come back to these power and energy settings. And I will explain during my talk. You know the holmium YAG technology. This is actually the gold standard. The initial report was in 1992, so it's more or less 30 years ago. So no need to say that we know this technology. This is the gold standard for urothelial tumor, stones, stenosis, and also for prostate. So as I said just before, in terms of holmium YAG technology, we have the low power system. It's more or less 30, 35 watts, and high power system, 100, 120 watts. But what does it mean? In fact, when you are using high power system, you are using a system with more frequency. As you know, pulse duration or pulse energy is exactly the same. There is no difference. If you would like to use 4 joules per pulse, it's possible with both. The only difference is the possibility to use more frequency when you are using high power system. So in fact, this is not the same, but we can say that when we are using high power system, in fact, we are using system with more frequency, with high frequency possibilities. But of course, the question is, when we do flexible ureteroscopy, do we need high frequency? I don't know if you know this publication. We recently published in the Journal of Endourology with one of my fellow, Dr. Ventimiglia, Eugenio. We did a review of 23 publications, people using low power system, so low frequency, and people using high power system, so high frequency. And we look at the results in these publications. Interesting to see that if you are using low power or high power, there is no difference in terms of complications rate, meaning that it's safe to use low power or high power during flexible ureteroscopy. If you check the stone-free rate, so I mean what you can do, again, no difference. It means that when we are using a low power system with low frequency, you do exactly the same. You cannot do a better job with high power, high frequency system compared to the low power. But then if you look at the operating time, and if you check the data, you can see that using high power, high frequency system, it seems that you are going 2 times faster, because the operating time reported in these publications demonstrates operating times 2 times faster. But if you go in details in these publications, you can see that the stone volume for both, regarding the low power group and the high power group, is 2 times bigger for the publication with low power. It's like this, it's a coincidence. But what does it mean at the end? It means that if the volume is 2 times bigger, it's completely normal that you are going 2 times slowly. So in fact, if you consider at the end the results, it means that using a low power or a high power system during flexible ureteroscopy, you do exactly the same. It means also that high power system is not superior to low power. Both of them are doing exactly the same job. I'm not talking about PCNL. PCNL, it's another story. And high power system is probably gives some advantages if you do PCNL with high power versus low power. But regarding flexible ureteroscopy, it seems there's no benefit today to use high power system. Regarding Moses effect, Moses technology, you know, it's you know the story. Moses technology is a special Moses effect. Moses effect was described in 1989. It was discovered in 1986, but it was initially published in 1989 by Isner. And it's just to describe what happened when you are using a pulsed laser like holmium YAG or thulium YAG, or also thulium fiber, if you are using thulium fiber in the pulsed mode. So this is this bubble of gas, you can see on this video. You know this video. This is just to describe the effect of pulsed laser. MOSIS technology was introduced in 2017 by Lumenis company, as you know. And if you consider the MOSIS technology, it's in fact a special MOSIS effect. It means that the shape of the bubble is a bit different. It's not completely round. It looks a little bit like a funnel, and it's supposed to bring more energy at the surface of the stone for better fragmentation, better dusting. It seems it works in the lab in this way, and there's some publication on that. But in fact, when we move to the clinical data, there's a lot of controversies actually to know if MOSIS technology is really superior to the regular MOSIS effect. Some publications say that there is no statistical significant difference. Some others said there is a statistical significant difference. Recently, Dr. Manoj Manga, that you know very well, he just published the cost effectiveness, and he just said that there is no benefit in terms of cost actually to use the MOSIS technology compared to the regular MOSIS effect, so the regular holmium YAG systems. We also published, coming from the lab, that if you are using the MOSIS technology, this is completely comparable to the long pulse duration mode when you are looking the retropulsion effect. So as you can see, a lot of controversies actually regarding this technology. MOSIS technology 2.0 is just very new. We don't know exactly how it works actually, but it gives the possibility to go to even more frequency, up to 120 Hertz actually. So it means much more frequency. But again, I would say be careful with this high frequency concept, since it could be really dangerous, especially when you treat stones into the ureter. And you know my general message is when you do something into the ureter, even you are using holmium or thulium fiber technology, be careful with high frequency. If you put too much frequency, you have no control about all the pulses, and this is a big risk to damage the ureter and to generate ureteral stenosis. Into the kidney, you can push the frequency to go faster, but into the ureter, be careful. If you're using too much frequency, you have the big risk to damage the ureter. So limitation of holmium YAG, you know about this. The fragments are still too big and it's time consuming. Again, it's very important to know that actually in endourology, we are looking about dust and we really would like to produce very thin dust, because we know that the dust can spontaneously evacuate because it's really light, and it's also possible to aspirate very thin particles. The problem is, what is the definition? What are we looking for? Coming from the lab, and my fellow Dr. Keller, Etienne Keller, nicely demonstrates that if we are able to produce particles less than 250 microns, it's possible to aspirate, but it's also possible to evacuate spontaneously because it's light enough to evacuate. And Etienne published this definition that dust means particles less than 250 microns. So if we consider all of this, what do we need actually? We need new system able to go finer and faster at the same time. It's a problem because if you go finer, you are supposed to spend more time actually. But as an endourologist, that's what we are looking about a new system able to go finer and faster at the same time. In terms of concept, to go finer, actually, we need to use smaller fiber. You can easily understand that if you are using very thin fiber, you will produce very thin particles. But in terms of laser technology, if you're using a fiber smaller and smaller, inside the fiber, in terms of energy, to keep the same energy density, you need to produce very low energy level. Otherwise, the energy density will be too high and you will not produce such small particles. To go faster, you need to compensate, you need to have much more pulses. So if you would like to go at the same time faster, you need to use very high frequency. So if we summarize, that's what we need actually. We need new system able to use smaller fiber together with lower energy to keep the same energy density inside the fiber and able to produce very high frequency just to compensate and to go much faster. If we ask Holmium technology about that, it's impossible. Impossible to use very small fiber, impossible to produce very low energy, and impossible to produce very high frequency. Even the new MOSIS 2.0 is able to go to 120 Hertz. It's still not enough. So now comes the thulium fiber technology that you know very well. So I think there's no need actually to re-describe this technology. You know this very well. It's completely different in terms of technology compared to Holmium. It's still a pulsed laser. It's also possible to use it in continuous mode, but in terms of stone treatment, it's better to use the pulsed mode. In terms of system, there's three machines actually available. This one is the one that you know very well in Asia. That's the UROLASE with the IPG medical. It's not CE mark, so we can, for me, for example, I cannot use it in Europe. In Europe, we use two different machines. This one is the Salty from Olympus. But in fact, it's an IPG machine. You know that Olympus developed this machine together with IPG. So it's exactly it's more or less the same compared to the UROLASE that you know very well. And there is also these European machines actually from Quanta. The name is the Fiberdust. It's also CE mark, and it's very, very comparable, I would say, to the Saltive system. You know the wavelength, no need to come back, you know this perfect. We call it the super pulsed laser, as you know, and it comes from this. When you register with oscilloscope, the shape of the pulse, that's exactly what you can see. I mean something very square, very homogeneous. And this is actually what we are looking in terms of laser technology. We would like to have very, very precise and very homogeneous pulse. So thulium fiber on this aspect is much more superior to Holmium. In terms of pulse energy, it's possible with the thulium fiber to produce very low energy. And you remember that that's what we are looking. We are looking for systems able to produce very, very low energy per pulse. In terms of frequency, repetition rate, thulium fiber also gives the possibility to use very high frequency, up to 2,000 pulses per second. I'm not sure it's something that we will use in clinical practice. It's probably really too much, but at least you can use something like 200 or 300 Hertz. Just a video coming from the lab just to show that when we are using very low energy, 50 millijoules together with high frequency, 1000 Hertz, you see that we are going very faster, much faster and much finer compared to Holmium technology. We can use very small fiber, up to 50 microns. And just remember that in terms of holmium-YAG technology, we're using fiber more or less 200, 270 microns. With thulium fiber, we are able to use small fiber up to 50. It's not available actually, not commercially available. Only the 150 micron is available actually, but the 100 micron will come very soon. And in theory, we are also able to use smaller one up to 50 microns. We recently published data comparing 150 and 270, and we just demonstrate, coming from the lab, of course, that we were able to produce much more dust with the 150 compared to the 270 micron. And just to confirm the concept that if we decrease the size of the fiber, we will decrease the size of the fragments to obtain real dust, exactly what we need to actually. Etienne also did a second beautiful publication to demonstrate that it was possible to dust all type of stones, including calcium oxalate monohydrate. And as you know, it's not so easy when we are using holmium-YAG. So it's also a very good point. We also demonstrate that in the same conditions, thulium fiber actually produced 2 times more dust compared to holmium-YAG. The Russian colleagues demonstrate, they were the first to demonstrate the superiority of thulium fiber in terms of time, much faster and more dust compared to holmium-YAG. So today, coming from the lab, again, I really insist, coming from the lab, we can say that the thulium fiber is superior to holmium. It's going finer and faster at the same time. But now the problem is, of course, to confirm this in our clinical practice. Again, coming from the lab, it's clearly demonstrated that we produce less retropulsion when we are using thulium fiber. And you remember I said that MOSIS technology is comparable to the long pulse mode. But if you compare to thulium fiber is even superior to holmium-YAG. In terms of resistance for the laser fiber, thulium fiber, there's no risk actually to break laser fiber, especially when we are working into the lower part. Less laser fiber burn back. Dr. Bodo Knudsen from the US, he just confirmed that we have less burn back with the thulium fiber compared to holmium. Dr. Molina, again from the States, demonstrated that there is no difference regarding holmium in terms of intrarenal temperature. You know that when we're using this high power system, we increase the temperature into the kidney, but there's no difference actually with thulium fiber and holmium-YAG. Thulium fiber is also superior in terms of maintenance. It's a very resistant, very robust system. And now let's have a look about the clinical experience. We are at the beginning, actually. We need more data, but the initial data, initial experience are very promising. One of the first clinical experiences coming from Russia. You know Dr. Martov, and also the people from Sechenov University. They demonstrate that they were able to go much faster regarding the operating time compared to holmium-YAG. You probably remember these 2 cases I did in 2019 in India during one workshop. And at that occasion, I was able to operate two patients, one with holmium-YAG technology, a second one with the thulium fiber. And you can see regarding my results that I was going much faster with the thulium fiber. I was able to break more or less 1 cubic millimeter per second. With the holmium-YAG, I was 0.6. And this is exactly what I do. Actually, that's my personal data. It's exactly this, meaning that I'm able actually to go more or less 2 times faster with my thulium fiber. Also remember that I think it's very important that we evaluate what we are doing actually. And I think 2 good parameters are these one, the cubic millimeter per second and the joules per second we are using. It's all of us, we should evaluate what we are doing today with these parameters, also with the joule per cubic millimeter. We very recently, few weeks ago, we published our initial experience in my department in Tenot in Paris, and that's what we demonstrate. Again, if we compare to previous experience with Holmium-YAG, we demonstrate again that we are going two times faster. So I think it's clearly demonstrate actually that there is really a benefit in terms of operating time associated with the thulium fiber. Of course, we will have to compare the different systems. Actually, we do some evaluation regarding the two systems available in Europe. To be honest, it seems very, very comparable. It's very difficult to tell you that one system is superior. Both of them are excellent. It works very well. Very small differences actually. It's also a fantastic equipment because you can use it also for the BPH in the pulse mode or the continuous mode, and it's also possible to use it for conservative treatment of urothelial tumor. For the conservative treatment, be careful. It's excellent because you have less bleeding, so this is something that we like a lot. The second problem is the thulium fiber is producing much more necrotic tissue. So when you are treating a big tumor, I must say that it's a bit confusing to have such a big necrotic tissue in front of you. With Holmium-YAG, the necrotic tissue disappears. So you can see much better the tumor to proceed. With the thulium fiber, the necrotic tissue stay in place over the tumor, and then it's a bit difficult to proceed. If the tumor is smaller, it's perfect because there's not too much necrotic tissue and there's less bleeding. But when the tumor is bigger, actually, I much prefer to use my Holmium-YAG compared to the thulium fiber. So the superiority of thulium fiber for the conservative treatment, I'm not sure it's so superior. We need to evaluate a little bit more. And finally, and to conclude, you have probably seen this recent publication regarding thulium-YAG. You know, thulium-YAG is not thulium fiber. Don't be confused. I think thulium-YAG, this is a modified thulium-YAG. Something interesting, I'm not sure that today we can recommend thulium-YAG modified as an alternative to the thulium fiber. It seems interesting, but we need much more data, much more evaluation. So don't be confused, because when you see this title, you see thulium laser compared to Holmium-YAG. Be careful, it's thulium-YAG, and it's not thulium fiber. So be careful with this kind of confusing message, actually. And I thank you for your attention.
I think please unmute Now's studio.
Just has entered to Nepal, and I want to give this mic to our chairman, Dr. Ravindra Sabnis. Also, he also wants to tell something.
Yeah, I think it was a fantastic lecture. One thing about Dr. Oliver Trexler is that we have heard the same topic several times, but every time we learn something new. Every time when we listen, we think that something new has come up, something different has come up. He makes it so interesting. And I think all these nitty-gritties of the laser disintegration and the peculiarities of thulium fiber are very nicely highlighted. I'm really excited to listen to this talk once again. Thank you.
Thank you, Ravindra. I think, you know, Ravindra, my general message regarding this talk actually, and that's why I put my first slide regarding the power. I think be careful. That's really my general message. Be careful with too much power into the kidney. Now we have very big systems. Holmium-YAG high power and thulium fiber is also very powerful. Be careful not to use too much power when you are into the kidney with flexible. My personal recommendation is don't go over 24 watts actually, according to the setting you will put in terms of energy and frequency. Be careful of that.
Because the question of the heat still is debatable, and a lot of people still continue to blame thulium fiber for excessive heat generation as compared to holmium. However, there are no in vivo and randomized studies, but this is what people keep blaming, and especially the holmium lasers keep highlighting that factor. So what you have to say on that?
Sorry, Ravindra, I'm not sure I catch the questions. You mean regarding the problem that we can generate with high power?
No, the heat generation, the temperature. So
exactly.
that problem is still not resolved. A lot of controversial things, and holmium people, they always say that there's a lot of heat and people get carried away with that.
Yeah, you're totally right. I think we don't know exactly. I can just tell you that actually we had recently two severe complications in terms of very severe bleeding. I have never seen this in my life. I can tell you in more than 20 years using holmium YAG low power. But we had two very severe complications recently with the thulium fiber. One of my explanation is we were using really too much power inside the kidney, and maybe this problem with this high temperature, especially if you do, you know my technique. When I press on the pedal for the laser, I don't stop. I press and I go continuously. So it means that all the time, my power is really 24 watts or even more. And this is maybe one of the problems, that when you are using very high power, because you put a lot of frequency, maybe you have to make some stops sometimes, to irrigate and to refresh a little bit the system, the kidney with the irrigation. And I think we need to take care about that. So again, since we don't know exactly the reason and what is the impact of this very high power into the kidney, I would recommend my colleagues actually don't go over to 24 watts. Most of the time it's enough. There's no need to go too high. And one of the problems is that people are thinking that high frequency is necessary, and they are pushing frequency. I think it's a mistake.
Dr. Oliver, the last question from here. Though thulium laser has the frequency up to 2200, what is the maximum frequency you can use for RIRS in TFL?
The problem is much more regarding the endoscopic vision. The problem is that when you put much more frequency, you have a lot of pulses, and then you generate a lot of dust, and then you see nothing. So the limitation is really due to the quality of the vision. I would say most of the time, we are able to control 200 or 300 pulses per second in terms of frequency, but you need to use low energy together. Be careful not to put too much energy, like 0.3, 0.4, and too much frequency. As you know, there is a balance between both. But probably if you are using very low energy, you can probably go to more than 200, 300 in terms of frequency.
Okay, thank you very much, Dr. Oliver Traxler. Now we're moving to next speaker. Is Dr. Keller online?
Yes, I am, and I hope that you hear me. Good morning.
Etienne Keller, he is the consultant urologist at the University Hospital Zurich in Switzerland. He specializes in adult and pediatric management of the urolithiasis, as well as laser inoculation and vaporization of the prostate. Yes, Dr. Keller.
Thank you. So I was proposed to have a pre-record presentation. I think it worked very well, and I would propose to have that pre-recorded presentation played. Thank you.
Chairman, dear colleagues, my name is Etienne Xavier Keller. I'm an endourologist situated in Switzerland at the University Hospital of Zurich. It's a great honor to me to have been invited to give this talk on lower pole retrograde intrarenal surgery, also known as flexible ureteroscopy. These are my disclosures, none of which is in conflict with the presentation. So first of all, lower pole stones, it is a big topic. It has been covered in literature since at least 2 decades. And if you look back to what has been published in the year 2020, there have been many good publications, at least 7, asking whether the anatomy or the infundibulopelvic angle impacts on the success of stone clearance with lower pole stones. There have been comparisons of different techniques, meta-analysis of the data published yet, and also reports about special cases. So why is this such a big topic in the literature? It's quite easy. The lower pole is just the most difficult calyx to reach with the flexible ureteroscope. And accordingly, it has been, over the past years, a big challenge to clear those stones. Today's presentation is not going to be exhaustive on the review of the literature. What I want to present to you is much more the tips and tricks, the hazards and pitfalls of lower pole ureteroscopy. First of all, the big topic of scope deflection. Of course, the deflection of a flexible ureteroscope will be different between a different brand and a different model. But every single of those flexible ureteroscope has the problem that the active deflection gets impaired when you put some ancillary devices within the working channel. May it be a basket or a laser fiber. And this is a problem that can be even greater when you use digital ureteroscopes. And this is caused by the big metallic capsule at the tip of the digital ureteroscopes, where the fiber optic can have a much better end deflection. So this might be your workaround for some patients. In the deflected instrument, there's a great risk of damage of the inner coating of the working channel. And this is because the inner coating is very soft and should be a gliding coating. This is especially true if you insert a laser fiber, because a laser fiber is nothing else than glass. It's also called silica. So the core and the cladding of the laser fiber is like a knife for the working channel. The protective jacket here in blue is made out of plastic. So the industry proposed the following workaround. It is called the bolt tip laser fiber. Indeed, this concept is useful to insert a fresh laser fiber in a deflected scope, but the problem is that the bolt tip design will get destructed within about 50 to 100 pulses during the lithotripsy, and then you are not able to use the bolt tip anymore. For this reason, the group of Professor Traxler came up with the concept of cutting the laser fiber through the protective jacket. And you do not need any special scissors for this. It was verified in an in vitro study that it is sufficient to just cut the laser fiber within the blue jacket to warrant the insertion of the fiber even in a deflected scope. In a deflected scope, there is another problem. If you do lithotripsy with a very sharp angle of deflection, there is the risk of laser fiber breakage. Also, this aspect has been verified in a study from the group of Professor Traxler, who showed that the more narrow the diameter of deflection and the higher the pulse energy, the higher will be the risk of laser fiber damage, and with the incurring risk of damaging your ureteroscope. Another very important point is to acknowledge the position of the working channel of each scope, which cannot be changed for a singular scope. It is either at the 3 o'clock position or at the 9 o'clock position. And as you can see in this study by the group of Professor Traxler, it is exactly the lower pole area that encounters some difficulties. So for a posteriorly located lower pole, you will want to have a scope that has a working channel at 3 o'clock for a right kidney and at 9 o'clock for a left kidney. For anterior calyxes, it seems that the 9 o'clock position is better for the right kidney and the 3 o'clock position is better for the left kidney. So those were the very important aspects when you need to treat the stone in situ. Now, of course, there is a big workaround for the problems we just discussed about. The workaround will be to simply relocate the stone from the lower pole and to put it in a more easy place. Why would we want to do this? To reduce the risk of instrument damages, to allow for an easier laser lithotripsy, and nonetheless maybe get a better stone clearance. But concerning the stone clearance, even though the technique of lower pole displacement has been described more than 20 years ago, it is still unclear in 2021 whether this leads to a higher stone-free rate. Here are the tips and tricks of how to relocate that stone. First of all, we are going to detail how to relocate a stone with a basket. I propose to use a so-called zero-tip nitinol basket. This is easier to pass along a big stone and then to open the basket secondly. In my experience, I have a higher success of entrapment of lower pole stones with such zero-tip baskets. What you do then is you take back your scope, you put the stone in the pelvis, and to release the stone from the basket, it's quite simple. You leave it fully open and you retrieve it within the working channel. If you push it out again, and maybe you need to retrieve it a third time again, it will get out of the basket. Now comes a technique that should be reserved for advanced users, somebody that feels very comfortable in flexible ureteroscopy. The concept will be to spare a basket and to use only the laser fiber to relocate the stone. It is possible. So what you have to do is to get in front of the stone and then put your laser fiber within the stone while you are activating the laser generator. What happens is that the silica, so the glass of the laser fiber, will incorporate into the stone and it will be sticking to the stone like it was glued. It really works. And then again, you go back to the pelvis, and to release the stone, you just have to pull back the laser fiber a bit in the instrument until the stone detaches. Of course, at this point, you are not lasering. The lasering is only when you insert the fiber. There's a great risk of damages because you cannot really appreciate how profound your laser fiber is within the stone. So I really want to emphasize that this is only for advanced users, and if you feel uncomfortable, then do it only with a good mentor. A last tip and trick how to relocate a stone is the situation where the stone is too big to get out of a narrow infundibulum. In such cases, I would to use a laser fiber and to do an in situ lithotripsy until the fragments are just small enough to be placed in the pelvis back again. And from here you can decide whether you want to try to retrieve the fragments directly, or maybe if they are still too large, you can do now in a very comfortable position in the pelvis a laser lithotripsy. So I hope that now you really understand that lower pole stones are a real challenge for the endourologist. And if you are not aware of the tips and tricks, you have a great risk of not being successful and having instrument damages. So please keep in mind everything we talked about concerning deflection, working channel position, cleaving a laser fiber, and relocating stones, and this will lead you to success. I thank you all very much for your attention. I feel really privileged to have had this presentation at the Nepalese Urologist Congress, and please feel free to write to me if something was not clear, if you have further questions. Bye bye, see you soon. Dear Chairman.
Thank you, Dr. Keller. I am sure the young urologist must have grasped your trick and tricks to reposition the stones from the lower calyx. Very useful talk. Thank you. May I now move on and call upon Dr. Sung Yong Cho, Associate Professor in Department of Urology in the Seoul National University. He is first person to perform supine PCNL, ECIRS, and RIRS with disposable scope in Korea, largest case series in RIRS and mini PCNL in Korea. Contributed as first author in chapters on various books on endourology, neurourology, and sexual medicine and andrology. It seems that Dr. Cho is a versatile urologist, and he is going to talk on ECIRS.
Good
Can you hear me?
ladies and gentlemen. It's my great honor to be invited to this webinar. Especially thank you, my friend Dr. Anil. I'm Sung Yong Cho. I'm working for the Seoul National University Hospital. I'm so happy to have such a good opportunity to share my experience with you today. For the treatment of complicated urinary calculi, I normally plan what type of surgery would be the best option for my patients. For small and multiple stones, I do not hesitate to choose RIRS first. For big stones, I consider a miniaturized percutaneous nephroidectomy first and RIRS as the next option. However, when should we consider bidirectional combined approach of antegrade and retrograde access? It may mean the initial bidirectional approach to the target or interoperative conversion of the surgical method. It is important to the surgeon and more important to our assistants who have to prepare the surgical equipment and the patient positions before surgeons arrive at the operating room. What should we consider for surgical efficacy then? There are many different situations, but we can choose stone-free status, relieving pain or obstruction, or improving renal function. We cannot choose only the stone-free rate in many cases. How about surgical safety? We can first choose less complications, and sometimes we have to stop stone fragmentation and have to remove the percutaneous tract to stop bleeding, because we can see much bleeding and we can leave some remnant stones in the patient's kidneys. It may mean we can negotiate the best results considering patient safety. Basically, a combined approach can be used to remove the ipsilateral renal stones and bilateral kidney stones. The target can include stones, strictures, and urothelia tumors. The terminology ESURS, namely endoscopic intrarenal, combined intrarenal surgery, originally tried to represent the combined antegrade and retrograde approach to remove the ipsilateral renal stones simultaneously by two main surgeons. However, the concept of the combined treatment of multiple stones has been expanded to consecutive application of multiple modalities or bilateral bidirectional approach to multiple targets. Now, this period can be called as the era of combined renal surgery. For example, I published my performance of ipsilateral PCNL procedures with subsequent ipsilateral or contralateral RIRS procedures at the end of the PCNL procedure in the Journal of International Journal of Urology several years ago. Overall, 26 patients were included in this analysis, and the stone-free rate of the initial endoscopic intrarenal surgeries was 76.9%, and the stone-free rate of the contralateral side was 92.3%. Complications occurred only in 2 patients, postoperative bleeding and urinary tract infection. However, these conditions were completely resolved with appropriate medications within 2 weeks postoperatively. I mean, this maneuver, this surgical procedures are quite feasible. Namely, many urologists are now recognizing the concept of the combined treatment of multiple targets as consecutive or simultaneous application of multiple modalities to multiple targets. As a previous investigation shows, the general prevalence of bilateral urolithiasis has risen to 15%, and bilateral non-simultaneous treatment has been also reported to have good outcomes. Key advantages of this seems to be reduced operative times, cost, and hospital stay, which will lead to an increased uptake of these procedures in the future. The kidneys and the renal stones are showing many different complicated situations, including some examples in this slide. But for the case of long calyceal neck, multiple tracks can be necessary, and fluoroscopic puncture can be helpful and feasible. For diverticular stones, a single application of fluoroscopic or ultrasonographic puncture can be feasible. The prone position can be the best option for the upper pole posterior diverticulum, but the situation can be a little bit different if it is the upper pole anterior diverticulum, because we have to penetrate the upper pole parenchyma to reach there. The risk of bleeding is increasing, and the miniaturized nephroscope have to be considered. Another thing is that we have to consider the acute angle of the renal axis in the supine position, because the tract can be made from below the rib series, and the penetrating length of the kidney can be quite long. You can see the obstructed ureters with many stones in the lower 3 figures. No fluoroscopic retrograde identification of the renal callus is available, and the use of ultrasonography is the only option to the surgeons. All these cases have to be considered for preparing combined approach, I mean the modified supine position, but not a simultaneous approach. How about the duplicated renal calluses? The anatomy is showing the narrow infundibulum of the lower of the ureter from the lower moiety with the acute angle of the ureter at the bifurcation level. The fluoroscopic retrograde approach can show failure in some cases, and in this situation, antegrade stone removal is the only option for this. Therefore, we need some time to have all this equipment, but I strongly recommend the combined approach of fluoroscopy and ultrasonographic puncture to maximize the success rate of renal access when we consider the complicated renal anatomy and stone distribution. And this is my case yesterday. There was a big stone in the renal pelvis and some additional fragments in the lower pole. My residents performed WJ indwelling 1 week prior to main surgery, but the upper tip of the WJ catheter was located in the upper ureter, not in the renal pelvis. And at first, I didn't recognize any problem with this because the operative record was incomplete. I couldn't guess the upper ureteric stricture. So When I performed the RIRS first, the ureter kinking was so bad, and my final destination was antegrade ultrasonographic puncture with position change from lithotomy position to modified supine position. We can think of multiple options for patient's position. Easy accessibility to the target, easy conversion of the operative method, device and equipment, and surgeon's preferences can be important parameters to choose the patient position. The anatomy of the kidney and ureter is also important because the anatomy under the nephroscopic or flexible ureteroscopic guidance should be intuitive to the surgeons. Now this figure is showing a different endoscopic view of the different calyces from flank side in the supine position. The lower pole is normally located higher than the kidney upper pole or mid pole. Anterior and posterior calyces are matched to the upper and lower direction movement of the nephroscope. When you consider the ureter course and the easy application of RIRS to the kidney, I inevitably prefer supine position to prone. In supine position, the direction to the ureterovascular junction from urethra, namely ureteral orifice, is quite straight. But the ureter goes upward to the common iliac vessels and downward from this point to the kidney. In prone position, the ureter goes quite straight compared to the supine position. However, the access to the ureteral orifice is very, very steep. So for combined approach, I think the supine position seems to be better than prone position. For combined approach, we have to dedicate our time to use operating room compactly and efficiently. To plan the accurate percutaneous puncture, I'm using the ultrasonography and 3D printing technique, especially technology, especially for complicated cases, including diverticular stones. Actually, I cannot deny the problem of the large number of devices for combined approach. Therefore, we have to arrange the location of the equipment systematically and delicately with our assistants in the operating room. Another point to check is what type of flexible instrument we have to use. I normally choose flexible ureteroscopy than flexible nephroscopy at the end of the PCNL procedures because flexible nephroscopy is flexible ureteroscopy is more compatible to navigate all the calyces than flexible nephroscope. However, some surgeons who favor prone can choose flexible nephroscope at the end of the PCNL procedure, considering the difficult approach to the ureteral orifice with flexible ureteroscopy. A previous comparative study in this slide also shows that retrograde flexible ureteroscopy is much better than antegrade flexible nephroscope in terms of successful access and the rate of residual fragments. Now my take-home messages are like this. First, according to the evolution of PCNL, bidirectional approach enables us to manage all the stones in different locations. Second, in terms of safety, surgeons have to consider relatively better options according to the patient's condition. I already told you the case of bleeding, intraoperative bleeding. Third, the concept of the combined treatment of multiple stones has been expanded. Consecutive application of multiple modalities or bilateral, bidirectional approach to the multiple targets. And lastly, for combined approach, supine position seems to be better than prone. However, the large number of devices for combined approach is still problematic. Thank you for your attention, and thank you, Dr. Anil, for this great opportunity.
I think the mic is off.
Please unmute studio.
And we'll get on with the another paper. Lecture.
The another lecture will be by Abhishek Singh. I think he's from Muljibai Patel Hospital in Nadiad. If I'm wrong, please correct me.
Yes.
He's talking about the contemporary disposable ureteroscope, how useful they are in our part of the world. Dr. Abhishek?
Yeah, please run the video. Yeah, Dr. Abhishek is a consultant with us, and now he has done a lot of stonework. He has presented a lot of papers, and he's quite interested in RIRS and various other surgeries. So please start his video. Do you have his video? He has submitted video. Do you have it? Please play the video.
Abhishek, can you hear us? I can see him online. Okay, Abhishek, can you hear us? There is some problem with your video. Can you present live in Zoom?
I think Abhishek. Hello, Abhishek, can you hear us?
Yes, sir. We are playing the video, sir.
Okay, so please go ahead.
A very good morning to all the viewers. I am Dr. Abhishek Singh from Muljibai Patel Urological Hospital. I thank the Nepal Urological Association for this wonderful opportunity. I also thank Dr. Anil Shrestha for this wonderful opportunity. Today, I would be speaking on insight into contemporary limited use flexible ureteroscopes. I have nothing to disclose. My flow of talk will revolve around description of 3 commonly used limited use flexible ureteroscope, comparison of the various scopes, comparison with the conventional scopes, description of smaller caliber limited use scopes, and then cost evaluation. As far as we are concerned, we are interested in the digital, lightweight, limited use ureteroscopes. So today we will be concentrating on 3 scopes: LithoView, U-scope, and endoscope. All the 3 are digital, and their shaft diameters range between 9 and 10 French. So let us start talking about endoscope. So endoscope is a scope by Biorad Medical Services. The shaft diameter of this scope is about 9 French. The shaft length is 67 centimeters. It has a working channel of 3.3 French and a deflection capability of 270 degrees on both sides. It is available in logic deflection. Now, if you look at the physical characteristics of all of these limited use scopes, they are pretty much lightweight. They do not have an additional weight of a camera. They are available in logic or anti-logic deflections. They can deflect up to 270 degrees. They are lightweight, therefore extremely ergonomic. The endoscope has a plug and play compatibility. The cable connector here, which has multiple pins, can be connected into this adapter. And this adapter in turn connected to your conventional screen. So you don't have to buy a separate monitor. and the monitor can process via HDMI, SDI, or DVI inputs and outputs. So when you compare this particular endoscope to a digital or a fiber optic conventional scope, it is comparable on many grounds and superior on many others. So if you look at the digital vision is very good. It is better than the fiber optic scope. And when you compare it with the digital imaging, the conventional digital imaging, you can still feel that the imaging is comparable, if not superior. So the weight of this particular scope is very light. It weighs 294 grams. The weight of the handle is only 180 grams. If you compare this with LithoView, the LithoView is a little lighter. It is 277 grams, including the length of the scope. What about the flexible tip? The flexible tip in endoscope is about 7 centimeters, and the same thing for LithoView is about 5.7 centimeters. Broadly speaking, all these scopes will have a flexible tip of about 5 to 7 centimeters. The optics of endoscope are also very good. When you compare it with LithoView and U-scope, it is definitely comparable. The field of view is 110 degrees, line of vision is 0 degrees, depth of view is 2 mm to 50 mm. It has a fiber optic illuminator and uses the digital CMOS technology. When you look at the exit of the laser fiber exits at 9 o'clock in endoscope, and in U-scope and LithoView it exits at 3 o'clock. The deflection of endoscope is 270 degrees without any instrument in the accessory channel. And with the accessory instrument also, the deflection loss is about 10 to 20 degrees only. It can access the lower pole well, and the fragmentation is also possible if the relocation is not possible. So this is pretty much true for all three scopes, but endoscope has this capability. Endoscope works for 21 hours, and now endoscope sleep is available, which has a shaft diameter of 7.5 French. Coming to a 9.5 French ureteroscope by Fusion called the U-scope. Now this U-scope is again 65 centimeters in length, has an outer diameter of 9.5. The tip is 9 French. It has a deflection of 270 degrees on both the sides. The working channel is 3.6 French, which is slightly bigger than the endoscope. Field of view is 120 degrees. It has an illumination by optical fibers and uses CMOS technology. This is a video demonstration of a lower pole stone managed by the U-scope. So turning the scope into the lower pole is not very difficult. The fiber exits at 3 o'clock. This might be helpful when you're working in the right kidney. The mediolateral movement and the flexion are very comfortable. The light weight of the scopes allows you to do the palm in and palm out movement very easily. Coming to the third scope, which is a LithoView. LithoView is manufactured by Boston Scientific. It has its own tower. It does not come in with an adapter, which can be used to connect it to the conventional screen that you have. It has a touch panel, interface box, and the scope itself. The platform for LithoView is digital. It is a 9.5 French scope. It is 7.7 French at the tip. It uses the digital CMOS integrator or imager. The working distance for the scope is about 2 mm to 50 mm. It has a working channel of 3.6 French. The field of view is 15.75 mm and the deflection is 276 degrees. If you look at the maneuverability of LithoView scope with accessories inside, there is some loss of flexion, but still the deflection is very, very good. So the range of movement with LithoView scope is very good. With a clear channel, the deflection is as high as 285 degrees. If you put in a 200 micron laser fiber, then you can go up to 277 degrees. And if you put in a basket, that is 1.9 French basket, you can still go up to 270 degrees. The irrigation with LithoView scope is also very good. If you consider the irrigation against the empty channel, when you put in a 200 micron fiber, the irrigation decreases by 50%. And when you put in a 1.9 French stone basket, it decreases to 1/4. Now let us visually compare the three scopes. The three scopes are digital. As I told you, the exit of fiber in an endoscope is at 9 o'clock, and in the other two scopes, it is at 3 o'clock. Depth of field is about 4 to 5 mm in all three scopes, and the field of view is between 9 to 15 mm. On and on, one can say that the three scopes are comparable in terms of maneuverability, flexibility, and vision. So let me share our experience of a randomized in vivo and in vitro comparison between LithoView and Fusion scope. In this study, we compared a few parameters. The first one was irrigation flow. The irrigation flow was tested without flexion and with full deflection, without any accessory, with laser fiber and with a basket in situ. And the flow was comparable in all 6 scenarios. We compared deflection without any accessory, with basket and with laser fiber, and the deflection was comparable between the 2 scopes. In the same patient and for the same stone and in the same situation, we tried imaging the patient with both the scopes and the images were comparable. A third person's assessment was also involved in the study. The vision with accessory, without accessory, and during lasing were compared between the 2 scopes and they were comparable. So we concluded that both the scopes are comparable in vitro and in vivo as per their performance. So what happens when you compare the single use or a limited use ureteroscopes to the conventional ureteroscope? So first you compare them in terms of efficacy and reusability. They are definitely comparable. And when you compare them with the digital scopes, yes, definitely they have the visibility and maneuverability profile, which is comparable to the digital ureteroscopes also. And cost obviously favors the disposable scopes. Now let us see a comparison of 7.5 French scope to a 9.5 French scope. The 7.5 French scope are smaller. The deflection is slightly less with basket as compared to the 9.5 French scope. The flow rates are comparable with and without accessories, even for the U scope 7.5 French. I would say the color perception is slightly paler and the image resolution is slightly poorer in a 7.5 French scope. So are these 2 scopes actually comparable in the real-time use? Probably yes, though we'll see that the image resolution in the 9.5 French scope is slightly better, but considering that 7.5 French scope is used in more difficult situations, it still holds the image resolution and the maneuverability is good. So 7.5 French is not an all-weather scope, but you should have it in your armamentarium so that you can deal with difficult situations. Let us briefly discuss the cost of single-use or a limited-use ureteroscope. LithoView costs 94,000 Indian rupees and its processing unit costs 4.1 lakh. Fusion costs 72,800 and the processing unit costs 1.5 lakh rupees. The endoscope costs 89,600 rupees and the processing unit costs about 3.5 lakh rupees. They can be combined with several schemes and you might get discounts, but broadly speaking, this is the cost. On an average, you require half an hour to do one case where the stone is about 1 centimeter. So if you do 8 cases with all these scopes, the cost will be about 11,000 odd rupees for LithoView, 9,000 for Fusion, and about 2,100 for BioRad scope. This entire issue is controversial, but we have been using disposable wires, baskets, needles, so why not ureteroscope? So if you compare them with the conventional scopes, they are definitely cheap if you can reuse them. But again, I said this is an extremely controversial statement. Many people may not agree with it. So with this, I come to an end of my talk, and my take-home messages are: single-use or limited-use flexible ureteroscopes are comparable to digital conventional ureteroscopes in terms of vision and maneuverability. They are cost-effective. There is decreased stress of breakage of these scopes. The user gets a digital quality image and the instrument is extremely lightweight. It helps in resident training. Lower calyx and difficult situations can be accessed more often, and the indications for RIRS have become extremely liberal. Thank you very much for a patient listening. As we part off, we must think about 2 things. Do actually disposable scopes decrease waste, help us conserve energy, and eliminate the exposure of toxic waste to staff? Or do they actually increase the carbon footprint and add to the global problems? I leave you with this thought. Thank you once again.
You have to unmute. We can't hear.
I would like to thank all the speakers and everybody in the auditorium as well as online for your patients' participation, patients' hearing. Thank you.
Dr. Sabnis, would you like to mention something?
No, I think all the speakers have done a fantastic job. It was a treat to listen to Oliver Trexler, and other peer speakers also have given the nice overview of the topic which was allotted to them. So thank you very much.
Thank you, chairpersons, and all the speakers of Stone session. Especially thank you to Abhishek Singh for being standby when video was not playing. Thank you, everyone.
Namaste and very good afternoon. Now we are moving towards a plenary session. To run this session, I request Dr. A.D. Bhatta sir, Professor C.S. Agrawal sir, the president of NAUS, to chair the session. And in the meantime, our past president, Dr. Biswaraj Joshi, is joining with us virtually. So we'll start with the two guest lectures from national faculties, and there are several papers also. So I request the chairpersons to conduct the session. Thank you. Yeah.
Good afternoon. So we are already late by half an hour, so there will be no question answer in between. We will see if time permits, we will allow the audience to for question. Dr. Biswaraj Joshi is another chairperson with us. He is probably online. Dr. Biswaraj Joshi, if he is online, please show his photo. So now I request Professor A.D. Bhatta to continue the session.
I called upon to present his paper, guest lecture, Radiation Safety for Urologist, Professor Krishna Kaji Bhomi, please.
Good afternoon, delegates. Today I'm going to talk on radiation safety for urologists. I would like to start my presentation by showing you this picture. This is the first X-ray image taken by William Roentgen, who discovered X-ray in 1895. Incidentally, this is Mrs. Roentgen's hand. The aim of my presentation today is to review radiation risk to urologists during urological procedures, to sensitize our urologists about the radiation risk they are involved, and to remind the ways to reduce radiation dose and prevent the risk involved. So ionizing radiation, X-ray is an ionizing radiation. It can ionize the interacting medium by knocking off an electron from the atom, producing free radicals that can damage DNA or cause tissue injury. Scatter radiation from the patients, parts of the table and equipment is the main source of radiation exposure to urologists. Let us be familiar with these terminologies. Absorbed dose is energy absorbed per unit mass of the body tissue. Equivalent dose is absorbed energy based on radiation type, and effective dose is biologic risk associated with absorbed energy. It has a threshold dose below which there is absence of effect and above which the severity of effect increases with the dose. Example is skin erythema and cataract. Stochastic effect represents probability of effect rather than its severity. It lacks threshold and the probability of effect increases with the increased dose. Radiation-induced cancer and genetic effects are the examples. Occupational dose limits are set by ICRP. The upper limit of 500 and for hands and feet is 500 millisieverts per year. So what is the risk to a urologist? The answer is it depends on how busy you are. This table shows mean effective dose in an average ECNL. This column shows dose per procedure to the different parts of the body, and this last column shows recommended dose limit per year. If you see these doses, the whole body dose, fingers and legs dose are remain within recommended limit even if you do large number of cases. But look at the dose to the upper limit of the recommended dose. If you do 10 cases per week, it's 50 millisieverts, and if you do 20 cases per week, it's already 5 times the recommended dose limit. It's quite alarming. First reported radiation-induced lens opacity was in 1998, just 23 years back. In 2004, Haskell published a report where 37% of 59 interventional radiologists had X-ray associated lens changes. Following this, in 2008, IAEA started a project which revealed that 40 to 50% of interventional cardiologists had posterior subcapsular opacities consistent with radiation injury. That was 4 to 5 times higher than. So with 20 millisievert per year continuous exposure, detectable opacities in the lens would appear in 25 years. ICRP advocates the principle of ALARA, which includes time, distance, shielding, justification tool for occupational protection from the radiation. We should ensure that the radiation dose from a procedure is expected to do more good than harm. And once radiation exposure is justified, we should optimize it by giving lower dose while maintaining efficacy and accuracy. So this fluoroscopy machine is the source of all radiation hazards to urologists. So we should know it and we should handle it safely to prevent us from unnecessary radiations. We should identify the X-ray source and image intensifier, and we should keep the X-ray source always below the patient's table. In most of the machines, the X-ray source is rectangular in shape and the image intensifier is circular in shape. On radiation inertia used and the lead equivalent thickness of the apron. For example, 0.5 mm lead equivalence thickness apron allows less than 1% of the radiation to pass through it if we use 60 kilovolt energy. But if we use 100 kilovolt energy, it allows 3 to 7% of the radiation to pass through it. Thyroid is sensitive to radiation in young people. The risk is small for males over 30 and females over 40 years. NCRP recommends use of thyroid collars for younger workers and all personnel whose dosimeter readings be a purpose-designed lead glasses with large flat lenses and protective side shields. This lead glasses was bought in our institute several years back, and we kept it in the cupboard unused for several years. Now I know the risk and I have already started using these glasses. So my request to my colleagues is, if you haven't started, please start it. It's essential. Thin protective gloves are available with variable reports of protection ranging from 50 to 60%. Ceiling suspended lead screen, stand mounted lead glass screen, and table suspended lead curtains are very useful to protect from the scattered radiation. There are two types of dosimeters, active and passive. Active dosimeters provide immediate information about dose rate, but they require power supply. Whereas passive dosimeters do not require power supply, but they only provide total dose accommodated over a period of use. This is the TLE dosimeter we use in our institute, which is provided by NAST to the hospitals of Nepal. ICRP recommends use of two dosimeters at the same time. One located at the collar level over the apron to monitor dose to the lens, another under the apron at the waist level to monitor effective dose to the body. Blair and colleagues published a retrospective study about reduced fluoroscopy protocol in PCNL. They found that steps such as laser guide, pulse fluoroscopy, fixed load MA KVs, and visual and tactile cues, and a dedicated single technician decreased the fluoroscopy time significantly. They also found that there was 80.9% reduction in fluoroscopy time while maintaining similar success rate, operative times, and complications in PCNL, and position the patient as close to the image intensifier as possible. Avoid steep gantry angulations, use pulse fluoroscopy at low pulse rate, use laser guide to position the fluoroscopy, collimate the beam tightly to the area of interest, and use magnification only when it is essential. And then what you can do yourself. You can employ a well-trained, dedicated technician who knows what you want and when you want. Plan the step before exposure. Similarly, mark the area of interest before exposure. Use short taps of fluoroscopy instead of continuous exposure. Hold the last image and study it. You can modify techniques like using air pyelogram, ultrasonography, or endoscopy guided access, needle holder to hold needles during puncture in PCNL. Of course, you seal yourself, including using lead glasses and step back. So at the end of this presentation, if somebody asks me what is X-ray, my answer would be X-ray is an invisible enemy. The risk is real. Damage appears several years later. So radiation dose of as little as 10 millisievert may result in the development of a malignancy in 1 out of 1,000 individuals who worked as assistant to an X-ray lab of Thomas Edison in 1890s. He used to keep his hand under radiation exposure for hours for 8 years, while his boss used to do experiment with the X-rays. Later, he developed skin malignancy in his hand, which later. So my tribute to Clarence Madison Daly as the first reported death directly due to radiation hazard. So my request to my colleagues is always remember this hand before you press the foot switch of your fluoroscopy machine. Thank you for listening.
Thank you, Dr. Bhumi. Next presentation is by Professor Paras Shrestha on laparoscopic urological interventions in iatrogenic gynecological injury. Please start the video.
Good morning, everybody. Today I'm going to talk about laparoscopic urologic intervention in iatrogenic gynecology injuries. The risk of injury in the pyloric tract in gynecology surgery is not so uncommon because they are very close to each other and they resemble each other. The urinary injuries incidents are commoner than other bladder injuries, and these are the most common places where you may injure ureter and bladder. While we ligate the genital vessels, while doing pelvic dissections, even a little bit come down closer, which is very common, that ligation while ligating uterine vessels and while you are dissecting bladder from vagina. So what are the mechanical injuries? There may be crushing, ligature, resection. It may be ischemia, segmental resection, and thermal burns. So the fate may be, if it is minimal, there may be spontaneous healing. There may be hydroureter, hydronephrosis, urinoma formation, fistula, repair that time. Or earlier the better, but if you have fistula formation, better wait for 3 to 6 weeks. There are different modalities, which includes open and lab. In our previous experience, we have shared of our open surgeries and the ureterostomy. If you're doing a little higher ureterostomy, then this is a typical upper tract approach position like we do in nephrectomy and pyeloplasty. We mobilize the colon, we find out the stricture part, and in this case, there was a stone, secondary stone above the stricture. After we transect the ureter, we do spatulations on the upper as well lower end, and we start suturing first by posterior wall. This is stented, and the anterior. This is how it looks at the end. Duration was 105 minutes, and after 4 weeks, we removed the stent. So there has been studies showing that it's feasible procedure with low complication rate and high success rate. Another procedure is laparoscopic UCN, which was done in post-vaginal hysterectomy patient with a distal ureteric stricture. Pelvic ports typical as we use in all cases. This is the position of the surgeons in the middle and nurses and your camera assistant on one side. And first we dissect the ureter from up to the stricture, transect it. Then we make the anastomotic site on the bladder like this. Then we close on one end and when we stent the ureter, and we close the other layer. This is how it looks, but we still have to make a submucosal tunnel. So this is how it looks, good osmosis. But if you have a longer stricture like this, we need to use a flap creating from the bladder, which is called body flap. After mobilizing the ureter, you bring down the bladder anteriorly and transecting and spatulation of the ureter. Then we create a flap from the bladder, and we try to create a tunnel like this, and we stent the tunnel, and we close the bladder side, as well as the ureter is tubularized, and we put swashes to decrease the tension and place the drain and come out. Similar outcome with 4 weeks digested removal. And literature has also shown that this body flap procedure is feasible and outcome is pretty good. And laparoscopic VVF repair is recently what we have done. This was done in a patient with 1 year of vaginal leak after lapistectomy for fibroid. And this was a CT finding with an obvious VVF. And cystoscopic finding was there was supratrigonal rent about less than 1 centimeter. And this was how it looks. So we prepared the patient with ureteric catheterization and catheterization of the VVF. We put patient in a Exeter Trendelenburg with a device retractor, the vagina with the pack instead of usual usual vaginal pack. And this is how it looks with the 5 ports, usual pelvic ports. And this is a short video I want to share. So after the cystoscopic identification of the VVF, we cannulate it with the ureteric catheter through the vagina so that the tract can be identified. This is how it looks. When you move the device retractor, the valve moves and we know exactly where we are. So we dissect between the vault and the posterior bladder wall. And the idea is to dissect around the fistula, and whatever excess bladder tissue around it has to be excised. So you can use monopolar scissors. The bladder is a very vascular tissue. So this is the crucial part of the procedure. You have to visually differentiate the deducer muscle and the posterior tissue of the vaginal wall. So creating this flap is crucial before doing the final repair between these 2 layers. So your assistant will always be helping you with the suction, as the bladder is a very vascular tissue, and you create a very good interface between the bladder and the vaginal wall. So excess tissues of the tract, including the posterior bladder wall tissue, has to be excised, and all the tissue tracts has to be excised. Once you have done, you can cut the ureteric catheter coming through the fistula, and your assistant can help you by the side. Make sure that you don't take the bladder wall at the time, and continuous vision of this yellowish ureteric catheter will help you to ensure that you're closing the tract. So we are closing this tract vertically, and as you know, we have opened the bladder horizontally and coming towards the center, so that you see a very clear vision that you're not taking ureter while taking this bladder wall. These are running sutures. Once you have done on the one side coming to the middle, we can start from the other side and come to the same place, and we finally close the bladder. So we coming to the middle and we're reaching out the same place we have come from the other side. Suture lines. So this is the final knot here. This comes in between the two suture lines to make sure that the fistula doesn't occur. So this is 2 weeks post-op cystogram showing no leaks. After 2 weeks, we take out the catheter. There have been various studies. So one of the studies coming from India has shown that laparoscopic repair has reduced the patient morbidity as well as shorter hospital stay, and as a very attractive option. So the take-home message of my presentation would be laparoscopic reconstructive urology is technically feasible, but yet challenging with a steep learning curve. Given that undisputed clinical advantages associated with this minimal surgery, all the ureters and bladder iatrogenic gynecological injury should be considered for laparoscopic repair and reconstruction. Thank you all for your kind attention.
Thank you, Professor Paras, for highlighting this very, very important topic. Now we are going to listen Dr. Deepak Thakur. His topic is outcome and safety of retrograde intrarenal surgery. Dr. Deepak Thakur, please.
Good afternoon, respected chairpersons, my seniors and colleagues. I am presenting on the outcome and safety of retrograde intrarenal surgery. I have no conflict of interest. Kidney stone affect around 10% of the population. And pathetic thing is that around 70% of the people experience recurrence within 5 years of treatment. There are various non-invasive, minimal invasive, and invasive method available for the treatment of stone disease, ranging from the ESWL, percutaneous nephrolithotomy, RIRS, open and laparoscopic surgeries. RIRS is one of the endoscopic innovations for the treatment of stone disease. It uses flexible scope and laser energy, and it is proved superior to other modality in terms of morbidity and hospital stay, but it is too limited by its delicacy, cost factor, and long income. The objective of this study was to establish in the Department of Urology of Virat Medical College and Teaching Hospital from October 2020 to March 2021. All patients gave informed consent. We included the patient with a stone size up to 50 mm and who consented for RIRS. We excluded the patient with active urinary infection, coagulopathy, and larger stones, and patient not consenting for the stage procedure. We had 46 patients enrolled in the study, and 4 were excluded because they did not want the second procedure. They wanted their stone to be clear in single setting. And when ureteral excess was not negotiable, 4 patients underwent PCNR on the same stage. So finally, we had 42 patients for analysis. All patients were evaluated pre-operatively as per the institutional protocol, and they received antibiotic. No patient was pre-stented. They were brought with intention rigid ureteroscopy, and we used 0.035 inch of guide wire and ureteral excess of 10-12 from the book, and flexible scope was litho book from the Boston Scientific, and we had laser from the luminous Versa Pulse 20 watt. It is being dusted. I'm sorry for the poor image. At the end of the procedure, all patients were subjected 6 frames of double J stent, and X-ray KV are done on the next morning, and patients were discharged. Patient demography, stone status, operating time, hospital stay, and complications were recorded. Double J stent was removed after 2 weeks, and stone clearance was assessed after 1 month by ultrasound. Those who were having more than 4 millimeter of stone were considered clinically significant residual fragment. These are the baseline characteristics of my patient. The mean age was 40 years and with slight male predominance, and stones were distributed equal frequency on both sides, and mean stone size was 1.3 centimeter. And most common location of the stone was pugae and pelvis, followed by upper calyx, then proximal ureter, mid calyx, and lower calyx. The mean operating time was 52 minutes, and hospital stay ranges from 1 to 3 days. We had complication in 5 cases. 1 has grade 3 ureteric injury, and 4 patients had sepsis. Clinically significant residual fragment were seen in 6 cases. So coming to discussion, RIRS is considered the primary treatment modality for the stones less than 2 centimeter, and its use is increasing as a primary treatment even for the larger stones. And it has proven effective for renal stone with high stone free rate and low complications. We feel that pre-stenting is not mandatory because in our study, 57% of the cases accommodated ureteral sheath without stenting. And similar facts are given by the Mahajan and colleague. In their case, 94% of the cases accommodated ureteral sheath. And another study by our colleague Chetri and his team from the Bir hospital, and they proved that 68% of their cases with which we have compared our results. So all cases are just on site ranging from 1 to 2 centimeter. And if we compare our operating time, this is comparable. Hospital stay also comparable with the other studies. And stone-free rate also looks comparable to others, but slightly higher than others because of the high selection of the patient. If we see complication risk, this is also comparable with these studies. The complication from the RIRS ranges from 0 to 25%, and most of them are minor. Major complications are uncommon. In our study, grade 3 ureteric injury occurred in 1 case because it was not pre-stented and calculus was impacted at pugae, and in situ fragmentation was done for anterior stenting. 4 of our cases had sepsis within the first week of surgery, and they required early stent removal, and they improved. Ureteric perforation has been reported up to 10% of the cases. In our study, 1 case has ureteric perforation, which counts around 2.5%. And those patients, 6 patients who has residual fragments, they did not want the second procedure, and they opted for the conservative approach. And next month, 2 of them has passed their stones. So this study do have some limitation because it is the sample size is small, single center study, and cases were highly selected. So we can conclude that RIRS is an effective procedure for stone disease, and it is safe with acceptable morbidity, and we recommend larger study with multi-center. Thank you. Happy New Year.
Thank you, Dr. Deepak Thakur. I call upon Dr. Rabin Basnet to present his paper, Testicular Sperm Extraction in Subfertile Male.
Good afternoon, respected chairpersons, colleagues, and dear friends. Deviating a little bit from our regular conventional urology, I'm going to present my experience on testicular sperm extraction in subfertile population. A male person is considered a male patient is considered infertile if he has no evidence of viable spermatozoa in any part of his testis. This affects around 1 in every 20 person in his lifetime. It may be primary subfertility or secondary subfertility. It occurs in around 1 in 20 persons. And I'm quoting this from Hers et al. This is the most quoted sentence in any literature on subfertility. A couple with subfertility of longer than 3 years or with a non-reversible form of soft fertility is unlikely to conceive spontaneously and should be advised for assisted conception. Testicular biopsy was one of the investigative modality before ICSI was popular, ICSI was introduced. But now, after the introduction of ICSI, intracytoplasmic sperm injection, it is one of the diagnostic and it is one of the methods to yield a viable spermatozoa directly from the testis. The indications for sperm retrieval for ICSI are obstructive oospermia. It may be congenital, it may be absence of the vas deferens, or it may be traumatic, or it could be iatrogenic, or it could be due to vasectomy, or non-obstructive causes of spermatozoa, where there is evidence of spermatogenesis on testicular biopsy. In this experience, I've gathered 50 consecutive testicular sperm retrieval techniques done at Nepal International Fertility and Laparoscopy Center between January 2016 and August 2019. In this, males with either primary or secondary soft fertility were taken with documentation of oospermia on at least 2 consecutive sperm analysis. And along with the male clinical examination, we did not miss the gonadal development examination, secondary sexual characteristic, and hormonal evaluation. And after the couple were taken off for ICSI, while the female was being prepared for oocyte retrieval, 1 week before the procedure of TESA or TESE, again final confirmation of oospermia was done with centrifugation at 1200 rotations per minute of ejaculation for 10 minutes, and the pellet was examined meticulously at 400 times magnification. And if there was no evidence of viable, if there was any evidence of viable spermatozoa at that time also, we took that for ICSI. Or if there was no evidence of any viable spermatozoa, the couple was prepared for ICSI. And during this period, the female was also being prepared for oocyte retrieval. Both the procedure, oocyte retrieval and TESA or TESE, were done at the same time, not to waste the oocyte. If the male does not have any evidence of spermatozoa, the couple were counseled that we could use donor insemination also, so not to waste the oocyte. So during this procedure, first we went for testicular sperm aspiration. This was done under local anesthesia. Around 3 ml of lignocaine, plain lignocaine, was injected into the spermatic cord, and 1 ml wheel was made at the site of puncture, and a butterfly 18 gauge needle butterfly was used to puncture the testis, directing towards the center of the testis, and it was aspirated with a 5 ml syringe, which was pre-filled with it was aspirated with 3 ml syringe pre-filled with human amniotic fluid reagent. And then as we are aspirating, we also directed the needle towards different poles, because spermatogenesis is not homogeneous throughout the testis. There can be focal spermatogenesis in different parts of the testis. So not to miss any part, we aspirated at different poles also. And as we can see in this video, this video is a specimen of a TESA after the tissue or the fluid was extracted. It was examined under 400 times multiplication, and in this video you can see lots of spermatozoa, mature, immature swimming. We selected the mature spermatozoa meticulously, and if there was no evidence of spermatozoa, then we went for testicular sperm extraction at the same sitting. For this, we injected another 5 ml of syringe at the 5 ml of lignocaine at the site of incision. We made a incision, vertical incision towards the testis, dissected the different planes of the scrotum, and when we reached the tunica albuginea, we made 3 different incisions, 0.5 mm incisions at upper pole, middle pole, and lower pole. Testes were squeezed, and the seminiferous tubules were squeezed out, and it was taken and again examined under microscope for evidence of any spermatozoa, any viable spermatozoa was then collected. So during this 3 years, we had a total of 50 patients with soft forms of soft fertility. Out of this 50, 38 were primary soft fertility and 12 were secondary soft fertility. We subjected them to testicular sperm aspiration initially, out of which 66% revealed spermatozoa, 17 did not reveal spermatozoa. They were again taken for, out of this 17, 15 were taken for TSA, 2 did not consent. Out of 15, 8 patients sperm was retrieved, and when out of the 7 where sperm was not retrieved, 2 did not consent, and 5 went for donor insemination. So we had a total of positive outcome in 41 patients. Out of the 41, and when the sperm was retrieved, we did a ICSI and made 3 to 5 embryos per patient, at least 3 to 5. And if excess of embryo was present, we have the facility of freezing the embryos for future use, or excess of spermatozoa also can be freezed for future use. So out of the 41 patients in 50 were subjected to ICSI from either fresh or frozen embryo transfer, out of which 32 were positive. Positive means positive pregnancy. And out of the 32, 30 delivered. And out of the 9 patients who were negative, 7, they were again given a second chance with frozen embryo, out of which 7 became pregnancy positive, out of which 5 delivered. And out of the patients with negative TSA, we went for donor insemination. 2 went for donor intracytoplasmic sperm injection, and both of them delivered. So the summary of this presentation is soft fertility is not the end, and testicular sperm aspiration is a technically easy, quick, safe, and cheap method of sperm retrieval. And if it cannot be, if viable spermatozoa cannot be taken out from that also, testicular sperm extraction is also another safe and quite an easy adjunct to TSA. Thank you.
Thank you, Dr. Robin, for your excellent presentation on important topics. Now I invite Dr. Prakash Chetri. He will be talking on buccal mucosal graft harvested under local anesthesia. Dr. Prakash, please.
Good afternoon. At the outset, I would like to thank NOUNS for offering me an opportunity to present on this topic, buccal mucosal graft harvest under local anesthesia. Since more than last 2 decades, buccal mucosa has been so friendly among the urethral reconstructive surgeons that it is considered as a versatile urethral substitute due to its inherited advantages, like it is easily accessible, it has thick epithelium and thin laminar propria, concealed donor sites, and so on. Usually, buccal mucosa is harvested under general anesthesia with a nasotracheal or orotracheal intubations. Graft is designed and infiltration for lignocaine Johnson is done. Margin is raised, the graft is then dissected in the plane between the mucosa and the muscle. The donor area is left open or closed primarily if the defect is small. So what made us to harvest it under local anesthesia? In some scenarios where intra-op augmentation was required for other types of uretroplasties performed in spinal anesthesia. So the objective of our study is to compare the outcomes of buccal mucosal graft harvested under local and general anesthesia. This observational study was conducted in the Department of Urology in NAMS Bill Hospital and Department of Surgery, Pokhara Academy of Health Sciences within the period of 28 months. consent was taken. The following patients were not opted for harvest under local anesthesia. These are the patients who did not consent to the procedure: pediatric patients, previous BMJ harvested patients on the epilateral site, and uncooperative patients. Exposed, and the same team proceeded to harvest buccal mucosa under local anesthesia. Patient was kept to mouth, his mouth as wide as possible. Swallowing of the saliva and secretion was acceptable whenever required, and the further steps was similar as previously described. Cold liquid diet was started after 4 hours of surgery. Analgesic was given in injectable form of paracetamol and ketorolac. Oral gauze pack was removed on the next morning, and the VAS score was recorded just before the pack removal. Data was analyzed on demographic parameters, stricture site, ease on maintaining the mouth open during the graft harvest by the patient, graft properties, VAS score, and perioperative complications. On analysis, 14 cases of local anesthesia with 37 cases in general anesthesia. The mean age was older in local anesthesia group. Bulbar urethra was the most frequently involved segment, and 3 cases were performed bilaterally in local anesthesia. Mouth wide open during the procedure, and the median VAS score was similar in both the groups. Who first recommended nasotracheal intubation, which later shifted to orotracheal. The main demerits of the graft harvest under general anesthesia is the need of mouth retractor, which causes sustained strain on the muscle of the jaw, contributing to the postoperative pain. The surgeon needs frequent manual repositioning of the head, and there is always possibility of neck hyperextension and the aspiration of the oral secretions or blood. And these demerits are abolished when performed under local anesthesia, and it is suitable for those contraindicated for general anesthesia in the period of 8 years. Graft harvest under local anesthesia is comfortable with older age group usually, and the youngest age in the literature was of 12 years by Goel et al. Was 8 centimeter, and by Azape et al. Was 10 centimeter. Goel et al. Had a larger series of bilateral grafts. The ease on maintaining to keep the mouth open during the harvest entirely depends upon the size of the graft to be taken and the oral anatomy. And none of our patients had difficulty, and the similar results were observed in the literature. None of our patients and in the literature had severe pain during the procedure or on the first postoperative period. Our patients had difficulty on opening the mouth fully at 2 weeks of period. It is non-randomized study, and we are biased for small strictures and older ages. At last, I want to conclude by saying that buccal mucosal graft harvest and local anesthesia is feasible unilaterally or bilaterally. It is safe with minimal or comparable perioperative complications. It is acceptable in all age groups and viable options whenever required. I am always thankful to my gurus. Thank you.
Thank you, Dr. Prakash Chetri. Even you have included one female case, which is really very, very interesting, because most of the time we know that we deal with male urethra. Thank you. I call upon Dr. Lee Chin Yoon to present his paper. Doctor from Malaysia. Dr. Lee, are you ready?
Very good morning to all the panelists. I'm Lee. I'm urology trainee from Hospital Tengku Ampuan Afsan, Kuantan, Malaysia. It's been my greatest pleasure to be able to present my study on this prestigious conference organized by Nepal Associations of Urological Surgeons 2021. Today, I would like to share my study findings on reconstructive surgeries for pineal paraphenoma from a single-center experience in Kuantan, Malaysia. Malaysia is a small country that located at the Southeast Asia in between Thailand, Singapore, and Indonesia. Where you might notice is the KLCC Twin Towers, which is one of the tallest buildings by objective, materials and methods, results. Last but not least will be the discussions and conclusion. So, most of the patients receive the pineal injections of foreign materials with the intentions of pineal augmentations. These complications occur as a result of atypical tissue proliferations and infection caused by the interactions of the foreign substance with the human tissue. Nowadays, pineal reconstructive surgeries are still the mainstay of treatments for the management of pineal paraphenoma. Our single-center experience. Over the 4 years experience, a retrospective review was carried out in 16 patients who underwent 3 different surgical techniques for the corrections of pineal paraphenoma. All of these surgical procedures performed at Hospital Tengku Ampuan Afsan. All demographic statistics, details of the surgical procedures, and post-op outcomes were collected. Written consents were also obtained from them who had their photograph taken. So here are the 3 reconstructive techniques. First is the simple primary excisions and suturings. Second is the excisions of the circumferential granuloma with bilateral scrotal skin flap reconstructions in 1 stage. The last is the excisions of the circumferential granuloma and bilateral scrotal skin flap, but we are doing this in 2 stages indeed. So from the result, we can see that Malay is the predominant race of patients, which is correspond to the majority race populations in Malaysia. Mean age of patients were 33 years old, and the mean durations of injection to the presentations was 4.8 years. And most common complaints by the patients with pineal paraphenoma were painful erections and inability to perform sexual intercourse. And 2 out of the 16 patients had a biopsy done prior to surgery with the suspicious malignant features of the pineal ulcers, like shown in the photo at the right. So we talk about the first technique. It's the simple primary excisions and suturing, and this technique only applicable for the patients with a focal mass over the penis. First, the granuloma get excised together with the overlying skin. Subsequently, the lateral edges of the wound get approximated using interrupted absorbable sutures like Vicryl, and this result would result a circumferential scar like, and also the longitudinal scar like shows in the photos at the right. By using these techniques, only 5 out of 16 patients underwent this procedure. This is because all of them only got the focal mass, and they all satisfied with the sexual performance. This will be the second technique. This is the excisions of the circumferential paraphenoma with bilateral scrotal skin flap reconstruction in 1 stage. First, after we excise the circumferential paraphenoma surrounding the penis, this must be done meticulously by preserving the superficial fascia of the corpus spongiosum and corpus cavernosum. After we excise the mass, it will show like the photo 1. Subsequently, the length of the penis must be measured together with the pineal circumferential length. The measurement would be applied to the scrotal skin like shown in photo 2, in which we draw a square shape. Subsequently, the scrotal skin square shapes would be excised like shows in the photo 3 with a bridge that shows in here. Subsequently, we bring the square shape of the scrotal skin towards the penis and wrapping it like shown in the photo 4. There will be some of the skin remain intact over the inferior aspect over the square shape of the scrotal skin. We call this as a bridge. Subsequently, the edges of the windpiece suture using interrupted suture over the dorsal aspect of the penis, like shown in the photograph number 5. Subsequently, we close up all the edges of the wound, paraphenoma extended until the base of the penis. The mean duration of these operations was 286 minutes. Otherwise, they had no major complications and none of them underwent wound revision. Despite with a good surgical outcome, all of the patients had a neopenile skin edemas. Otherwise, all of them satisfied with the outcome with a good sexual performance with the in 2 stages. So the first stages is the excisions of the paraphenoma. Subsequently, we buried the penis into the scrotal skin, like shown in the photo A. 3 months durations being given for the wound healing. So for the second stage of the surgery, first, we make the zigzag incisions over the lateral aspect of the penis, like shown in the photo B. Subsequently, the edges of the wound being approximately over the ventral aspect of the penis, like shown in the photograph C. Subsequently, after we close out the remaining edges of the wound, it would be shown like the photo D. Only 2 patients underwent this procedure, and 2 of them also performed under combined spinal epidural anesthesia. This is because one of the patients, whereas the second procedure required around 270 minutes. Both of them experienced superficial wound dehiscence. Otherwise, 2 of them also satisfied with the surgical outcomes. For the discussions, highest incidence of paraphenoma has been reported in Thailand. And for our study, most of the patients also received the injection from Thailand as well. Only 5 patients had the focal mass, either over dorsal or ventrally of the penis, and all of them just underwent patients of the circumferential granuloma. Intact sensations and faster healings of this bilateral scrotal skin flap comparing to the split skin grafting provides a better surgical outcomes. Otherwise, all patients post-op recover well with a satisfactory sexual performance. In conclusions, excellent outcomes were observed by doing reconstructive surgeries to patients with paraphenoma, and simple excision biopsy and suturing are adequate for focal mass, whereas the reconstructive surgery using this bilateral scrotal skin flap is the best options after the excisions of circumferential mass. Thank you for your attention.
One of the promises when we take the Hippocratic Oath is to first do no harm. Every weapon in a surgeon's armamentarium is double-edged, and every cure has a potential harm. Renal calcular disease, preservation of renal function is of paramount importance, especially in view of its potential for recurrence. Percutaneous nephrolithotomy, the most commonly done procedure for upper tract calculi of more than 2 cm, is actually inflicting a grade 4 renal injury with the perceived drawback of its deleterious effect on renal function. Short and long-term effects of PCNL have been studied in detail. However, acute kidney injury, which has an incidence of 6.7 to 38.2% and an associated mortality of 23%, has been least discussed and studied. So, with an objective to study the incidence, risk factors, and outcomes of AKI post-PCNL, this prospective observational single-center study was conducted on 517 patients who underwent PCNL within the study period. Patients with preoperative AKI and CKD were excluded. The variables studied included patient demographics, stone characterization by CT, intraoperative details, postoperative complications classified as per the modified Clavin-Dendo system, with serial creatinine monitoring at 12, 24, and 48 hours, and a clinical review at 1 month. Patients who developed postoperative AKI were followed up with serial creatinine values up to 1 year. 47 of the 509 patients developed postoperative AKI, older age group, presence of comorbidities like hypertension and diabetes mellitus, preoperative use of ACE inhibitors and ARBs were significant risk factors for postoperative AKI. A low preoperative hemoglobin, altered coagulation profile, a raised serum uric acid and total leukocyte count also contributed to postoperative AKI. The cohort of patients who developed AKI were found to have a significantly higher stone volume and density and were commonly seen with staghorn stones. A larger tract size, multiple punctures, and longer operative time also increase the risk of AKI. In a multivariable logistic regression analysis, the factors significantly associated with postoperative AKI were male gender, high BMI, preoperative use of ACE inhibitors, an elevated serum uric acid, and a supracostal puncture. On ROC curve analysis, an age of more than 39.5 years, serum uric acid of more than 4.05 milligram per deciliter, and a stone volume of more than 673 millimeter cube were our calculated cutoffs with a high sensitivity to predict postoperative AKI. The various patient factors, stone factors, and operative factors contributed to postoperative AKI in 9.2% patients in our study, which is comparable to world literature. Possible explanation in elderly patients could be due to reduced plasma volume and cardiac changes leading to intraoperative hypotension and renal hypoperfusion. Alteration of the renin-angiotensin system due to use of ACE inhibitors and ARBs is a known predisposing factor for renal hypoperfusion. Raised serum uric acid levels causes activation of the pro-inflammatory cascade, which leads to endothelial dysfunction, causing renal vasoconstriction. Preoperative leukocytosis leading to AKI may be explained by the effect of inflammatory mediators on microcirculation. However, there is scarcity of literature evidence explaining the correlation of low hemoglobin to AKI. A high stone volume, density, and staghorn calculi increase the complexity of the procedure and operative time with increased risk of postoperative bleeding and infective complications leading to postoperative AKI. Although no morphological or functional decline by imaging and nuclear studies at the access site has been studied, it can be well interpreted that multiple tracts and a larger tract size causes cellular injury and significant nephron damage. Among the 9.2% patients developing postoperative AKI, the mean length of hospital stay was not increased due to lack of clinical deterioration in majority, although 3 patients required 2 sessions of hemodialysis. Among the AKI cohort, serum creatinine was significantly higher by 0.249 milligram per deciliter at 1 year as compared to postoperative values, and 8 patients progressed to CKD at 1 year. AKI post-PCNL is least discussed yet not uncommon, although its correctable causes and risk factors can be easily identified and managed to prevent this potentially grave complication. Further studies are required to corroborate our findings and cutoff values. I would
come to the end.
Presenting. Impact of multiple renal vessels on graft function in laparoscopic live donor nephrectomy. Kidneys with multiple vessels are quite common in renal donors, and such kidneys are generally not considered for donor nephrectomy due to complexity in procurement and dubious graft outcomes. But many studies have compared the graft outcomes following laparoscopic donor nephrectomy in single multiple renal artery groups and concluded that the graft outcomes and complications are similar in both groups. However, most of them include only multiple renal arteries, and recipient parameters were less extensively studied. Only 2 studies so far have included multiple renal veins along with arteries. Laparoscopic live donor nephrectomy in multiple renal vessels is still technically challenging, and apprehensions regarding the prolonged ischemia time, operative times, and increased risk of complications still exists. Till now, no studies from South India assessing the impact of multiple renal vessels on graft function laparoscopic renal transplantation. And in the present study, we extensively evaluate our experience with laparoscopic live donor nephrectomy in patients with multiple renal vessels. A primary objective was to study the impact of multiple renal vessels on graft function in terms of immediate, slow, and delayed graft function. And secondary, to study and compare the operative outcomes in recipients of multiple and single vessel groups in terms of total ischemia time, creatinine levels, early complications, and length of hospital stay. Ours is a prospective observational study, and all consecutive patients evaluated and admitted by Department of Nephrology and Urology for laparoscopic live donor-related transplantation between October 2018 and April 2020 were included, and all pediatric transplants and recipients of poor graft function due to non-surgical causes and patients unwilling to participate were excluded. Preoperatively, the arterial anatomy was delineated by 320 slice CT angiogram. All patients underwent standard laparoscopic right and left donor nephrectomy. When multiple arteries were encountered, attempt to preserve all arteries were done, and 2 veins were encountered. The smaller vein was sacrificed, and if both veins were of equal caliber, both were retrieved for separate anastomosis. In case of early branching artery, were either retrieved as common stump or retrieved as 2 arteries. These are some of our intraoperative findings. Standard recipient technique was followed. When 2 renal veins and arteries were encountered, both were anastomosed individually to the external iliac vein, external iliac artery, respectively end-to side. And when 3 renal arteries were encountered, the smallest third artery was anastomosed end-to side to the main renal artery, and the 2 were anastomosed to the external iliac artery, end-to side. Ours is a single recipient surgeon and single donor surgeon study. 5-3 without the need for hemodialysis, and in the absence of both, it is defined as immediate graft function. These are the statistical methods followed, and all p values less than 0.05 were considered as statistically significant. A total of 117 patients were included in the study, and among them 41 patients were recipients of multiple vessels. The graft function among the multiple vessel group, we observed that the 38 patients had immediate graft function, and 3 cases had slow graft function, and no cases of delayed graft function. However, the 3 cases of slow graft function, the creatinine normalized at 3 months and continued to remain stable till 1 year. This table shows the distribution of vessels. Among the multiple vessel groups, we commonly encountered 2 artery and 1 vein, followed by more than equal to 3 artery and 1 vein. We encountered 9 cases of early branching arteries, and among them, 7 were retrieved with the common stump, and 2 were retrieved as double arteries. We encountered 10 cases of multiple veins, and among them, 4 were retrieved as single vein, and 6 were retrieved as double veins. We did not find any statistically significant difference in the outcomes in terms of graft function among the single vessel and the multiple vessel group. On comparison of the outcomes, the estimated blood loss was significantly higher in the multiple vessel group. The total ischemia time and the total operative time were also significantly higher in the multiple vessel group. Despite these, the postoperative creatinine values remain stable and comparable between both groups and continue to remain stable till 1 year. The grade-wise complications were also comparable between both groups. These are some of the standard validated studies we use to compare our results. We observed that in our study, the graph function was significantly better. We encountered only the 3 cases of slow graph function and no cases of delayed graph function. Postoperative creatinine was comparable between all studies. Since most studies use complications as only arterial and ureteral complications, we encountered only 1 ureteral complications, but we could not find any data to compare the operative time, the total blood loss, as well as the ischemia times. Based on our observations, we conclude that the complex vascular anatomy should not be considered as a contraindication to laparoscopic donor nephrectomy, nor does it influence the choice of laterality in donors. Recipients of allograft with multiple vessels experience longer ischemia times, increased operative times, but in terms of early graft functions and propensity for arterial and ureteral complications, it is similar to the single vessel groups. It is critical to understand the anatomical variations as laparoscopic live donor nephrectomy is technically challenging compared to open nephrectomy. Expanding the use of laparoscopy to these cases will increase the donor pool for living donor renal transplantation. However, donor safety should not be compromised at any point and should not hesitate to convert to open surgery. These are our limitations. Thank you.
Thank you, Dr. Sanjay, for your nice presentation. Now we conclude this plenary session. Back to the conveners. Thank you. Thank you all the speakers once again. Thank you.
Thank you, sir, for chairing the session. Now we are moving towards a resident prize session. In order to motivate or encourage the residents in presentation, scientific presentation, we are having this session. We have total of 6 papers. And in order to conduct this session, I would like to request my friend, Dr. Anil Shrestha, Dr. Bhojraj Luitel to chair the session. And in the meantime, Dr. Rikesh Jang Karki from BPKHS Dharan, he is joining with us through the Zoom. Hello, Dr. Rikesh. Are you there? Please, Dr. Anil and Bhojraj, kindly start the session. Thank you.
Thank you, Ghanshyam. So, to start this session, I would like to start from the first paper by Divas Ghewali from TUTH. Dr. Divas.
Respected chairpersons, my seniors and colleagues. Today I am going to present on the comparison of STOR's professional image enhancement system Spectra A mode versus white light in the detection of carcinoma urinary bladder. Coming to the introduction, bladder cancer is one of the most common urinary bladder cancer, and it is the 7th most common cancer in Nepal. And it is usually present in the elderly with hematuria as a common presentation. And around 2/3 are present in the non-muscle invasive bladder cancer, and most of the early recurrences are in fact overlooked or the residual tumors. And small or papillary tumors or flat CIS lesions may not be properly visualized during the white light cystoscopy, and yet incomplete resection may lead to the substantial increase in the early recurrences. And narrowband imaging, which filters the red light and the blue and green light is filtered, passed to the tissue, which creates the better contrast with the surface, so for the better visualization. And Spectra A also has the capacity of filtering red light at the console level, at the image capture, the image capture in, uses the same principle and causes the better tissue visualization. And significant number of the patients who had early recurrences might have been missed in the TURBT. Other studies which have used the narrowband imaging had shown the superior results. And the Spectra A mode has not been studied in the bladder cancer up to our knowledge and does not require dye for tissue visualization. And General objective is to compare the detection rate of the carcinoma urinary bladder using professional image enhancement system spectra A with the white light only. And these are my other primary and secondary objectives. And it was single center prospective observational study of 1 year duration at TUTH IOM. And inclusion criteria were all patients undergoing the TUIBT for suspected urinary bladder tumors based on the imaging and or white light cystoscopy. And exclusion criteria were inadequate vision due to bleeding, or a termination of the procedure due to complication or consent withdrawal. And sample size was calculated by this formula. And coming to the methodology, the patient with suspected bladder cancer were approached for the enrollment and assessed for eligibility. Then they were planned for TUIBT. And at the time of TUIBT, the white light cystoscopy was done, and findings were noted in the bladder diagram, and Kolka biopsy of small lesions were done. And then it was changed to the spectra A mode, and then extra finding noted were included in the bladder diagram, and the Kolka biopsy of small lesions were done. Then again it was changed back to white light, and the TURBT was completed and tissue were retrieved. And finally it was changed to the spectra A mode to see any remaining tissue or for the margin status, and the histopathology was changed separately and were analyzed. Analysis was done by the SPSS with the tumor detection rate, positive histology rate, false positive and false negative rates were calculated, and comparison was done by the McNamara chi-square test. And coming to the results, among the 90% approached for the study, 64 were included in the study due to the various reasons. And the white light cystoscopy showed the 145 lesions, whereas the spectra A mode has shown visualized the 184 lesions. And coming to the patient characteristics, most of the patients were elderly with mean age of 62, with male being predominant, with most of the patients having the multiple tumors. And coming to the detection by the spectra A mode, had the higher rate of the detection, around 95%, and in the PTA and T1 lesions. And while comparing the both white light and spectra A, the spectra A had the better advantage on the tumor detection lesion, total number of biopsy proven lesions, and the missed lesions, whereas the white light had the better advantage on the false positive rate and the percentage of positive biopsy among the detected lesions. And on the additional lesions detection, the spectra A was seen to be the better, and which also diagnosed the few CIS lesions as well. And on the detection of suspicious margins, 7 lesions were detected, out of which the 3 were proven to be the malignant. Coming to the discussion, variable evidences are available for different methods of enhancing detection of carcinoma urinary bladder, and use of spectra A has not been done to study bladder cancer so far up to our knowledge, but many studies which have used the NVI using the same principle have shown the better results. And while comparing our study on the tumor detection rate, and it was comparable to with other authors which had the higher rate of tumor detection of more than 95%. And coming to the additional tumor detection also, the higher sensitivity that led to the higher rate of the additional tumor detection rate, and which is quite comparable to the other studies. And false positive rate may be higher due to the higher sensitivity of the test, and which is also equivalent to other studies done by the various authors. And limitations of our study was the cystoscopy and resection were done by the multiple surgeons, and we have included the T2 lesions, which might have influenced some overall results of our study. And coming to the conclusion, spectra A has a higher detection rate, whereas the white light demonstrates the higher percentage of the positive histology in the detected bladder cancer. So if we can combine the both methods if available, then it can increase in the detection of the bladder cancer. Thank you.
I think it's we don't have question answer in this session. So Rosas.
Next, I would like to call upon Dr. Anil Pukar Saha. Anil Pukar, no? Anil Kumar Saha, sorry, Anil Kumar Saha, Nepal Medicity Hospital, FCPS resident, to give a presentation on comparative survival analysis of cytoreductive nephrectomy in metastatic RCC treated with targeted therapy at BP Koirala Memorial Cancer Hospital, Nepal. Dr. Ali.
Currently posted for uro-oncology rotation at BPK MCH. For another couple of minutes, we'll be centered on the discussion of our study, 5-year survival analysis of metastatic RCC patients treated with targeted therapy at our center. Renal cell carcinoma, which is 9th most common carcinoma in men and 14th most common carcinoma in women. According to UROCON 2018 data, there were 4 lakhs new cases in 2018 only. Male and female ratio worldwide is 1.7:1, and incidence of metastatic RCC accounts about 15 to 22%. The objectives of our study was to assess the demographic profile of metastatic RCC patient who received targeted therapy, to assess the overall survival analysis of metastatic RCC patient on targeted therapy, and to compare the difference in survival among metastatic RCC patient who received cytoreductive nephrectomy with sunitinib versus sunitinib only. It was a retrospective study at our center, and the patients of metastatic RCC treated with sunitinib were taken, included in our study from Jan 2007 to August 2014. And there were 2 arms, nephrectomy. Those patients underwent nephrectomy and later on started with sunitinib within 3 months, and sunitinib only. And sunitinib should have been given for at least 1 month. Those patients receiving any other systemic therapy, and those who had cytoreductive nephrectomy after the start of targeted therapy, and those who had intrinsic resistance to the targeted agent were excluded from our study. A statistical analysis of categorical variables like frequency, continuous variables such as median were analyzed, and survival curves and their differences were analyzed by Kaplan-Meier curve and log rank test. Data were found statistically significant when two-sided p-value were less than 0.05, and all the analyses were done on version 2 SPSS. We had 101 patients initially, out of which 29 patients excluded due to incomplete data, and 18 patients who had a history of prior nephrectomy were also excluded. So finally, we had 54 cases only. There are 218 patients who had been getting sunitinib, and the data of those patients are in pipeline. We started sunitinib therapy in 2007, and we can see here the number of the patients getting sunitinib therapy is increasing gradually as the year increases. Majority of the patients falls in between 50 to 69 years of age, and majority were male, that were 72%, and majority were Hindu, married, and literate, and farmer by their profession. Lung, liver, bone, and the lymph nodes were common sites for the metastasis, and only 31% of the patients had underwent cytoreductive nephrectomy before starting sunitinib therapy. Clear cell carcinoma was found the commonest pathology. So coming to the overall survival of our patient, the average was 12.29 months with 2.35 months of a standard deviation, and with a median value of 6 months. As we separated the metastatic RCC treated with only sunitinib, where the mean overall survival was 7.9 months in comparison with those who had underwent cytoreductive nephrectomy before, had 21.5 to 9 months, and the data shows there is significant difference in between 2 arms. So coming to the discussion, targeted therapy may be different for each patient, and the matter of the concern is whether does it improve the quality of life or not. For the active site of the disease, medical treatment aims to shrink the disease, surgical treatment aims to remove, and ablative treatment aims to destroy it locally. For patients with multiple site disease, the mainstay of the treatment has been systemic therapy. Before starting any systemic therapy, we need to stratify the risk of the patient on the basis of MSKCC and IMDC criteria. And unfortunately, we could not categorize the risk basis of our patient on these 2 criteria. According to STRAC trial, which was a randomized double-blind phase 3 trial, it has 2 arms. one getting sunitinib and another getting placebo, showed longer disease-free survival that was 6.8 years versus 5.6 years, which was significantly different. Whereas the ASSURE trial doesn't support the finding of the EXTRACT trial, and it has the data were randomized in 3 arms, sunitinib, sorafenib, and the placebo, and the overall survival was 5.8 years versus 6.1 years versus 6.6 years, respectively, which were not significantly different. Does the nephrectomy has any benefit on survival in metastatic RCC? And according to SWOG and URTC trial, the median survival were 11 versus 8 months and 17 versus 7 months respectively, and it has positive suggestion. According to Heng et al., those who had underwent cytoreductive nephrectomy before had better survival in comparison with those who had not. And Carmina trial also suggests the same finding. What does EU 2021 recommends? It recommends immune checkpoint inhibitors as a standard of care and sunitinib as alternative in patients. So the limitation of our study was recurrence-free survival and progression-free survival not evaluated, MSKCC and Heng mode of risk stratification not done, prognostic factors not evaluated, and other modalities of the systemic therapy were also not evaluated. So concluding my topic today, my take-home message is treatment of the kidney cancer is getting more complex. Care includes multimodality treatment, targeted therapy, immunotherapy have proven benefit in metastatic RCC and definitely improve the survival. Surgery should be offered to the patient with favorable risk category. Thank you.
Patient in renal transplant recipient lymphatic complication or randomized control trial. Islet vessels are covered with dense lymphatic channels, and these lymphatics need to be cleared from the surface of the vessel before vessel anastomosis during renal transplantation. Inadequate ligation of these lymphatics leads to lymphatic complication. Lymphatic complication may include lymphobia or lymphocyte. Bipolar vessel sealing system denatured protein and connective tissue, and that forms seal and fuse and obliterate the lumen. Ligation of these small lymphatic vessels with silk is not always possible. That can be managed easily with bipolar vessel sealing system. The general objective of the study was to compare the post-renal transplant lymphatic complication between bipolar vessel sealing system and silk ligation of lymphatic vessel. Specific objectives were to compare the total amount of drain volume, to compare the duration of drain placement, to compare the incidence of lymphocyte formation, and to analyze the risk factors of lymphatic complications. It was the prospective single-center, single-blinded, randomized control study. The study population were the end-stage renal disease patients undergoing renal transplantation surgery. The study was conducted in Department of Urology and Kidney Transplant Surgery at UTS. The study duration was of 1 year. After approval from ethical committee, the trial was registered in Trial Registry System of Japan. Informed consent was taken from the patients, and data collection was collected based on pro forma. All patients undergoing renal transplantation were taken for the study. The exclusion criteria were urine leak, urinary formation, retroperitoneal hemorrhage, re-exploration, or mortality within 3 months duration. By using this formula, the sample size was calculated to be 68. Patients meeting the inclusion criteria and consenting for the participation were enrolled in the study. Block randomization was done, and the surgeons informed before surgery regarding the treatment allocation. In donor nephrectomy, after perihilar lymphatic ligation was done using silk physio on back table before renal transplantation. In renal transplantation, in the silk ligation group, lymphatic tissue were ligated using silk physio, while in bipolar group, in-seal bipolar vessel sealing system was used. In the left side, this is a UROCON endo-surgery generator, and in the right side, it is in-seal tissue sealer. Drain volume was measured daily during hospital stay, and the drain was removed when 24-hour drain volume was less than 50 ml. Significant lymphobia was defined as a drain lymph volume of greater than 50 ml after 5th postoperative day, while urine leak was defined as drain creatinine of greater than 3 times the serum creatinine. Follow-up ultrasound was done in 6 weeks and 3 months. Symptomatic lymphocyte was defined as lymphocyte with pain associated with graft dysfunction, swelling of the iliac fossa with the graft or ipsilateral pedal edema, whereas uvinoma was defined as the fluid with aspirated fluid with creatinine of greater than 3 times the serum creatinine. Data analysis was done with SPSS. Biobehavioral analysis was done using t-test, Mann-Whitney test, chi-square test, or Fisher exact test as appropriate. And the multivariate analysis was done using binary logistic regression. The p-value of less than 0.05 was considered statistically significant. Total of 72 patients were assessed for eligibility. After exclusion of 4 cases which were unfit for surgery, 68 patients were randomized into bipolar and silk group. Total of 6 patients were excluded in the bipolar group and total of 4 cases were excluded in the silk group. So total of 28 cases were analyzed in the bipolar group and 20 cases were analyzed in the silk group. The baseline characteristics between the two groups, bipolar and silk, were comparable between the two groups. The total drain volume, drain removal day, and the post-operative hospital stay were comparable between the bipolar and the silk. Also, significant lymphorrhea, symptomatic lymphocyl, and the lymphatic complications were comparable between the two groups. There was a total of 27.6% lymphatic complication, while it was 25% in the bipolar and 30% in the silk group. The univariate analysis of the risk factors of lymphatic complications were done. The risk factors included were recipient age in years, donor's age in years, sex of recipient, BMI of recipient, duration of dialysis, diabetic recipient, first one ischemia, number of renal arteries, lab versus open nephrectomy, lymphatic dissection, and graft rejection. Among these analyzed risk factors, number of renal arteries and the graft rejection were found to be significant risk factor for lymphatic complications. When these risk factors were analyzed with using multivariable analysis using binary logistic regression, number of renal arteries or graft rejection were not found to be the significant risk factor for lymphatic complication. Coming to the discussion, the overall lymphatic complication in our study was 27.5%, which was within the range as defined in the literature. While comparing with the similar studies, Simperes et al. Did the similar study in 2018, Lucan et al. In 2017, and the finding of Lucan et al. Was the total drain volume and the lymphatic complication decreased significantly by use of bipolar vessel sealing system. However, we couldn't find the similar findings. The lymphatic vessels have less smooth muscle and the limited clotting factors without thrombocytes. So it is recommended to involve heavy lymphatic tissue in the bipolar blades for effective sealing. The limitation of the study was it was single-centered study and the multiple surgeons were included in the study. So to conclude my study, this study did not find any significant difference in lymphatic complication between bipolar vessel sealing system and the silk ligation. However, large sample multicentric studies should be done to add evidence on lymphatic complication among these two groups. Thank you.
Thank you, Dr. Prem. Next, I would like to call on Dr. Vaikunta Adhikari from NAMS. Please go ahead.
Namaskar, myself Vaikunta Adhikari, a resident from Department of Urology, NAMS, Beer Hospital. Today I'm going to present on in situ partial relocation lithotripsy for low pole stones in RARS. RARS is the recommended treatment modality for the low pole stones, and especially for those stones with unfavorable low pole anatomy or shockwave lithotripsy. However, the stone-free rates in the low pole calyx is lower as compared to that in other locations. The limited deflectability of the scope after the passage of the laser fiber prevents the adequate access to the low pole and thus leads to inadequate visualization and inefficient lithotripsy. Spontaneous passage of the fragments is further hampered by the dependent position of the low pole calyx, and that is even compounded in those with unfavorable anatomy of the low pole calyx or the stone passage. Since relocation of these stones to the favorable calyx have been shown to other previous studies to mitigate the access these two problems, a study was conducted in our department to assess whether the relocation before the lithotripsy has any effect on stone clearance for low pole stones. Stones with less than 2 centimeters diameter in the low pole calyx were included, and there was a set of exclusion criteria. The groups are divided into two: in situ lithotripsy, where the fragmentation was done in the low pole calyx, and others are relocated to the favorable calyx, followed by the laser lithotripsy. A single surgeon performing more than 100 RIRS per year perform all the procedures. Ureteral access sheath placement was done. In those cases where ureteral access could not be placed, the procedure was done without the use of ureteral access sheath. The reusable Flex X2S 7.5 French the Carl stores was used for all the cases. The stones were relocated to the favorable calyx in using the nitinol tipless basket 2.2 French. And in those cases where a stone could not be relocated in one piece, the stone were fragmented and the individual fragments were relocated to the favorable calyx. Laser lithotripsy was done using the 120-watt laser with 200 micron laser fibers. Dusting and the pop dusting mode was used. In those cases where we need the fragmentation before the relocation of the fragments due to its large size, 1 joule 10 Hz and a short pulse settings was used. Disease stent was placed at the end and patient was discharged the next day, and they will call for follow-up at 2 weeks with X-ray KUB for disease stent removal, and at 4 weeks ultrasound abdomen and ultrasound and X-ray KUB was done to assess the stone free rate. There were 72 patients during the study period. However, 12 patients lost to follow-up, so only 60 patients were analyzed. The upper pole was the predominant location chosen for the relocation. In those cases where upper pole was unfavorable, the mid pole relocation to the mid pole was done in 7 cases. The patient demographics and the stone size and stone density were similar between the two groups. Operative duration, lesion duration, and energy used are similar between the two groups. Although there was a trend towards the mean operative duration longer in case of relocation group, however, there was not significantly significant. The overall stone free rate was 85.7% in the in situ lithotripsy group. It was 92% in the relocation followed by lithotripsy group, although it was not statistically significant. The stone free rate for the stones larger than 10 millimeters was higher in case of the relocation group, but it was not clinically significant. Low pole stones remain in challenging locations to assay to have a complete stone free rate. Unfavorable anatomy such as narrow infundibulopelvic angle less than 90 degrees, narrow infundibular width have been shown in some studies to be unfavorable factor for spontaneous stone passes. With the improvement in the scope design, laser machines, and accessories, the stone free rates are getting better. The availability of the single use scopes have mitigated the issue of durability of the scopes, and the better deflection available with the today's scope with the improved vision have led to the better stone free rates. Other ways that can be improved in clearance are the active extraction of the fragments and the relocations. But both these techniques require the skilled operator and the use of the accessories, which again adds to the cost issue of the already expensive modality. Relocation have been shown to improve visualization, and since the scope do not have to be placed a longer duration in a flex position in a lower pole, is increase the durability of the ureteroscope. And since the spontaneous passes of the fragments are facilitated by the relocations, better stone free rates can be achieved. Our stone free rates are comparable to that of the other studies. So to conclude, a prospective study done in our department shows that stone free rate can be improved with the relocation for low pole stones. However, a larger multi-centric studies is required to validate these results. Thank you and Happy New Year to all of you.
and respected faculties, ladies and gentlemen. Today I'm presenting on topic metabolic evaluation of high-risk stone formers, an analytical observational study which was done in our institute. To introduce, urinary tract stones are known for their recurrence. So why not to prevent the recurrence? So this is the question. And there are some group of patients which we can identify by history examination and their medical profile that they can form stones who are considered as a high-risk stone formers. So the main rationale of our study is to just diagnosing and treating single stone does not finishes the role of urologist. So correcting underlying problem can prevent the stone recurrences to some extent. So methodology, coming to methodology, this was a retrospective observational analytic study which was done over 6 months. And patient with multiple bilateral recurrent stones along with any high risk factor who gave consent were included after 20 days of at least 20 days of stone pre-interval. And all demographic profile and patient's history were taken, and the laboratory investigation included serum calcium, phosphorus, uric acid, urine microscopy and routine culture in selected cases, and urine pH. And a single 24-hour urinary oxalate, citrate, calcium, phosphate, uric acid, and creatinine were analyzed. And the different principle of measuring the different parameters with normal reference were set for comparison. And coming to the result, most of the patients were almost 60% were male, and my study included 46 total patients. And younger age group patient, which were below 50, and mean age was 35. That means younger age patient who had still long longevity. So that kind of group were there. So preventing consider some rational. And mean BMI was within normal limit. Males were predominant, and around 20% patient had family history. And serum calcium and phosphate were within normal range. And coming to the result, managed with different options. Almost 50% patient were managed with RIRS, followed by PCNL, and some patients require only observations. And coming to the indication of metabolic evaluation, multiple stones were the most common, followed by bilateral stones and recurrent stones. Coming to the comorbidities, hypertension and diabetes were notable, and was also accompanied by hypothyroidism. So metabolic common problem in our group of patients, which was compared with different study from Asia, from other countries of Asia and Europe and USA. And so there are different guidelines and there are different recommendations for patient to prevent the stones. So does that recommendation and guideline match to our group of patients? That is the main we need to find that question from this study. So we compared, and the most common was hyperoxaluria, so which was not so common in Western studies, which was followed by hypocetoturia. And another important finding in our patient was hypocalciuria actually, which was in other studies, hypercalciuria was one of the notable metabolic abnormality. So that is the that one of the finding which we may need to change in our group of patient while recommending. So this may be one of the study to suggest, and we need other further studies as well. And on discussion, oxalate was more on our study, which we compared with other study. However, citrate was also on lower side. Mean citrate was on lower side compared to other studies, and uric acid was within as par to the other studies. And the important finding was low calcium level. So to discuss the different metabolic abnormalities are detected across the world, maybe because of the dietary habit, the geographic effect, and metabolic evaluation can help in advising the preventing strategy. And we know that this is a retrospective observational study, so we need further studies, and this can be one of the study to suggest that our patient have different metabolic profiles. Thank you. And these are my references.
Thank you, Dr. Purushottam. Next, I would like to call upon Dr. Vinod Babu Garti for his presentation. Dr. Vinod, please, from NAMS.
Good afternoon, respected chairperson, senior faculties, and delegates. I'd like to thank NAUS for providing the opportunity to present this clinical research paper in this auspicious forum. We started a study in Beer Hospital regarding comparison between simple and classical techniques of varus needle insertion to create new operating, since we are getting larger number of laparoscopic cases in our department in the last few years. Laparoscopic surgery were indispensable part of urologic surgery for many diseases. The most initial and key step for developing the working space in the abdomen is carbon dioxide pneumoperitoneum, and for this there are mainly two methods, open and closed techniques. Today I'm going to talk about the closed technique regarding the varus needle insertion, and because my clinical research topic is on that. The closed technique, the classical one, is most of us are familiar with this technique, and there are various methods to confirm this. And simple pneumoperitoneum technique is, as the name suggests, it is very simple. I'm going to describe it in detail in coming slides. The objective of my study is to compare classical and simple technique of creating pneumoperitoneum, closed pneumoperitoneum, and the parameters that I'm going to to compare these are time required for the pneumoperitoneum, associated injuries, and failure rate. This study is conducted in Department of Beer Hospital from 2019 July to 2021 March, a comparative observational study. The variables were time duration, creating the pneumoperitoneum, and injury associated and failure rate. Patient is admitted, and computer-generated randomization is done and allocated in each group. Sample size collected was 116, 53 in each group. Classical technique, we all are following, I guess, this classical technique for many years, so I'm not going in detail. But the simple technique is, this is quite new technique. Skin is stab, incision is given over the part where the needle is going to be inserted. A 5 ml syringe filled with normal saline without the plunger connected to the needle hub, and the lock status is maintained. The varus needle is inserted in till the muscle layer, and the lock is opened and further advanced into the peritoneal cavity. The loss of resistance. After the loss of resistance, there is free flow of the normal saline from the 5 ml syringe is noted. It's seen in the picture in this video. And this confirms the interperitoneal location of the varus needle tip, and carbon dioxide is connected. Then the pneumoperitoneum is created. Now going to the result part of my research regarding the demographic parameters, these are comparable in both of these groups regarding the gender, mean age, BMI, and we allocated randomly the previous abdominal surgery cases also in this group. Most of the indications for laparoscopic surgeries were for nephrectomies, unfortunately. The mean time for pneumoperitoneum creation we found was significantly lower in simple technique, but the complications rate as well as failure rate or failed pneumoperitoneum was negligible and none in the both group. Let's go to the discussion part. In total, 116 patients were included in our study, 2 patients excluded, and the significant difference was found only in the pneumoperitoneum time. So we can say that from this study, the simple technique of pneumoperitoneum creation is quite effective, safe, and comparable to the classical technique, and it is faster. Justin et al. 2004 published a paper and which established that there is less chance of visceral and vascular injury, which was thought to be dreadful and very life-threatening condition till that time. And these two authors were the one who introduced the simple technique of pneumoperitoneum, and they did 25 consecutive pneumoperitoneum without any difficulty. And Okhtara et al. In 2016 published a paper comparing this simple technique with the open technique, and they found that comparable result with the open technique, and the results were similar with our study also. In this paper, Chotai et al., they found that the time taken for the new operating creation is quite higher in the closed group, which was also quite higher than our study, but the complication rate is quite comparable in these papers and in our study group also. Mustak et al. Released a paper in 2019, and they found that the complication rate is quite comparable with open group, and the complication rate in this paper is comparable with our group also, and the time taken for the pneumoperitoneum is also comparable. So with all these results and discussion part, we can conclude that simple technique of creating closed pneumoperitoneum is quite easy, safe, faster, effective, and reproducible method. So for the beginners and for the novice surgeon, it is quite easy, safe, and fast. We can go for it, and the learning curve is not that much big. Thank you.
Behind the time, without delay, I like to hand over. I like to request the chairperson to conduct the session. Thank you.
Thank you, Dr. Hari and Dr. Sujit, as a convener of this session. I would like to take apology from all the panelists and participants that we are a bit delayed with our schedule, and to catch up this schedule, even we are continuing during our lunch time. I request all to continue your lunch, and now we will start the session. To have a brief introduction, we are very thankful to Urological Society of India and Indian Journal of Urology, especially the leaders of the Indian Journal of Urology. Dr. Rajiv Kumar is current chief editor in Indian Journal of Urology. I must take a name of Dr. Nitin Kekre, sir, to motivate us not only for the practice, but also to do simultaneous research. Research can be anything that your observation, your daily experience, we can document somehow in the paper so that your future progeny or the future generation surgeons will learn from you. So today I would like to welcome, I hope, Dr. Mohan Raj Sharma, Dr. Rajiv Kumar, and Dr. Apul Goel are on the virtual platform. So let us give a round of applause and welcome all our panelists. Thank you, sir. Thank you for being with us. On the first presenter is Dr. in this now's IJU session is Dr. Mohan Raj Sharma. Dr. Mohan is well known to us, and we don't need his further introduction. He is currently head of the department in Department of Neurosurgery at Tribhuvan University Teaching Hospital, Institute of Medicine. He is also chief editor of Journal of Institute of Medicine, Nepal, and he is very active in giving the training to the resident, and all of us must have taken some form of his training on the research methodology. He is the chief of Institutional Review Board of Institute of Medicine. So I would like to welcome Dr. Mohan Raj Sharma. Besides, he is an excellent and experienced neurosurgeon. He is also a very good researcher, and his interest has recently made him to publish a very good book that we all are very proud of that, and at least I have read twice. And I request all to go through his book because it is very small, very informative, and that gave you some idea and insight into the research methodology. Dr. Mohan Raj Sharma, please.
Everyone, first of all, I'd like to thank the organizing committee and Dr. Pawan Chalise, the Euro. No, म फेरि रिपिट गरेँ है यसमा यो युरोकोन 2021 हो है हजुर डाक्टर हो अनि यसमा चाहिँ अर्गनाइजिङ सेक्रेटरी हो डाक्टर पवन चालिसे हजुर अर्गनाइजिङ कमिटी एन्ड रिसर्च I would like to bring warm greetings to all of you on behalf of my colleagues and myself from Department of Neurosurgery and Department of Research from Tribhuvan University Teaching Hospital. The target population of obtaining a baseline information regarding a population. That is what the medical statistics interpretation do not need to know. The objective of my presentation today are as follows. The first and most important one is to inspire young surgeons / urologists to develop statistical thinking, which is data, statistics, and loss gathering. The topic I have chosen today for presentation is basic medical statistics, the path less traveled by the surgeon. I would like to bring warm greetings to all of you on behalf of my colleagues and myself from Department of Neurosurgery and Department of Research from Tribhuvan University Teaching Hospital. I have no conflict.
The slide is mismatched,
I would like to start my presentation with this important quotation. The deepest sin against the human mind is to believe things without evidence. So to get good evidence, a statistical concept is a must. And in the clinical subject, the knowledge of statistics and research methodology is less than optimal for many clinicians. So many neurosurgical journals have started to publish at least one article per issue on topics related to biostatistics and methodology for quite some time. And I believe that the same thing happens in urology literature too. The objective of my presentation today are as follows. The first and most important one is to inspire young surgeons / urologists to develop statistical thinking, which is so important these days. Next is learning the essential concept of medical statistics, especially p-value and confidence interval, which are needed for proposal writing, paper publication, and critically appraising the medical literature. What we do not need to know and what I'm not going to say today is how to do a statistical analysis. As a clinician, we are not required to do a complicated statistical analysis, but we need to know how to interpret the results written in the literature. How we define statistics. This is the definition by J.M. Lass. It is described as a science and art of dealing with variation in data through collection, classification, analysis, and interpretation in such a way as to obtain reliable results. And medical statistics is nothing but the application of statistical concepts in the field of medicine. The statistics is broadly divided into two types, descriptive and inferential. Descriptive statistics uses the tools which are used to summarize the data However, no attempt is made to compare any data sets, and results are not inferred to the target population. It is essentially obtaining a baseline information regarding a population. That is what the descriptive statistics is. In inferential one, data sets are compared by statistical methods very robustly, and inferences are made about the target population. This is the fundamental principle of statistics. We accept there is a chance that we will come to the wrong conclusion. You know, a statistic doesn't say you can be 100% correct. All it says is how close you are to the truth. This is given by statistics. There are two important concepts regarding the research in medical science. One is the population, and second is the sample. Population is a group of people who share a common character or binding trait, usually a disease. For example, patients with urinary stones will be a population. All patients with urinary stone will be a population. All patients with head injury will be population. But sample will be a representative part of that population. You cannot take everybody with urinary stone from Nepal, but you will take a certain subset of that population and do the study. And your intention is to infer the result you obtain from that study to the entire population, of course, with a certain degree of uncertainty. This picture will beautifully show you how the concept of target population to sample is done. The target population is the population of interest in which the researcher wants to generalize the results of the population. Sampling frame is another important concept because everybody from the target population is not accessible to you. So the accessible part of that target population is the sampling frame. For example, if I work at teaching hospital, all patients who come with certain diseases to teaching hospital will be the sampling frame of the target population of all Nepal. So from that sampling frame, I'll take a required number of samples and I'll do a study, and then I'll infer the results of that sample back to the target population. This is the whole mechanics of the research and statistical analysis. Let's go with the data. There are two important quotations I'd like to show you here, which underpins the importance of data. In God we trust, all others bring data. Nobody believes what you think about anything. Whatever you say should be supported by strong data. And data is the sword of the 21st century. The thing now more and more technology develop, more medicine develop, different way of treating patients develop. So everything has to be backed by data. Without that, it is very hard to convince others about treatment. There are four important terminology regarding this, which I'd like to discuss here: data, information, knowledge, and wisdom. Data is the lowest unit of knowledge, but with the data is a set of value making the basis for reasoning or calculation. If anything stops at data level, it has got no meaning. So from data, you have to go to a certain level, different level, which is information. So what is information? It is nothing but the data has been analyzed in some fashion so that it becomes suitable for making decision once. So based on a set of data, you make a decision once, that becomes information. But if you have a multiple level of information and you have the understanding based on extensive experience dealing with information on a subject, it becomes a knowledge. And the ultimate form of information, form of this continuum is the wisdom. When you have data, information, knowledge, and the practical application of a person's knowledge in those circumstances where good may result. So this will be the wisdom. Let's get an example of climbing a Mount Everest, and let's put this in the context. So data will be the height of the Everest plus all other values related to climbing. That will be the data. So information will be overall overall synthesized data regarding the Everest climbing will be the information. Third step, knowledge will be the information plus an understanding based on advice of the experienced climber will become knowledge, and based on 1, 2, 3, when the person successfully climbs Mount Everest, that becomes the wisdom. So from data, we ultimately become wise. And the same thing happens in medical research also, in which we start from data and ultimately we become wise. Let's describe briefly about the type and distribution of data. Data are broadly divided into discrete and continuous data. Discrete data is also called qualitative and continuous is also called quantitative. Discrete data is just yes, no value, sex of the patient, ethnicity of the patient, like that. And continuous data goes through a spectrum. And continuous data can be spread out in many ways. For example, like this, it can be skewed to the right, it could be skewed to the left, it could be all jumbled up, or it follows a particular pattern like this. The uh, data are aggregated a lot in the middle and is smoothly spread out on each side, and it conforms to a shape called bell-shaped curve, just like this bell. So this is the and this is called the normal distribution of the data. Now let me go to the two important concepts in medical statistics, which we very frequently encounter in our literature. One is confidence interval, second is the p-value. So how we basically do research is like this. We have a population 1 and we have another population, which is called population 2. It is impossible to recruit every member of the population to do our research. It would be just impossible. So what we do is we take a subset of those population and we regard them as sample 1 and sample 2. Then we do the compare. We do different study and we do the comparison and we come with a result and we want to infer that result to the population of interest. So, but while doing that is we have not taken the entire population, we have just taken the sample. There will invariably certain degree of uncertainty, and that uncertainty can be handled by these two concepts. So how we handle those uncertainty are by these two mechanisms. Hypothesis testing. Well, in hypothesis testing, we like to find out how often our observed finding is due to chance alone, and this is expressed as a p-value. And next is using the concept called confidence interval. It is nothing but a range of value that will contain the population parameter within a designated confidence interval. Because the result we obtain may not be the true result of the entire population. But when we set a range of values, then we have to what extent we also say also designate a certain confidence level. Like if we want to be 95% certain that our value falls within the range where the population value also falls. This is called confidence interval. I'll next couple of slides also I'll elaborate on this concept. First, let's go to the hypothesis and what research hypothesis is. Research hypothesis is the bedrock of evidence-based medicine where everything else is rests. Research hypothesis is a specific, clear, and testable proposition about the possible outcome of a scientific study, and it describes in concrete terms. There are no abstract terms in research hypothesis. What you expect will happen in a certain circumstances, and it is used in a clinical study to define the relationship between two variables, usually an independent variable and a dependent variable. And by convention, it is research hypothesis are stated as null hypothesis and alternate hypothesis. Null hypothesis is stated that there is no difference between two types of treatment or two types of modality of treatment. Whereas in alternate hypothesis, we say that there is a difference, and the alternate hypothesis which the researchers hopes to verify, but you always start as there is no difference between the two types of treatment as null hypothesis. And research hypothesis is always preceded by research question. You come up with a research question and then you convert that into research hypothesis. Now let's go to the concept of p-value, which is very important. And if you analyze the papers, more than 80% of the papers or a research articles will use p-value as one of their in their result section. So it is extremely important for us clinicians to understand what that means. It gives the probability of any observed difference having happened by chance. If a p-value is what is the probability of that difference between two treatment modality due to the external factor or happening by chance. This is all p-value is about. Here is a good sentence. It is not important for us clinicians to know how the p-value is derived, but we just need to interpret the result. Let's interpret the result. So if somebody says p-value equals 0.5, what it means is probability of the difference having happened by chance is 0.5 in 1. So it's 50-50. So in medical science, if there is a 50-50 chance, it is not acceptable. So this will not be considered statistically significant. Let's go to another situation. P equals 0.05. What does it mean? It means that the probability of the difference having happened by chance is 0.05 in 1. That is 1 in 20. What it means that in 19 out of 20, the difference must have happened due to some intervention. But in 1 in 20, it could have just happened by chance. And the p-value 0.05 is considered a magic value. It was nothing but by convention that the statistician, a group of statisticians decided that anything less than 0.05 should be considered as statistically significant. So anything less than 0.05 is called statistically significant difference. How about p equals 0.01? Again, the similar thing. The difference having happened by chance is 1 in 100. Very unlikely, so we call it highly insignificant. And if the p-value is 0.001, then anything that could have happened by chance is 1 in 1,000 times. In medical science, this is extremely rare, so you consider it as very highly significant. Let's get this. I have taken from the book Medical Stat Made Easy from Harris and Taylor. Let's get an example. 376 patients in urology OPD were randomly assigned to be seen by Dr. Jones and Dr. Stephen. Let's see. The patient satisfaction is 93% and 95% between two doctors. Whereas, the mean time of they take due for the consultation is Dr. Jones spends 16 minutes, whereas Dr. Smith spends 6 minutes. So just looking at this, we cannot say whether whether Dr. Jones sees patient faster, or who is more, patients are more satisfied with Dr. Jones or more satisfied with Smith. So we do some statistical test, like here we use chi-square test and students test for qualitative and quantitative data respectively. So in the first line, the p-value is 0.04. So there is it is not statistically significant that Dr. Jones is or Dr. Smith is any better than Dr. Jones in terms of patient satisfaction. Whereas in the second line, Dr. Smith sees patient much faster, 0.001. So it's highly significant. So the hospital director would love Dr. Smith, who gives the same degree of patient satisfaction, but also sees patient much faster. See, with the use of statistics now, you can say with certainty that Dr. Smith is a better doctor in terms of patient satisfaction and seeing the patient. But one thing we should be careful is we should not toss our p-value, meaning that even if the p-value doesn't come significant, you do not manipulate the data and derive p-value as significant. This will be against the research ethics. Glorification of p-value. P-value has been glorified so much in the medical literature that you have to have a p-value significant, otherwise your research is useless. It is not like that. I'll give you some example. What are the misconceptions regarding p-value? P-value, it is not the probability that S1 is true, or S0 is true, or S1 is true, or study was conducted well and findings are accurate. It doesn't say that. Or it doesn't say that study results are important. No, not at all. Or it says that whatever difference and a smaller p-value doesn't mean a bigger difference between the two groups. All it says is that the finding is less likely to be due to chance. If the p-value is 0.001, it says that, it's extremely unlikely that the results are due to chance alone. There must be some external factor, but it doesn't say that the external factor was very strong. No, it doesn't say. And another important difference we should note is statistical significance versus clinical significance. A result may come statistically significant, but it may not have much clinical value. For example, if a drug lowers the blood pressure by 2 millimeter of mercury or 1 millimeter of mercury, and if it comes p-value comes as less than 0.05, still it doesn't have much significance. It's lowering blood pressure by 2 millimeter of mercury is not significant. So there are certain statistical tests that will ultimately generate a p-value. For continuous data, for parametric data, you use t-test and ANOVA test, and for non-parametric, you use Mann-Whitney U test and Kruskal-Wallis test. You can read this yourself. The time will limit us to go into detail. And for categorical data, if the sample size is high, you can use chi-square test, and for the smaller sample size, you can use Fisher's exact test. There are certain reasons why p-value is not less than 0.05. There are certain, but it is not a moment of despair at all. If the results are still statistically significant, still you contribute to the science. And the reason could be there is really no difference, or difference is too small to detect. But this in itself is a contribution to science and should be duly reported. The second possibility is this. There was a difference, but our study was not sufficiently powered to detect it. It means, our sample size was too small, or the power was less. So this suggests that you should do another study which is sufficiently powered to prove it, or in this study, you should regard this study as a feasibility study or pilot study, and this should be acknowledged and discussed while reporting the result. Let's go briefly about the confidence interval. Again, confidence interval is noted in almost 75% of the papers we read in the medical literature. So we need to know what this is. Confidence interval is a range in which we can be fairly confident where the true value lies. If we have the access to the whole population, and suppose we have the whole population's age. If we want to know that what is the mean age of the patient with the renal cell carcinoma. If we have the access to the entire population, there will be a true mean, but we are not going to take the entire population. So we will take a sample, and we want to be certain that our samples mean age of our sample is close to the actual mean age of the entire population, and this will be given by the confidence interval. So it is customarily put at 95% confidence interval. Nothing is 100% in statistics. So we want to be 95% confident that our sample, our data, our what you call statistic or our parameter is falls within the certain range of that parameter, which is called confidence interval. And this is another important concept here. The size of a confidence interval is related to the sample size. If you have a larger sample size, you can afford to have a narrower confidence interval. But if you have a small sample size, you put a wider confidence interval. So when you read the literature, you have to look at the confidence interval, how narrow or how broad. If you have a narrow confidence interval, the research is fairly certain, confident about the result. If you have a very wide confidence interval, the results, it's difficult to infer, with certainty. And there is another concept as margin of error. You have a population, then you take the sample, you do the study and do the statistical test, and you infer that result to the population. But while doing though, you incur some degree of error, which is called margin of error. That also you have to designate how much margin of error you are willing to accept to infer that result to the population. So this picture will illustrate the difference between the p-value and the confidence interval. Hypothesis testing postulates two choices: null hypothesis and alternate hypothesis. Data will help the researcher to choose the right one. For example, in this picture, there is a real mountain and this is the reflection of the mountain. There is one, if you can say both is a mountain, one is just the illusion reflection. So hypothesis testing will help the researcher to choose which one is the real mountain, which is the reflection. Whereas the confidence interval gives plausible values for the population parameter. It helps a researcher go closer to the truth. So once you have decided which one is the real one, and confidence interval will guide you to reach to your destination. So this is the book I have written in the regarding the health science research, and almost half of the topics here are related to statistical concept, and I request you, when you have time, please go through this. So to conclude my presentation, data, on the basis of the data, we make many decisions, and we first acquire data, we do the statistical analysis, and we get the useful information in the medical field, we apply that, and again we gather more data, and this circle of data, statistical analysis, and useful information goes on and on. To conclude my presentation, statistical thinking will one day be as necessary for efficient citizenship as the ability to read and write, said by famous H.G. Wells. Thank you so much for patiently hearing. Thank you. Good afternoon.
I have one query, and I feel very interesting myself. In day-to-day practice, if I'm not wrong, what we are today is probably mostly based on our personal experience. And what we will be tomorrow is also mostly guided by our experience. But in research and all this clinical practice, why this personal experience is given the least important? It is kept at the bottom of the level of evidence. As a researcher and as a person who is working mostly on this academics, will you please highlight the differences in understanding this thing? Sir, can you hear us?
Yeah. Are you asking that question to me?
Yes, sir.
Okay, thank you. Thank you for the question. Well, it all depends on the hierarchy of evidence. There is a hierarchy of evidence. One opinion or one case report will just generate the hypothesis. It doesn't prove or conclude anything. That's why the opinion has been placed really at the bottom of the hierarchy of evidence, because your experience may be different from my experience. Then then there will be no guidance to the younger generation. This is the main reason, in my opinion.
Hello.
Yes.
Good afternoon, Professor Rajiv Kumar.
Good
Rajiv,
afternoon.
sir?
Can you hear me?
Yes, sir. Yes, sir.
Good afternoon.
How are you, sir?
I'm all doing very well. How are you guys doing? I can see you enjoying a physical meeting in the middle of Kathmandu. Out here, we are in trouble.
Yeah.
I am sitting in the middle of a COVID pandemic. Everybody around me is positive, and it's like it's like crazy here.
Very, very scary. Yeah. Sir, would you like to give some
Yeah.
comments, expert comments on this statistical pathway that Professor?
I think Dr. Sharma has made a very difficult topic sound very easy. He's done a very good job of putting together a very difficult topic. He's made it sound very simple. He obviously has a lot of experience in this area. Explaining statistics is never easy, and he has made sure that he has given you the most important points in statistics. And being a surgeon himself, he understands how surgeons need to know the gross facts. They don't want to get into minor details and 10 differential diagnoses. They want a diagnosis and they want a solution. So he's done exactly that. About your question about experience versus evidence, you're absolutely right. Many times we feel that our experience in our circumstances is more important than what we've read in the books. Every one of us experiences it every day. And that is why medicine is more an art and a science and not just a pure science. You can't really put everything into a computer and get an answer out based on a database or based on evidence. You know how your patient is. He's come from a hilly area, although your statistics data says lithotripsy is the best for a 1 centimeter kidney stone in a normally functioning kidney. You may need 2 sessions, and this person is never coming back to you for the second session, and therefore you choose to do a RIRS or you choose to do a PCNL rather than lithotripsy. So that's where your experience counts, that I know this patient will not benefit from what my guidelines says and what evidence says, and therefore that is experience obviously has value. But then that applies to individual patients. You can't generalize that to everybody who has that condition. And that's why evidence-based medicine is based for the large majority of people. That's where the 95% confidence interval comes in. It applies to 95% of the people. But you may have that one person who's an outlier on either side, and there your experience comes into count. So evidence-based medicine and experience-based medicine are not enemies. They're not fighters. You're supposed to use the knowledge of one with the other and give the best to your patient. I hope I've just made a little clearer on what you were saying.
Thank you very much, sir. Sorry, I would like to introduce Professor Rajiv Kumar. He is Editor-in-Chief of Indian Journal of Urology. This is our official journal at the moment. And he's also in the capacity of Additional Dean of Academics, I think, in All India Institute of Medical Sciences. He's very, very promoter of the young urologist and different young urology sessions he has conducted worldwide. And as one of the awardees in the past, myself and Dr. Suman, we were there in Hong Kong long back. So with this, I would like to welcome Professor Rajiv Kumar for his presentation on talk on ethics in writing, pseudo journal, selecting the right journal. Sir, please go ahead.
Thank you.
Over the next 30 minutes or so, we'll be talking a little bit about ethics in writing, pseudo journals, and how do you select the right journal. And over this time, we'll cover what is misconduct, talking a little bit about research misconduct, reporting bias, conflicts of interest, authorship issues, plagiarism, a little bit about pseudo journals, which are a huge problem these days, and then about how do you choose a journal to which to submit your manuscript. So let's first begin by defining scientific misconduct. Scientific misconduct is defined as the failure to conduct, evaluate, or report research in an ethically acceptable manner. Now, the key point here is the issue about ethics. It's about a gray area, not necessarily black and white, not necessarily the law. So what that means is that what you do or what is done may actually seem ethically acceptable to some individuals, but would not be acceptable in other circumstances. And therefore, often the definition of whether this is right or wrong is debatable and is not always black and white. Whenever you publish a paper, it's actually a part of a research cycle. It begins with a research question or a hypothesis, which then leads you to design your study, your research. You conduct your research, you analyze the data. You then submit it for publication, which then brings in issues of publication misconduct, which we'll be talking about today. After all that, the manuscript gets published. Once it gets published, it again generates a new research question, and that again creates a cycle. So it's a part of a cycle. And unfortunately, all parts of this cycle can be subject to misconduct. We'll be focusing ourselves today primarily to publication misconduct. When you talk about misconduct, it's typically looked at as a part of a spectrum. Certain things are considered minor problems, certain things are considered major problems. So for example, you made an error in your sample size, or the wrong test was used. It's not truly a misconduct, it's more a mistake. And while the paper may not be valid, you're unlikely to be penalized for it. On the other hand, if you've done something like fabricating data, so you didn't have data, you just put in some random numbers from your thought. You falsified data, so the hemoglobin was actually 6, you wrote it as 8, or you modified data. The image shows the residual stone, you modified the image to remove the residual stone. Or omission, you've had 4 patients who died in your study, but you decided to drop those 4 patients for some random reason and not include them. Now, these are genuine problems. This is misconduct, and that would be penalized. So let's talk about some of these errors which are common and which need to be avoided. The first is selective reporting. So which results should you report? You've done a study where you found 5 or 6 different things. Some were good, some were not so good. So which one should you report? Should you report all of them? Should you omit the bad ones? Should you only report the ones that you committed in your methods? What should be reported? Typically, you should report everything that you said you would report in your methods. So if your study said, I'm going to look at hemoglobin change, I'm going to look at change in creatinine, I'm going to look at urinary flow rates, whatever you said you would look at, all of it should be reported, even if it's good or bad to your study. Additionally, if you find some things that are important, you hadn't planned on it, you found 4 patients had severe complications you hadn't anticipated, and it was because of a contaminated irrigation fluid, that must also be reported. Now, it's just because your irrigation fluid was bad, you thought that that doesn't need to be reported. It does need to be reported. So anything which is of significance should be reported. And then when you do a discussion, don't just find studies which support your results. Also look at studies which think that your results may not be right or may not be the best ones. And you must report everything that puts your study or your data in the right perspective. So that's what's called doing a complete reporting and not doing selective reporting. The next common issue that we talk about in misconduct is issues related to authorship. So the immediate question that comes up is, why should authorship be an issue? Why can't I put 10 people on the authorship? I have 5 residents, 3 faculty in my department. We've done 1 study. Why can't all of us be authors? So the issue is something called responsibility. It's the most important aspect of who can be an author. To be an author, an individual must fulfill certain specified criteria. The International Committee of Medical Journal Editors has put forth a set of 4 criteria, and anybody who wants to be called an author must be able to fulfill all 4 criteria. Only then are they authors. Now, these are important because it ensures that only those people who've contributed to the research, who understand what is being said, and who will take responsibility for the content, only those people get to be authors. People who don't fulfill those criteria are either guests or ghosts. So people who don't fulfill all the criteria, they're just there because you like them, they're senior people, you want to put their name because it makes your paper look good, they're called guest authors. And then there are certain people who deserve to be authors, but they don't get their name on the paper. They are called ghost authors, and we'll explain this a little bit. Whenever you write a paper, and we'll talk about this in the conflicts of interest, you're supposed to declare your conflicts of interest. So let's say that the drug that you're reporting on, you are also the manufacturer. Let's say you're the company that makes the drug, you've done the study and you want to report the study. Now, if you report such a study as an author, you're required to state that I own the company. Therefore, I will make profit if my drug sells. That creates a problem for many people. When you read a paper written by a pharmaceutical company, you immediately trust it less than if the paper was written by somebody who did not make money from the drug. And therefore, because of the conflict of interest, readers will put less value to that paper. Therefore, many times such companies will leave their names out of the paper. They will come to you as a researcher or as a physician. They will say, doctor, we have done this research, we've got this data, can you publish it for us? You are very happy, you've got a paper already written, you just put your name and you submit it. What you've done there is created a ghost author. The actual author was the company. They have left their name out. You don't know the reality of the data, but you've accepted responsibility for it. And that's a very dangerous trend, and that's called ghost authorship. The problem is that authorship is related to trust. When you read a paper in the New England Journal of Medicine, when you read a paper that's come out of Mayo or Harvard, you automatically trust it more than any other paper. Nobody ever checks the data. The data may actually be coming from a very small institution and done well. You often trust authors based on what their past history is or what their affiliation is. And the whole concept is based on trust. And therefore, if you are not honest about who the authors are, it creates a problem. When you give authorship to people who don't deserve to be author, then you create experts who actually aren't experts. You put 4 people's name, but they know nothing about the subject. And suddenly they become experts. So that's a problem. And then, of course, people make money from manuscripts. And we've seen that in the last 1 year of COVID. Selling drugs, whether you're selling hydroxychloroquine, remdesivir, tocilizumab, lots of money has been made simply because a couple of papers have been published. And therefore, paper authorship becomes extremely important. And I've already talked a little bit about the conflict of interest. So whenever you have some interest other than the patient's interest being primary, that interest has to be declared. So if the company gave you the drugs for free, if the company is going to take you on a holiday, if the company is going to give you some money, they're going to pay you some money to deliver a lecture, everything becomes a conflict of interest to what's written on the paper. and all such conflicts of interest needed to be declared when you submit a paper. The next important misconduct we talk about is plagiarism, and again, this is unfortunately very common. A very broad definition of plagiarism is taking that which is not yours, a very broad definition. So when you copy words, when you copy ideas, when you copy pictures, all that is called plagiarism. So you cannot copy somebody else's work. You actually can't even copy your own work. So if you have written an article, you can't just copy a paragraph from that article and write it in another article. That also is plagiarism itself, plagiarism. So the commonest errors we see are paragraphs being copied, pictures being copied. It most often appears in the introduction part or in the discussion part of a paper because they are the most difficult to write in your own language. You have to be extremely careful that you don't do that. You can't be salami slicing, which means you have 100 patient data, you write 10 in one paper, 10 in another paper, 30 in another paper. So you make 3 or 4 papers of the same type on the same data set. That's also a variant of plagiarism. It's more of salami slicing. These are all types of misconducts that you must avoid. And again, like all misconduct, there's a whole range where plagiarism could be. It could be some small thing like a few lines that are copied to an entire paper being repeated. The same paper being published in 2 places, or even worse, somebody else's paper you copy and put your name on it. So all these are errors of their misconduct, and you will have to be punished because of if you're found out. Submission misconduct, everybody knows that papers get rejected. So you think that if I submit to 5 or 6 and I will simply publish in the very first one which gives me a rejection acceptance, and it will save me time. But that's wrong. You can't do that. You can only submit to one journal at a time. You have to wait for the answer from that journal, acceptance, rejection, and only then can you submit to a next journal. This is again a very common problem. Authors believe that we want to save our times. We know we'll get rejected. So let's just give it to 5. And the first one that accepts, I will publish, and the other 4 I will withdraw. All of that is wrong. It's a misconduct. You can't do that. This is now bad because it's very easy to detect and there are lots of punishment. So it's best avoided. The problem that's arisen because of all these pressures to publish is something called predatory publishing. Predatory journals are journals which do not do peer review. All they require is money. You give them some money, they will publish your paper 2 days, 3 days, and they're doing it only for money without doing any peer review. That's a predatory journal. Now that doesn't mean that every journal where you're paying money is predatory. Most good journals will charge you money to publish, but they're not going to publish you just because you paid them. They will do your peer review, they will do an analysis, and only when they find it suitable for publication, at that point you have to pay. Very different from predatory journals who don't bother about the scientific content. All they do is pay them the money and they'll publish. This is a huge problem. They'll be willing to publish no matter what your subject is. They guarantee your publication within 3 or 4 days. They'll send you repeated emails asking you to submit to them. And this is all dangerous stuff because it's very easy to get fooled. Differentiating a good journal from a bad journal can sometimes be difficult. I made a mistake very recently despite having more than 20 years of experience in this whole business. Therefore, it's very easy to get caught into a pseudo journal or a dubious journal mistake, and you will lose your money if you publish with them because such publications are worthless and you have to be extremely careful with them. The last point is something about where should I publish. So people often look at impact factors and say that this is a good impact factor journal, therefore maybe I should publish here. So you must be careful that the only genuine impact factor that's considered valid is the one that is issued by an organization called Clarivate Analytics. This is only given to journals that are listed in the Science Citation Index Expanded SCIE, and the impact factor is published in something called the Journal Citation Report. There's a mathematical formula which calculates the impact factor for a journal. It's not for a person, it's for a whole journal. When you choose where you are going to publish, you should carefully select your journal. The area should be of your interest. The journal should be speaking or publishing manuscripts in the area of your interest. You should look at its reputation. You should, of course, look at its impact factor. If it has a genuine impact factor, does it go to authors or readers who you wish to address? And ultimately, can you afford the cost if it's going to charge you a cost to publish? You also have to look at the regulatory requirements. Now there are a number of organizations which require specific requirements for which journal is acceptable to them. And therefore, you have to finally decide that does this journal fit my requirement? follow its instructions to authors, look at the editorial board, and then look at the journal metrics. Finally, be careful between choosing between citations and impact. Yes, you want a high impact factor. The European Urology is 17. You want to go into European Urology. But then you may not do so, and you might be looking at an impact factor of 1 or 2 journal. But is somebody going to read it? Why publish in a journal which does have an impact factor but which nobody reads? On the other hand, you have a journal which may not have an impact factor, but which all of your membership gets, which everybody reads. It's free to read. It's more topical, more in your region. It may be better to publish in such a journal where at least your peers will read you, rather than to publish in a journal which nobody reads, but it has an impact factor. So choosing your journal becomes important. Don't get swayed by things that look like this, which is an impact factor of 1, 2, 4, 5, which is truly a fraud impact factor. They've just given it to themselves. This is not our Science Citation Index impact factor. So that in summary is about scientific misconduct, predatory journals, and impact factors. It's important to be aware of these problems because they are now rampant, and the only way you can avoid it is to be aware of what the problem is. Thank you. Morning.
Thank you, Professor Rajiv Kumar, for elaborating on ethics and writing pseudo journals and how to avoid the predatory journals, for guiding us. At this moment, I would like to request Professor Mohan Raj Sharma for giving some expert comments and suggestions, please. Mohan sir, please, up to you.
Yes. Professor Rajiv, excellent presentation on scientific misconduct and predatory journal, especially in the academic setting when you have the pressure to publish. Then all these predatory journals have the job to do. They make a lot of money, and out of the very young aspiring academician, they really want to catch your desperate desire to publish, and this is what we should be very careful about. When the journal's name start with World Journal of something or International Journal or Advanced Journal, then it almost always there is a catch. And he very rightly said, when somebody writes that our impact factor is 543, it's automatically is a predatory journal. Actually, what he said, I also encountered a very similar situation just last year. One of our MCS residents submitted a journal, and the editorial board had a very distinguished people in there, but they were also lured to be in the editorial board. And when after like 1 week of submission, they said that your article has been accepted for publication, and they wanted 800 euro for the publication. Initially they never said that they will charge money, but once they said that 800 euro, unbelievable. And I told my resident to withdraw the article, and they said you cannot withdraw anymore. Even withdrawal also they want to take the charge. So that kind of robbery is there, and we have to be very careful in that regard. Everything he said, I concur. Everything he said, and you have to be very careful when you submit your paper in the beginning of your career. And another point is, you don't have to publish your journal in a very high, your article in a very, very high impact factor. It might take 2 years, 3 years, even if your research paper is very good. What your need is, what is your intention is, if you want to publish in a, less than high impact factor journal is also okay. And these are the things you have to consider. I congratulate Professor Rajiv for a very excellent presentation.
Thank you very much, sir.
Yes, all of us
Thank you.
have these experiences.
Thank you very much.
Now I would like to invite Professor Apul Goel, who is editor of IJU and professor from King George Medical University, and to give his talk on discussion, especially focused on discussion part of our scientific paper writing. Due to his own familial circumstances, probably is not able to join us live. So we'll play a recorded video of on discussion part of a scientific paper.
Thank you, Rajiv. Thank you, Indian Journal of Urology, Dr. Pavan Raj Chalese and NOS for giving me this opportunity. Over the next 12-13 minutes, I'll be discussing on how to write a paper, but my focus will be only on the discussion segment. So once you have written a manuscript, it needs to be communicated to the research community. And the structure of the manuscript is standardized and is in the emerald format, where I stands for the introduction, M stands for the material and methods, R is the results, and D is the discussion. In the introduction, you essentially write the aim of your study and the rationale for choosing that particular aim. To fulfill that particular aim, what material and methods were chosen comes in the material and methods section, where you discuss the methodology in detail, including the inclusion-exclusion criteria, the type of patients, which surgical method was used. All these comes under the material and methods. So whatever were your observations come in the results section. If you see, writing the material and methods and the results section is relatively straightforward. Then comes the discussion, and this will be discussing in greater detail. When you are submitting your protocol either to the ethics committee or to the dean office as part of a postgraduate thesis, you have already written the introduction and the material and methods section. So what all comes in the discussion section? You delve into the meaning, importance, and relevance of your results. It should focus on explaining and evaluating what you found, showing how it relates to your literature review and research questions, making an argument in support of your overall conclusion. So if you see, for writing a good discussion, you need to have thorough knowledge of the topic and a deep understanding of that particular topic. Only then your discussion will be good. So you need to remember that any discussion should have these 4 key elements. Number 1 is interpretation. So what do the results mean? The implications of your study. Why do the results matter? The so what? The limitations. What can't the results tell us? And your recommendations. So what practical actions or any change in practice or scientific studies should follow after this particular research? So your paper, your discussion should have all these 4 segments. It's mandatory to have. But before starting all these 4 points, the first paragraph should summarize your key findings. So you start with the results indicate that the study demonstrates a correlation between. The analysis supports the theory that. So you start with the summary of your key findings. Here, just don't repeat all the data what you have already mentioned in the results section. Just make a clear statement of the overall result. So it's typically in 1 paragraph that you summarize the key findings of your study. Then comes those 4 key things that I've told should be there in any discussion. So give your interpretations, spell out the significance of your results and show exactly how they answer your research questions. Identify correlations, patterns, and relationships among the data. Discuss whether the results met your expectations or supported your hypothesis. Contextualize your findings with previous research and theory. Explain unexpected results and evaluate their significance. Consider possible alternative explanations and make an argument for your position. So again, if you see the slide, writing a discussion is not that straightforward. You need to have good knowledge. Only then you can interpret your study nicely. So organize your discussion around key research questions, following the same structure as your results section. So this is a good idea because often the results are so many and the discussion sometimes becomes haphazard. So you need to organize your discussion, and the best way to do it should be according to the results. So you follow the same sequence as you followed in your results section and you discuss each point separately. If you think some of the points are not worth discussing, so in that situation, you can start by highlighting the most significant or the unexpected results. For example, you can start with in line with the hypothesis. If your results essentially prove what is already known, so you can start with in line with the hypothesis. Or if the results are contrary to the existing knowledge, you can say contrary to the hypothesized association. Or the results contradict the claims of Smith that. The results might suggest that X. However, based on findings of similar studies, a more plausible explanation is Y. So you need to interpret your results. A common problem, especially common in the postgraduates is that they feel that whatever was statistically significant is probably the only result that they have achieved. Anything which in where statistical significance has not been proven, they feel that those results are not important. But this is not true. So be sure to carefully address all relevant results, not just the statistically significant ones. Don't run after p-values. So what is more important is the clinical significance. So you need to understand the difference between statistical significance versus clinical significance. So in clinical research results that are statistically significant are often interpreted as being clinically important as well. But again, as I mentioned, this is not true. So statistical significance indicates the reliability of the study results, but clinical significance reflects its impact on clinical practice. For example, supposing a new drug comes which increases the survival of a cancer patient by 1 month. Okay, so and for that the patient has the drug is very costly and it is very toxic as well. So the clinical significance of that particular intervention or that particular drug may not be important, although statistically an advantage of in the survival of 1 month may be statistically significant. So you need to understand, although measuring statistical significance is very, very simple. You see a p-value of less than 0.5, but measuring clinical significance is not that easy. Now, the second component of a discussion is that you need to discuss the implications. You need to answer these questions. Do your results agree with previous research? If so, what do they add to it? So if you are just confirming what is already known, so how your study is adding up to it? Are your findings very different from other studies? If so, why might this be? So again, if you are observing something different, then you need to explain, are there any practical implications? So if you need to tell the so what of your study, why your study needs to be published should be there in the implications. So show the reader exactly what your research has contributed and why they should care. The sentences that can be in the form of these results build on existing evidence of the results do not fit with the theory that the experiment provides a new insight into the relationship between these results should be taken into account when considering how to example. So this is how you write the implications. Another important thing that is mandatory in any good discussion is that you acknowledge the limitations of your study. And the limitations aren't about listing your errors. For example, very, very straightforward errors, but about providing an accurate picture of what can and cannot be concluded from your study. So that is actually the limitations, what can or cannot be concluded from your study. So the limitations might be due to the research design or the methodology or unanticipated obstacles that emerged during the research process. Mention only those limitations that are relevant to your research and the impact of limitations on achieving the aims of your study. So the limitation again needs some thought and to write the limitations. And some common examples of limitations that are seen in different papers are a small sample size, sample limited to a specific group of people that limits the generalizability. For example, if you want to see the knowledge of urology postgraduates about randomized controlled trials. So you want to do a study and you want to understand what is the understanding of the postgraduates about randomized controlled trials, and you choose a study sample of postgraduates doing post-graduation in urology in Nepal. So your results might not be relevant or cannot be generalized to the postgraduates of India or America. Okay, so this limits the generalizability of your study. And then there are certain confounders that may, because of which your study may have limitations. Some examples are the generalizability of the results is limited by, the reliability of this data is impacted by, due to lack of data on X, the results cannot confirm. So this is how you write the limitations. So Then comes state your recommendations, or you can say the conclusions. So anything, whether you recommend any change in practice or you recommend further studies. If you are recommending further studies, why you are recommending further studies? What were the limitations on which on the basis of which you are recommending for further studies? Another important thing that you need to understand is what to leave out of the discussion. So don't introduce new results. This is again not very uncommon. You suddenly see something new emerging in the discussion. Don't make inflated claims. Avoid over-interpretation. Don't undermine your research as well. The discussion on the limitations should aim to strengthen your credibility, not emphasize weaknesses or failures. So you need to tell the strengths of your studies as well. Maintain focus. Do not discuss extraneous ideas, concepts, or information. Okay, so to write a good discussion, as you must have understood by now, you need to have a good knowledge and understanding of that particular topic. And this comes by reading literature written by other authors. And in fact, discussing those papers in the journal club, understanding how to interpret data, how to write a discussion. So you need to develop this ability to evaluate a paper critically and accurately. You need to develop ability to recognize problems in the experimental design, familiarity to broad-based, relevant and current literature, ability to generate interesting and important questions, ability to generate original ideas on the literature, ability to group data in a logical fashion. So when you read other papers written by other authors, you need to critically evaluate that paper, and then you will develop the skill to write a good paper yourself. You need to have good writing skills. Your figures, the language that you use should be clear. Because if you see the Google page, there's a section where you can download images. There's a section where you have the images only. So many times figures and tables of your article can be downloaded separately. So they should be standalone so that a person who is downloading that particular table and figure can understand the table without reading your paper. The entire paper without reading your paper can understand that particular figure or that particular table. So that improves the visibility of your article. Okay, so try to make figures and tables that are standalone. A very common problem in the discussion is plagiarism. In the material and methods and the results, these are usually specific to your particular research, and there's usually no copying. But in the discussion section, what happens when you are quoting other literature to justify your or interpreting other literature, you tend to copy what that particular author has written. So this is what is called as plagiarism, and you need to identify. There are so many softwares now that will detect plagiarism. So plagiarism is not accepted in your research article. A word about how to write a discussion in case reports. So often what is seen is that once you have reported your particular case, which was rare, and then in the discussion you write it as a book chapter. So this is not correct. You need to discuss your particular patient, your particular case in the discussion as well. Okay, so describe the peculiarities of the case and don't tell general knowledge, general information of that particular issue. So this is an example that I have taken from a paper, which is a case report on Cooper's syringo seed. So the authors have started with the genesis, then the classification, then the prevalence, then what are the symptoms, and then how to evaluate by ultrasound and all that, cystourethropy. So the discussion is like a chapter in a book. You need to focus on your particular patient, okay, your particular case. Thank you so much.
Thank you, Dr. Apul. This is the most difficult situation when we are writing a paper. We usually get stuck at the discussion part. Everything is so clear. Methodology, you already had that. So everything flows like river, but suddenly there is a big dam when you come in the discussion part. So this is the reason we plan during this session is how to plan and formulate the discussion part and what are the essential component of it. I think Dr. Apul Goel has nicely elaborated everything and make most of the things clear. Dr. Rajiv, are you there? Would you like to give some expert comment on this topic? Dr. Rajiv.
Yeah, you're right, Pavan, that the discussion is the most difficult part to write because you don't know how to start. And therefore, when you're starting a discussion, a very common way in which you can start is to summarize your results. The most important aspects of your results can be summarized in 1 or 2 lines and highlight what is the relevance of those results to the context and then go around discussing the various aspects. So that's the problem with the discussion. And again, very important thing Rapul highlighted is that's where plagiarism happens most common because people find it difficult to write it themselves. So they read some other article which was similar and they copy what was written on that article in this article. So that's unfortunately the common parts. You have to learn a little bit more in writing the discussion, but then what Apul has said is the most appropriate thing. Apul called a little while back, there's a emergency that he needs to attend to and therefore he couldn't be available online and he expresses his regrets for that.
Dr. Rajiv, when we are citing many article or the paper during the discussion, so how can we avoid the plagiarism? Because there are so many ways we need to cite those papers. So most of the people, young researcher and our resident, they usually do the cut pasting at the discussion part. So would you highlight that part?
So the simplest problem is what you just said, cut paste. If you stop doing Control C, Control V, those are the shortcuts for copy paste, then you will avoid plagiarism. All you need to do is read the article that you wish to cite, understand what the author in that article has said, then write it in your own words and then give a reference to that article. Don't copy from that article and paste. That is exactly what you just said, cut paste. Just avoid that. Read the article, think about it in your own words and write it in your own words and then put the reference number. As soon as you do that, the language will change. Now it will be your language, your interpretation, and not the language or the interpretation of the original author. So although you have said what he wanted to say or what you think he wanted to say, it's not cut paste. And there is a reference put at the end of it, and therefore you can avoid plagiarism. So that's the only way of avoiding plagiarism.
Thank you very much. Now, I would like to request Professor Rajiv Kumar for review for the journals. Why do papers get rejected? Please, Professor Rajiv Kumar, up to you.
Thank you. So we'll go to the video for that.
For an author, the most important problem is actually getting their paper published. Writing it happens, but then once they submit it to a journal, the commonest endpoint of that submission happens to be a rejection. And therefore, over the next 10 to 15 minutes, we'll look at why do your papers get rejected. As an author, the path to publication seems extremely difficult. This is you, a scientist with some work in your hand, you want to get it published, but then there's this bunch of 8 or 10 people on your path preventing you from publishing. They're called editor, reviewer, and they try to do everything possible to prevent you from publishing. And the immediate question that comes to your mind is why? Why can't I just publish everything? It costs nothing these days. The journals are online. All I need to do is put up a manuscript on a web page. It probably costs less than $50 to buy that web space. Why can't I publish anything I wish? And this is what brings us to the inside story of what defines a journal. Why do journals exist? And what is the hallmark of publishing? To understand this, we need to go back a little bit in time to understand why were journals ever created? Why do people ever write? And this is a story that goes back more than 300 years. Probably one of the first few medical journals was the Philosophical Transactions of the Royal Society. It's a journal that's published even today. It's more than 300 years old. And the reason journals were created was because people needed to disseminate information. Somebody made a new medical discovery. There was no TV, no internet, no way of telling people or other physicians what they had found. And the best way of communicating with everybody, telling them what does good, what does harm, was to write and publish. And therefore, the whole concept behind writing was to disseminate new knowledge, new information for the benefit of mankind. Unfortunately, over the years, everything has changed. People now need to publish much less to benefit mankind, but far more to benefit man, and that man happens to be themselves. They need this paper to make an academic progress. They need to publish this paper because they want to get invited to speak at conferences. They have to have a CV. They need to be available on PubMed. And of course, there's lots of money in it. If you publish a paper about a new drug, the drug makes tons of money. Therefore, the whole reason why people are now writing has changed from benefiting mankind to benefiting man. And that brings in a new question. You need to be sure that what you're publishing makes sense. The result of this desire to publish or this need to publish has led to something which we talked about earlier, and that's pseudo journals. That's a lot of journals which just say, give me a manuscript, I will immediately put it up on a website. That's my online journal. You're happy you've got a publication. I'm happy I'm just going to make a little bit of money from you. Therefore, why is it wrong? Why can't I just give them some money and have them put my paper on the net? The answer lies in the importance of a paper. In medical science in particular, all our treatments, all our knowledge comes from what's been published in a manuscript. We look at publications and decide, how do I want to treat my patient? A paper is extremely powerful. And over the last 1 year, we've seen in the COVID pandemic how each one of us was searching for treatments, searching for diagnosis. We were looking at papers immediately as they came off the press and used them to treat our patients. That's the power of a paper. And if what's written on the paper is false or not verified, you have the potential to harm patients. The other important thing is nobody verifies the content of a paper. Nobody ever checks whether this study was actually done. You trust the authors. This brings in the importance of understanding the power of a paper. And therefore, you need to make sure that whatever gets published is published correctly. That's where the role of a reviewer comes in. Reviewers and editors are considered gatekeepers of science. Whenever you put out a manuscript that is looked at by 5 or 6 of your peers, they judge it for whether the content is valid, whether the study was properly done, whether the methodology is consistent, can it be made better, can it be easier to understand, and is it speaking a balanced tone. Now, the reviewers don't always get it right. It's been often proven that reviewers get it wrong. You get rejection from one journal, you get acceptance at another journal. You make minor changes, one journal says good, the other journal says bad. Therefore, they don't always get it right, but at least they make contributions to try and ensure that really bad science doesn't get through. So what do reviewers expect to make them accept a journal? The first thing, of course, is that the science must be valid. What you're speaking must sound to be scientifically logical, based on some background data, and must have validity. It must be brief. Don't give them tons of papers which they can't read. It must be written well. If every time they need to look at a dictionary or they need to understand Google translation to understand what you're saying, they're not going to be interested. It must not be biased. Just because you think holmium laser is the best technology on earth, don't try to put everything in your paper to say holmium is the best. There must be something that's wrong with it. There must be some things that make TRP better. There must be some things that make thulium better. Therefore, don't be biased in what you're saying. Don't make a conjecture. Just because you're comparing holmium with thulium and you think that the results were good, don't say holmium is cheaper just because you bought a cheaper machine. If you didn't do a cost analysis, don't talk about cost. That's conjecture. And of course, no misconduct. Write what you found. Write your thoughts. Don't copy from somebody else. No. So what are the insider's tips to get yourself published? The first thing you must understand is the concept of IMRAD. IMRAD is introduction, methods, results, and discussion. This is the most important tip about writing. Introduction is understanding why did you ever do the study? What did you study? What was the reason behind doing the study? The method section is defining how you actually did the study. The results describes what you actually found. And then comes the discussion, which explains what your results mean. So now let's look at each one of these sections one by one. The first thing that you write in a manuscript is the introduction, and you must answer 3 basic questions. What is the problem? What is not known about the problem, and how are you going to answer that question? So what is the known information? For example, we know that there are multiple techniques of treating an enlarged prostate. That's known knowledge. What is not known is whether TURP is better than a holmium enucleation. So that's the unknown knowledge. We don't know whether the results of one are better than the other. What I'm going to do about it is that I'm going to do a comparative study comparing flow rates after TURP or holmium laser. So you've answered the 3 questions. That is your introduction. That introduces your study to your readers. That's the introduction. So answer the 3 questions in the introduction. Then you talk about the methods. Methods basically must include everything that you did to get your results. Who did you study? What was their age? What was the prostate size? What was the comorbidity? What was their baseline flow rate? Were they medication failures? Were they on a catheter? Were they on anticoagulants? What machine did you use? What settings did you use? When did you measure the flow rate? When was the catheter removed? How did you measure the hemoglobin? Everything that you've done to define the patients, that's your subjects. Your intervention, how did you do the TURP? What machine did you use? How did you do the holmium laser enucleation? What machine did you use? What was the comparison? Who did you compare? So the TURP was the comparator group, holmium was the intervention group. How were the 2 groups chosen? What were the outcome measures? Simply saying we assessed outcomes is not enough. What did you measure? I measured flow rates on day 15 using IPSS. I measured the prostate volume using an ultrasound, transabdominal 10 days later. I measured complications by calling them on the phone on 30 days. Whatever are the most objective or definable techniques or tools of measuring the outcomes, define all that, and that's called the PICO. It can also be the time, and that's called the PICOT. That's what comes in the method section. Then comes the results section, and in the results section, you must define all the methods endpoints that you decide. So if you said outcomes, I will measure the following 5 things. I'll measure the flow rate, I'll measure the volume, I'll measure the IPSS, I'll measure the hemoglobin drop. Your results must answer all the questions that you raised in your methods. Give only the facts, don't explain that my results are hemoglobin is lower because of this. The explanation comes in the discussion. In the results, it's just the facts. And remember to use the text and the tables and don't overlap. So if you have multiple findings, put them in the table. Summary finding, the most important endpoint, put that in the text part of it. Then comes the discussion, and this is where we often mess up. A discussion is not just giving 10 more studies which found that same study. So you've done TURP versus holmium laser. You now say study A found this, study B found this, study C found this, study D found this. That's not a discussion. A discussion is to discuss your results. We found our flow rates were poorer with TURP. All right. Why were they poorer? Is this different from other studies? This is where you give comparison with other studies. Why is it different from other studies? Why are your flow rates poorer? That's a discussion. So you do have to compare with other studies, but that's not the only point. You have to actually justify or explain why your results are similar or why are they different. Don't do just a literature review and quote 20 studies which are similar or different. Explain your results and provide your limitations. What do you think could be done better the next time? The next step is that when you come to the submission, make sure you follow the journal guidelines. Don't irritate the editorial office because you can't write the submission. So if the journal says 12 font size, make it 12 font size. If the journal says Arial, make it Arial. If they say put that heading should be purpose, write the heading as purpose. If they say the heading should be background, background. If they say introduction, introduction. Small things. If they say put the table in the main file, put the table in the main file. If they say upload the images separately, upload. Make sure you follow the journal guidelines because ultimately they have to do the same thing. They'll just keep sending it back to you and they'll keep getting bugged that you're not following the basic rules. Make sure it's consistent. If your abstract says 30 patients, your main text should also say 30 patients. If the average age there was 68, average age here should also be 68. And if there is a difference, everybody assumes that you're cheating somewhere. And make sure you run a plagiarism check. Revise. Don't just send the very first draft that you wrote. Read it a couple of times before you send it. So in summary, the best way to avoid a rejection is to write a good paper. You must have something to write. You must have some data. You must have a hypothesis. You must be trying to answer a question. There must be something new that you're saying. Once you've got something new to say, write it well, spend time drafting a good manuscript, read other papers that have been published in the journal to see how they've written it, and make sure you try and follow a certain pattern that the journal wants. Be honest. If there are lacunae, accept the lacunae, say it well, write it well, and submit it only to one journal at a time. If you follow the basic rules, you'll get rejected. That is the unfortunate fact. 1 out of 10 papers get accepted. So 9 out of 10 times you will get a rejection. But if you've done it well, the chances of your acceptance get higher. Thank you very much.
Hello. Thank you, Dr. Rajiv, for a nice elaboration on the topic, why do papers get rejected? We are with today as a panelist, Dr. Mohan Sharma. He is also the editor-chief in Journal of Institute of Medicine, Nepal. Many papers, when you talk about the impact factor, I think many journals, they do receive many papers and in this capacity that they cannot handle. So before going into the editorial process also, I think many journals, they scan, and based on their guidelines, if they are not accepted, they are not from the big names, the papers are not big names, they may get rejected out. So is this situation persist or not, Dr. Mohan?
You mean the gift authorship, Dr. Pavan?
Yes, sir.
Yeah. This is actually rampant in academic setting. You know, when there is a big name in the in the author's list, there is a slightly increased chance, unfortunately, of getting paper published. Though we all say it should be discouraged. You know, just because the head of department is well known in the circle, and if his or her name is there, the chance that the article may be published. But many journal editorial board have the blind review system that should technically eliminate that risk, but still sometimes that can get through. That is one problem. Another is the one we have faced is the duplicate submission. Dr. Rajiv also touched on it. You know, they submitted to multiple places, and then the article which was submitted to us is exactly published a couple of months ago in another journal. And these are the things we have to. Our policy has been to educate them first. You know, this is not right. You have done wrong. Please do not do it in the future. That kind of warning we have given them. Apart from that, we do not blacklist them. But if they do the thing repeatedly, then we have to blacklist them. That is the one thing. A comment about the about why paper get rejected. You know, every author thinks that his or her paper is the best, and they get very angry why my paper was rejected. But when they do the introspection, there are a lot of lacunae, lot of weaknesses in that paper, so that paper was rejected. So authors should follow the guidelines, all the instruction Professor Rajiv just mentioned, and that decreases the chance of rejection, though you can never be again 100% sure that your paper won't be rejected. That's my comment, Pavan. And another thing is, if I have a time, if you have a very bad research, no matter how good your writing is, it's hard to get published. But if your writing is poor, even if your research was very strong, you run the risk of it being rejected, and that will be a nightmare for all of us. That one should be careful. And the only substitution, no matter how many webinar or how much lecture you listen to, unless you start writing, that art of writing will not come. So the only tonic for this is to practice and start writing. Thank you.
Professor Rajiv Kumar? Hello, sir?
Yeah, I heard nothing. There was no audio. Can you just repeat what you said?
Yeah. Now IJ session has come to an end. Do you have any expert comments or suggestions that how to move forward and how is the overall session? We want to hear from you. That's all.
So I just wanted to add a couple of comments to what Pawan said about in-house rejections, and he was absolutely right. All manuscripts don't get sent out to external reviewers. Between 50 to 70% of manuscripts that come in will get rejected upfront, right at the time within the editorial office. So that's a problem that, I mean, it's not a problem, it's a solution that actually every journal has. In terms of your next steps that you ask for, we're very proud to be the international journal for the Nepal Association of Urological Surgeons. We also have editorial board members from the NAUS. And whenever we get manuscripts from Nepal, we will generally try and include Nepalese reviewers in our panel of review because they would understand the local scenario more. So that's the general policy most journals have. If you submit your manuscript to the Journal of Urology, the Journal of Urology will obviously send it back to somebody within the region also. One of the reviewers would probably come from Nepal or India to make sure that they get regional inputs. So we would be happy for people from Nepal to apply to be reviewers for the journal. It's available on our website. You can log in and apply to be a reviewer. And all the best. Writing a paper is not easy, but once you've done the first 5 or 6, life becomes easier. The first 5 or 6 are the toughest ones. After that, things become much easier. And we are happy to help you and guide you whenever you need our help. So thank you very much for the opportunity. The journal is grateful for this opportunity to be here.
Dr. Pawan.
Yes, sir.
Can I ask a question to Professor Rajiv?
Yeah, sure. Go ahead.
Yeah, Professor Rajiv, do you have any baseline criteria as to who can be a reviewer? Like this many number of publication minimum or academically this rank, anything like that?
So generally what happens is that the urology community is not very large within the subcontinent. And generally we would have some idea who this individual is, or we would get an idea from their CV when they graduated and how many years they've graduated. So we look at their CV, we look at what their publication record is, and that is usually enough. We will generally assign them 1 or 2 manuscripts to review. No manuscript goes to only 1 reviewer. There will be 5 or 6 reviewers in every manuscript. And we assess their review. If we think that the review was good in line with what we decided, we will send them more. If we find that the reviews were not good, we will probably drop them. So the basic criteria is a person should preferably be a qualified urologist. Very rarely do we include residents for review, almost never. Usually it would be a qualified urologist. We look at their number of publications that they submit in their CV, and we will send them 1 or 2 test manuscripts for review. And the feedback that we get on those 2 reviews will decide whether we give them more or not.
Okay.
Thank you, sir.
Thank you.
Is there any questions from the floor? Last time, because we are closing this session. If there are not more questions from the audience, I will take this opportunity to thank Dr. Rajiv Kumar, Dr. Apul Goel, and Dr. Mohan Raj Sharma. These are the names from where we are really inspired to do our research during our clinical practice, because most of the urologists, they are very, very busy in their clinical practice, taking care of the needy patient, that we need to accept this. But hearing your lectures, being a student in your class, it's being possible for us to just to start something that we started documenting, something that could be the experience, our observational study, and that is how we are teaching our resident too. Thank you, sir. Thank you, sir, being with us. So I conclude the end of the session, and I would like to start another session within a minute time. Thank you.
Thank you very much for the opportunity.
Very good evening. So now we are starting our last session of this conference, but this is not the end because we are starting our disease donor program in the coming future. 2008, 8/8/2008. That is the day when we started the first successful kidney transplantation at Trivandrum University Teaching Hospital. After that, Bir Hospital also did a successful transplantation. And then these transplantation programs rampantly flourished across the country. Now there are 8 centers who had done successful kidney transplantation. There are few disease donor programs. Disease donor kidney transplantation has also been done, but it is not practiced regularly throughout the country. And this is the high time where we need to change our legislation. We need to make us comfortable. We have to correct our legal rules, and we need to start the disease donation program. And I am very happy that Mohan Foundation joined today with us, along with the NOWS in this session, to have this disease donor kidney transplantation symposium. On behalf of our convener, my co-convener Vijay Katwal, I would like to invite all the chairpersons to this session. Dr. Vijay, please join with us. I would like to invite the chairperson for this session, Professor Dr. Bholaraj Joshi. He is the key person, instrumental person to start the kidney transplantation, along with Dr. Dibya Singh Shah, who is leading our institute currently as a dean, and she was the head of the Department of Nephrology at UTH. I would also like to invite as a chairperson, Dr. Rishi Kumar Kafle. He is renowned nephrologist in country, and he has joined us today on virtual platform. Welcome, sir. I would also like to request Professor Prem Raj Gewali, who is current executive director of Said Dharma Bhakta National Transplant Center, to join as a chairperson. So I would like to start this session as a virtual live, and there are one physical presentation being done. So this is a classical example of a hybrid conference that we are having this during difficult time. So up to you, sir. Professor Bholaraj Joshi, sir.
Thank you, Pawan, for such a nice event. Huh? So Dr. Pawan has already did the introduction about the kidney transplantation in this country, how it started. Now it has flourished very nicely. Not only that, other types of transplantation also started in this country. And everybody knows throughout the world is the demand is more than the supply. And unfortunately, in this country, it is not been materialized how to increase the donor pool. And very Western country, they have come up with the deceased donor blended criteria and other things. But we are yet to finalize such thing. Highlighting and Mohan Foundation, I remember once we had a transplantation conference over here. They did a very nice job, and I opened up so many people. And we have the critical care person, Professor Suhas Acharya. He's also one of the front runner for this campaign of the disease donor program. And any further information, I would like to ask my co-chair person, our Professor Kafle, Rishi Kafle. He's a renowned nephrologist, to have few words, and then after we'll proceed to the paper. person of Subhash Prasad Acharya. Professor Rishi Kafle.
Yeah, thank you, Dr. Bhola Joshi. Thank you for giving this opportunity to chair in a really a hybrid session. Park Village, your residence, and Chennai, Mon Foundation, and so many speakers from other cities too, from Delhi, Dr. Jana Ananta. So this seems to be a very good session because now we are heading to the development. Transplant is stagnant with the donors. When we are having only live donors, living donors, so we are stuck with the less patients who will be benefited. Time has come to go for the disease donor program. I think Mon Foundation has done a wonderful job. I think much more to be done. So we like to hear today from Mon Foundation team and others what Nepal need to do in this August conference. So Dr. Bhola Joshi, back to you, please.
Okay, thank you, Professor Kafle. Now, I would like to invite Professor Subhash Prasad Acharya. He is the professor in critical care and he is one of the leader in brain death program. And he will talk about the introduction to the brain death pathway. Professor Acharya, please, floor is yours.
Thank you, sir. I would like to thank NAS for giving me this opportunity to come and talk about disease donation pathway. I will be talking slightly different than what we have been talking in the morning and yesterday. So my talk will be about disease donation pathway. So how will we proceeding to a brain death declaration in a patient who is in ICU. These are my conflict of interest. I work for these organizations. As we all know, our Human Body Organ Transplantation Act was implemented in 2055, and where it was written that disease donation was possible. And then Brain Death Act got passed in 2073, and few disease donations have already occurred. If we see the mechanism of brain stem death, this is a common cycle we see. There's neuronal injury, neuronal swelling, raised ICP, and decreased intracranial blood flow. And this is a vicious cycle that goes on. And the point where the intracranial pressure starts to go up and gets more than mapped is almost incompatible with life. The brain becomes insalvageable at that time. So once we suspect a patient is having brain stem death, or we do not see any brain stem reflexes, the first step we do is to try to find or establish an underlying cause for the patient to be brain dead. And the common possible causes leading to brain death that we see in our scenario are cerebral anoxia, trauma, intracranial trauma, head injuries, various sorts of hemorrhage and contusions, intracerebral hemorrhage, and subarachnoid hemorrhage. These are the commonest cause that leads to patients and in waiting for brainstem death. So, and then we need to find out, is there a cause for the patient to be brain dead? Potential cause for brainstem dysfunction? No obvious cause, or if there is any doubt about the cause, we need to be cautious about diagnosing brain death. And we need to make sure that there are no confounders that mimic brain death. Then the second step will be to look for the confounders before proceeding for brain death verification. We need to rule out the following and aim for near normal values. Like these are the preconditions. We need to see that there is no severe hypothermia or temperature less than 32. We need to make sure that there is no severe hypotension, even with or without vasopressor. The systolic blood pressure should not be less than 100. Drugs, alcohol, poisoning, recent use of sedation or neuromuscular blocking agents. They are also confounders for brain death. And other medical conditions like severe electrolyte abnormalities, hypoglycemia, and acid-base abnormalities. These needs to be ruled out first. And the practical tips is there are a few points. Like one, we need to insist on measuring core temperature and not the surface temperature in such patients. We need to look for history of drug overdose, sedation. We need to check the peripheral nerve stimulator, because sometimes if the patient's metabolism in these patients, when the metabolism is prolonged, delayed, the muscle relaxant that has been used like 2-3 days back might be having some effect. So we need to use the peripheral nerve stimulator and see the response. We need to have most recent values of electrolytes, and we need to insist on ABZ at the start of clinical testing with 100% oxygen and pre-oxygen. Before we head toward brain death testing, we need to do all these things. And as we know, brain death criteria is established by the documentation of irreversible coma, irreversible loss of brainstem reflexes, and cessation of respiratory central function, or demonstration of cessation of intracranial blood flow. This is how we proceed. But once we suspect that the patient may have brainstem death, we need to identify all those factors. And there are three essential steps. One is documentation of coma. Next is documentation of the absence of brainstem reflexes, and documentation of apnea test. These are the component of brain death testing. But even though before we go for brainstem death testing, we have to manage this as potential organ donors. So this was a very good review article published in New England Journal of Medicine, and we in critical care mostly follow this. These are the guidelines for disease donation management. Donor management. Temperature, target temperature, we try to keep the patient temperature more than 35, using circulating hot air blankets, warm IV fluids, and adjustment of ambient temperature. Respiratory system, we target FiO2 to maintain the PaO2 more than 100, saturation more than 95%, PaCO2 of 35 to 40, and PS of 7.35 to 7.45. Ventilation strategies, we use similar low volume ventilation, similar to management of ALI, ARDS, so as to not decrease the incidence of ventilator-induced lung injury. Fluid, management of fluid is restrictive. We do not give too much fluid to these patients. We follow restrictive fluid strategy in this group of patients. Cardiovascular system, regarding inotropes, it is dopamine. That's the first choice of inotrope, not noradrenaline. Otherwise, in all ICU patients and at all times, noradrenaline is the first choice of vasopressor. But in potential donor, we use dopamine, because noradrenaline in higher dose like 0.05 mics per kg per minute resulted in impaired cardiac contractility in transplanted hearts and also right ventricular performance. So that leads to problem in heart and lung transplants. And this is how we maintain the hemodynamic goals, targeting mean arterial pressure more than 60, urine output more than 1, and ejection fraction more than 45. If not met, we start dopamine and dobutamine. If not achieved, then only we go for a pulmonary artery catheterization, Swan GANs, and then try to see the cardiac index and pulmonary capillary wedge pressure. And if the cardiac index is less and the CEP is less, we give some fluid. If the cardiac index is okay, we just follow that. And if left PCWP is high, we put on dopamine or dobutamine. This is how we maintain the hemodynamic goals of patients of potential donor. Hormone replacement we usually do after diagnosing or declaring brain death, but sometimes we might have to start before also, because at times the diagnosis of brain death might be delayed by a few hours or even some at times days. So we take this into consideration. Vasopressin, methylprednisolone immediately, and insulin in 50% dextrose, because they are very much sensitive to hypoglycemia. So we give dextrose and insulin to maintain the blood glucose between 80 and 150. And then thyroid hormone thyroxine, bolus followed by infusion. And then once the brain stem death is confirmed, or like we go proceed for brain stem death testing. This, as we know, have to be done by 2 specialists, and this is how we manage. And even after brain stem death testing has been done, we follow the similar principle to manage the donor. Thank you very much. I'll be happy to take any questions.
Thank you, Professor Acharya, for just elaboration, the pathways and how to maintain it. And is there any query from the floor? Time is short, so we'd like to further go. So is there any comment from the Professor Shroff, Sunil Shroff?
Thank you. I think Subhash has done a good overview as an intensivist. We remember doing a workshop with him about, I think, 3 years back. And, I think, the intensivists in your country are very keen to start the program. They require a little bit of support from the system. And I think today's, hopefully, seminar will help to kickstart it. Maybe last time we couldn't do it, but perhaps with the help of our urologic friends, we should be able to start the program.
That's true. Anything from Professor Kafle?
I think he has, Dr. Acharya has elaborated very well. But I think my only concern is that whatever we are doing it, this seems to be a very sensible area, how to convince the people, involve people. Dr. Subhash presented the aspect the doctors and doctors community is doing inside. But we have to learn so much how this is translated to the family members, how this is done in a way that they will be involved from which stage, how critically, how meticulously we have to do it. I think this seems to be a great thing. The art of doing, I think the more discussions will come up.
Yes.
He has elaborated very well. Thank you.
Yes, Dr. Kafle, we have, some counseling session also to show you how it is done. You're right. That the communication between doctor and the patient's relative is very important, because we need to build that trust factor, and the patient's relatives need to believe that the best was done for the loved ones before you can ask for organs. If the patient's relatives are not convinced, then it's a big no. So that first question is that you should have given the best care to the patient's relatives, patient, and the relatives should be happy with the care in the hospital before they will actually consider anything like organ donation. That's the key, Dr. Kafle.
Thank you, Dr. Shroff. It is good.
Thank you, sir.
Yes, now I would like to invite Professor Sunil Shroff. He's a renowned urologist as well as the transplant surgeon, and he's from the Chennai, and he's the main person who started the Mohan Foundation and its activity, and is imparted to so many countries, including Nepal, about the deceased donor program. And he's here to share us, because last time he came and just gave so nice talk. So I would like to ask Professor Sunil Shroff to proceed.
So Subhash has already, elaborated on brain death. I'll just show you a video. I'll do a very short presentation and then show you a video of brain death, and I'll try and keep it as practical as possible, because I know that the audience has urology colleagues and nephrology colleagues. So I will keep it not from the critical care point of view, but more from our surgical and physician point of view, what we need to know. Between birth and death, with birth, you have a very correct time of birth with time and date. However, today you can't say the same with death. The reason I say is because over the last 200-300 years, as medical science has evolved, the diagnosis of death has become even more complicated. Before 1850, to actually declare death, they used to leave the body for decomposition before they could be sure that a person is dead. In 1850 came stethoscope, and they started using that to look, listen to heart sounds and breath sounds. But last 60, 70 years, we have what is brain death, and that has actually complicated death and brought another layer of definition on top of what we call circulatory death or cardiac death. There's another layer which has come called brain death, and that has made death a little bit more complicated. But that has also helped in that situation to make organ donation a reality. So you should look at dying, unlike birth, as a process. In normal death, what happens is you have a circulatory death followed by brain death, followed by death of cells. Whereas in brain death, you would have, what happens is that the circulation is going, but the brain is gone. So, this triangle of dying of cells, the heart and the brain is kind of become independent of each other. One can exist without the other. That's how now death is. And we need to differentiate between normal brain death, and the vegetative state or deep coma. And this is very important as clinicians to understand that a patient in coma is not brain dead. Many times we get calls from intensive cares and doctors that this patient is in coma, is brain dead, can you take the organs out? So you have to find out first, when a person or doctor rings you, what is the cause of brain death? If they don't have a cause of brain death, you cannot diagnose brain death. That is very important. The first question you need to answer, what is the cause? Have you established that cause? Whatever it may be, it's trauma, tumor, whatever. You should have an established reason for brain death. So you need to differentiate. You must remember that brain stem in the brain, you have the whole brain, in which also there is a brain stem. Brain stem is the brain's motherboard. And when your motherboard dies, you die, because there is no resuscitation possible of this brain stem, and you do not wake up and breathe again. And I'll tell you why it is. This slide I've taken from my friend Dr. Dale Gardner from UK. He always uses this as a simple description. Because we follow both in Nepal and in India the brainstem death concept, not the whole brain death concept. Because brainstem is the physiological core of your brain. Why we say that? Because brainstem consists of your three sections of the brain: the midbrain, pons, and medulla. And this is compressed zone of your brain. It carries all the sensory, motor, and other most cranial nerve nucleus from there. Because this is the core which is responsible for your attention, arousal, consciousness. It is responsible for your breathing. It is responsible for your blood pressure and heart function. Without breathing, without your heart, you cannot be alive. So, and this is also responsible for your consciousness. So these are the three areas. That's why it's called physiological core, the brain, and this is where it is. This is your, physiological core, which is important. And if this section dies, you're dead. And, Subash has already told you about the causes of brain death. And in brain death, if you do an isotope study or if you do an angiogram, you'll find an empty skull. There's no circulation within the brain. Indications for possible brain death is when you have increased urine output, patient gets into hypothermia because temperature cannot be controlled, and the blood pressure drops. That is an early indication from possible brain death. So let me just go to a video and show you a video on brain death. Let me share my screen again. Just give me a minute. This is a short video on how you determine brain death. I hope the sound will play. Sometimes the sound is a challenge. Can you see the video?
Demonstrate each one of them.
Is it audible?
Yes, it's audible, Dr. Shroff. Pupillary response to light. A bright pen torch light should be shown into.
So Dr. Ramakrishnan is showing you how to test for brainstem reflexes and how to determine brain death. It's a 4.5-minute video, not very long, so it won't bore you for very long. So let me play it for you. So he's testing the pupillary reaction first, testing cranial nerves 2 and 3. The whole brainstem testing is done to look at all the cranial nerves which are being supplied by the brainstem. So they look at all the cranial nerve reflexes and followed by apnea test to check whether the breathing is spontaneous or not. That's what you do to determine brain death testing.
Each eye in a darkened room. The pupils may not necessarily be fixed and dilated in brainstem dead patients. However, there should be no pupillary response to light. It's normal to expect grimacing of the face to painful stimulation. However, this is absent in brainstem death situation. A firm supraorbital pressure should be used to check this cranial reflex. We will now check for the doll side phenomenon. To do this test, the doctor holds the patient's head between his hands and moves the head from side to side through 180 degrees. He should hold the head to one side for 3 to 4 seconds and look at the simultaneous eye movement to that side. A similar movement is done to the opposite side and the eye movement is observed. If the cerebral hemispheres are damaged but the brainstem is still alive, there will be an obvious deviation of the eyes to the opposite side for a second or two, followed by a release phenomenon when the eyes will get realigned to the side of the head. We are now going to check for the corneal reflex. What needs to be done is taking a moist cotton-tipped swab and applying a firm pressure to the cornea, of course, without damaging it. The patient is observed for involuntary blinking of the eyelids. Let's now perform the vestibulo-ocular reflex, also commonly referred to as the cold caloric test. This test involves.
So what you see is which cranial nerves are tested. Here the cranial nerves 8, 6 and 3 are being tested when he is doing this cold caloric test, vestibulo-ocular reflex, okay?
Involves instilling 20 ml of ice cold water into the external auditory canal and looking at the eyeball movements of either eye for about a minute. No eyeball movement indicates an absence of the reflex. To check the gag reflex, a cotton-tipped swab or a spatula or a Yonkar could be used to stimulate the posterior pharynx to look for the response. We will now check for the cough reflex, and this is going to require a temporary disconnection from the ventilator. The cough reflex is tested by using the bronchial suctioning. Either a closed suction or the open suction method may be used when a patient is having an endotracheal tube. For this test, the patient is disconnected from the ventilator for 10 minutes.
So this is now apnea test is showing. This is the last test as a confirmatory test that a person is actually dead, brain dead. And in this test, we are looking at whether the patient has any respiratory, whether the patient makes any respiratory effort. So this is the most important test. This is the gold standard test, clinical test to determine brain death. It's called the apnea test.
However, to avoid hypoxia to vital organs, 100% oxygen is given for 5 minutes before disconnection from the ventilator. Even during the test period, 100% oxygen is given through a tracheal catheter. In the patient who is brain dead, the carbon dioxide tension increases at a rate of 2 millimeters of mercury per minute during the apnea testing. If the initial carbon dioxide tension before the testing is about 40 millimeters of mercury, then the arterial carbon dioxide tension after about 10 minutes is likely to be 60 millimeters of mercury. This test is often considered as the ultimate test to establish brainstem death. The spontaneous respiratory response fails to occur even in the presence of stimulatory drive from increased carbon dioxide. Declaring brainstem death is, if anything, a very, very sensitive issue that I think every single doctor needs to be cautious, because families still have a significant denial on accepting the concept of brainstem death. And that puts the extra burden on us as clinicians to be doubly sure that all the right process has been followed before we actually declare that somebody is brainstem dead, making sure that there are no abnormalities with the electrolytes, making sure that the temperature is normal, making sure that there is no narcotic medication or sedation on board, are all steps that should be included in our protocol and an algorithmic approach. Therefore, there is no flaw in any of the steps followed while declaring brainstem death.
So this is a very short video and a short talk on brain death, and we'll be happy to take any questions. Subhash also is there in the room. Just to, if I hope, if there's any clarification to be done, we can do that before we go on to the next talk.
Yes, thank you, Professor Saraf, for such a nice elaboration and the video. So I would like to thank, and we have to move on because of the time constraint. Now I would like to invite Pallavi Kumar. Actually, after the following the brain rate and other thing, we say loss of slips between cups and lips. So loss of slips means how relative will handle such a bad approach, bad situation regarding the organ donation. So over to the Pallavi Kumar.
Thank you so much, sir. And I would like to thank the Nepal Association of Urological Surgeons to have invited me. I'm fondly remembering today my visit to Nepal. I think it was last year, January, if I'm not mistaken, just before COVID hit us. So I don't know what the nature of audience is, but my session is going to focus on how do you handle the grief of families who've just lost somebody, and with the objective of asking them and convincing them for organ donation. So very broadly, if you look at the process of organ donation, can everybody see my screen? Is my screen visible?
Yes.
Okay. So very broadly, this is the process of deceased organ donation. You have to identify a donor, then you're going to have to declare brain death, as both Dr. Subhash Acharya and Dr. Sunil Shroff has been focusing on it. Then you approach the family with the objective of obtaining consent. Of course, you're constantly doing donor assessment and management, and then there is organ retrieval and family follow-up. Now, the transplant coordinator, and I think we have a similar terminology in Nepal, is actually involved in all of these processes and juggling multiple things. Yes.
Full screen, please.
1 second, Dr. Shroff.
It is visible, but not full screen, Pallavi.
Okay, is that better, Dr. Kafle?
Yeah, it is fine.
Okay. So the transplant coordinator, as we all know, has to be multitasking, juggling between all of these things. Given the time that I was given today, I am going to be very specifically focusing on how do you approach a donor family. So when do you approach? While the law says that you can declare a person dead only after the second set of tests, I'm sure that's true of Nepal also. But in order to save time and to have enough time to coordinate the multiple things that are required in a deceased organ donation coordination, we usually approach the family after the first test. I tell the person that, we've performed certain tests, there has been no response. The person in all probability is brain dead. We will be performing another test, but this is a time where you can begin to look at, start thinking about organ donations. We start talking about that. Now, I've used a word there called decoupling. Decoupling means that the news of giving death to the family and the conversation of asking for organs are two different conversations and should be treated differently. You cannot say, I'm sorry to say your loved one has died. Do you think you can donate the organs? Invariably, you will get a no. These are two very different conversations. The family has to be given time to understand and accept death. And at a later point in time, when you think they have sufficiently dealt with this news, that you can bring up the conversation of organ donation. Where do you do this? Ideally, hospitals should have designated rooms, because it's a family that is grieving. They're likely to get upset, they're likely to cry, they need privacy, they could get angry. So there should be a specific, if the hospital is serious about organ donation, there should be a special room for this kind of a conversation. Who does the talking? Most definitely the transplant coordinator. But in our approach, we feel that if the treating physician is part of this conversation, it really is effective. If the treating physician and the transplant coordinator together speak to the next of the kin who's in legal possession of the body, it makes for a more effective asking. I want everyone in the audience to remember that when you speak to families for organ donation, you have to remember it is their decision. It is their loss. It is their grief. It is their understanding of organ donation. It is their experience with this hospital. So please understand, it is their decision whether they want to say yes or no. You can only give them information and ask them and encourage them, but you cannot impose your decision on them. And this is something that we must remember, because if we follow this understanding, it shows in our body language, it shows in the words that we use with the family. Who said? Dr. Kafle said. Dr. Kafle said, so, how do we involve the family? At which stage do we have to involve the family? And it was a very relevant question that Dr. Kafle asked, because very often we think that when death is declared, that time you start involving the family in the whole conversation on organ donation. But you must understand that the family's yes or no depends on whatever has happened to them from the moment they've entered the hospital. So did the treating team make them feel involved in the treatment of their patient, of their relative? Did the family, feel trust and confidence in the treating doctors? Did the treating team regularly give them information about what is being done? What is the prognosis? What is the situation? Is it deteriorating or is it becoming better? If they feel involved in all of these processes in resolving conflicts, should we go ahead and do the surgery or not? Should we do this? Then they also feel involved in taking decisions and saying goodbye. So basically the treating team has to build a partnership with the family, because that eventually will help the transplant coordinator, the counselor, and the treating physician to bring up the conversation of organ donation. So what are we really trying to achieve with these conversations that we are having with the family? We are first and most importantly helping them understand brain death and its finality, to let the family know this is death. There's no coming out of it. The person has died. And then you help families to cope with this news. It is a very shocking news for the family that after all of this, their loved one has died. And you help them cope with their grief. Now, grief is not an overnight process. It's not like 1 hour the family will cope with their grief. It is a lifelong process, but you have to help them cope with grief sufficiently enough so that they can at least are in a position to hear and understand your next request, which is your ask for organ donation. So in order to do this, in order to understand this, you have to know your family. You have to understand, who the close relatives are. Okay, this woman has died, but her husband doesn't take the decision. The elder son takes the decision. So you have to start understanding all the family dynamics. What are the interpersonal relationships? What is the socioeconomic status? Is this family likely to bring up money issues? What religion do they belong to? You have to have certain understanding of all of these things. So like the treating team, the counselor also has to build a partnership with the family. At all stages, the family should feel involved in the decision making. Timing is very crucial. You ask quickly, you will get a very quick no. But we all know that in organ donation, we do not have the luxury to wait a long time. So this is something that you have to learn to arrive at with experience. And in this, what becomes very, very important is to understand stages of grief. Now, you must understand that not all families go through all of these stages, and not all families will necessarily go in this order. But as a person speaking to families undergoing grief, you need to be alert to understanding some of these stages and its symptoms. One of the most common symptoms is denial, where the family is refusing to believe that death has happened. What are you saying, doctor? I can see the heart beating. It can't be death, that the person is still alive. So in that stage, you definitely cannot ask for organ donation, because the person has not even accepted death. Where can you even begin your conversation on organ donation? So when the family is in denial, you do not start talking about organ donation. Anger. Very often families get very angry with the hospital or with themselves. I've had families say, oh, you know, I'm so angry with myself. I took my wife to a smaller hospital. We wasted so much time. Or they could be angry with God or just angry with their fate. So when a family is angry, they are too caught up with their anger, and they cannot be listening to your conversation about organ donation. So that again is not a good time to speak about organ donation. Bargaining. Very often families will say, do whatever you need to do, doctor. I will give you whatever you want. Or they'll say, do you think we can take a second opinion? Do you think that will help taking him to a bigger hospital? So all of these things again go to point out that the family has not accepted that. They're still hoping that something someone will do that will help them save their patient. Again, not a time for you to ask for organ donation. Then you will see families becoming silent, you know, huddling together. They start crying, and they start maybe some of them become very quiet and reflective. And you know that now they are slowly coming to the understanding that maybe we've lost our loved one, and that's maybe the end has come. And finally acceptance comes. And very often families will ask you, now what, doctor? Ab kya karna hai? And you know, now they have understood. They've understood that death has happened. Now they're asking us, what are the next steps? Do we get the body back? They start calling up other relatives. They start talking about end rights. And now you know that the family has accepted death, and you have to then start planning how you will talk about organ donation. So this is a special family. Please understand, all families are special, but families who've lost their loved ones are even more special. And families that you're expecting to take decision on organ donation, you're placing a whole lot of burden on them. So this family needs time, your time, to understand, you know, the whole conversation, to discuss with other family members. They need your attention because they are going through a lot of turmoil, and they need your care about how you're talking to them, how you're giving the how you're presenting the information, how are you asking about organ donation. It has to be done very, very sensitively, because please remember, for you, it's just one more patient and one more death. For this family, this day will live on for all their lives. So it's important to understand where this family is. And these are some questions, we call them open-ended questions, that we suggest that counselors and doctors ask the families. Things like, a lot has been told to you. What have you understood? You know, it must be a lot of confusing information. So very often families will say, yes, the doctor said there are no brain reflexes, and my loved one will not survive. That means they still are not understood death. So it's important to ask open-ended questions so that you establish that the family has understood and accepted death. Please avoid using jargons like, oh, I know how you feel. I know how, you know, what you're going through, because please remember, you do not know. You've not lost your loved one. It is this family, and don't belittle their grief. Don't belittle their loss by saying just empty things. It's sometimes good to just keep quiet. It's sometimes good not to say anything at all. Most definitely do not make false promises. Oh, we will hand over the body to you first thing in the morning. You cannot decide when the body will be handed. There are multiple departments involved. You know, you have to have a discussion with all the people involved in the process, and together take a decision of what time the body will be handed back to the family. And if the team has decided 8 o'clock, please tell them 10 o'clock. It's okay if you give the body back early. You know, waiving of hospital bills, who will get the organs, all of these things you are not allowed to tell the family. So please do not be honest in your conversation at all times. And families will still say no, and these are some of the most common reasons why families say no. They just do not understand organ donation. They still think some miracle will happen. There are some religious reasons that prevent people from donating. There is fear of what the body will look like. Of course, there's a huge distrust in the medical community, especially in the private hospital. We have to understand and respect that. And you know, there could have been unpleasant events in the hospital during the treatment, or like I said, the treating team did not keep them involved, did not tell them what was happening, did not make them partners in the whole process. So very often these reasons make families say no. So what happens when you get a no? You continue to be respectful and caring. There have been times in my own personal experience, a family has said no, but I've continued to handhold them for some other things, you know, to get the body back or some administrative formalities. And in all of that, the family has turned around and said yes to organ donation. And also remember, no does not always mean your failure. It's not about you. It's about this family. And for whatever reasons they could not say yes to the ask, please make sure that you do not make the family feel guilty about the fact that they could not say yes. This is a very favorite picture of mine. That little cat is a transplant coordinator, and that's your admin team and your critical care staff and your neurologists and your transplant teams. And sometimes it can be very, very overwhelming for the transplant coordinator, but please understand, he or she is a very important person in this whole process, and you have to support her or him so that they can do their work well. Thank you so much. I'm going to show you, we made a film on right and wrong approaches of counseling a family. Of course, we don't have the time to show the whole film, but I'm just going to show you some clips. 1 second, sorry. Just give me 1 second.
If anyone has any questions from the audience, you can ask now, or we can, while we're waiting for it to load. Do you want me to load it, Pallavi? Are you able to load it? Yeah.
No, I got it. So 1 second. So this is a 22-minute film. I've just taken short excerpts out of it. It's going to show you right and wrong approaches of how you approach a family, a donor family. So the first one is a wrong approach. Let's see what happens here.
Come in. मैडम बेड नंबर 5 के पेशेंट की फैमिली आपसे बात करना चाहते हैं. वो कई घंटों से वेट कर रहे हैं. क्या मैंने बुला लूं?
हाँ, अभी थोड़ी देर में बात करती हूँ. अच्छा, बुलाओ.
ओके मैम.
Is it audible to all of you?
Is it audible?
Yes, it is okay.
So what did we see here? You know, that the nurse has come to the doctor and saying the family wants to speak to you. And, you know, the doctor is clearly involved in other things. She is clearly not stopped herself from doing what she was doing to really give time to what this family is all about. And that's clearly not the right approach to go to a family. Let's look at how it can be done properly.
मैडम वो पेशेंट की फैमिली से मिलना चाहते हैं. पेशेंट की कंडीशन के बारे में कुछ जानना चाहते हैं. क्या मैं उनको बुला लूं?
हाँ, मैं उनसे अभी मिलती हूँ. ज्योति को तुम जानती होगी, हमारी ट्रांसप्लांट कोऑर्डिनेटर, जो पेशेंट से, फैमिली से ऑर्गन डोनेशन की बात करती है. तो ज़रा हम पहले डिस्कस कर लें कि हमने फैमिली से कैसे बात करनी है. तो फॉर आवर अंडरस्टैंडिंग, राजीव इज़ अ 44-year-old मेल जो 2 दिन पहले हमारे आईसीयू में सबअरेक्नोइड हेमरेज के बाद एडमिट हुआ है. उसके सारे टेस्ट हो चुके हैं और ये कंफर्म है कि वो ब्रेन स्टेम डेड है. जैसी थोड़ा फैमिली के बारे में बताओ.
पिछले 2 दिनों से फैमिली आईसीयू के बाहर ही खड़ी है. उसकी वाइफ काफ़ी अपसेट है. उनके 2 बच्चे हैं, एक 12 साल का लड़का और एक 15 साल की लड़की. पेशेंट के पिताजी और उनके बड़े भाई यहीं पर हैं और पेशेंट की माँ बच्चे को लेकर घर गई हुई है. फैमिली काफ़ी परेशान है और अभी जानना चाहते हैं कि पेशेंट के साथ क्या हो रहा है.
ज्योति, तुमने पेशेंट के नोट्स पढ़ लिए होंगे. पेशेंट ऑर्गन डोनेशन के लिए सूटेबल है और अब हम उनकी फैमिली से बात कर सकते हैं. हमें ये सोचना होगा कि उनसे बात कैसे की जाए. मुझे लगता है कि हमें कुछ समय बिताना होगा उनको ये समझाने के लिए कि हमने सारे टेस्ट करने हैं.
If you can stop and start, you know, just stop it for a second.
Yeah.
2 seconds, where sometimes, you know, it loads in the background, and then if you start, it'll be okay. Yeah, play again, see how it goes.
मतलब क्या है, और वाकई में राजीव मर चुका है. जब मैं फैमिली से बात कर रही होंगी, अगर तुम्हें लगा कि कुछ मिस हो रहा है तो तुम ऐड कर सकती हो. हम दोनों एक साथ ये समझ पाएंगे कि उन्होंने पेशेंट की डेथ को एक्सेप्ट कर लिया है कि नहीं, और उस हिसाब से हम लोग आगे बढ़ेंगे. अगर मुझे लगता है कि उन्होंने सब कुछ ठीक ठाक एक्सेप्ट कर लिया है, दे अंडरस्टैंड एवरीथिंग, तो मैं ऑर्गन डोनेशन की बात को शुरू करूंगी और तुम फिर उसको आगे ले चलना.
और अगर मुझे लगा कि फैमिली काफ़ी परेशान लग रही है और शायद पेशेंट की कंडीशन को ठीक से नहीं समझ पा रही है, तो क्या ये ठीक रहेगा कि हम उस समय एक ब्रेक ले लें और फैमिली से थोड़ी समय के बाद बातचीत करें?
हाँ, मुझे लगता है यही सही रहेगा।
एंड डिपेंडिंग अपॉन द सिचुएशन एट दैट टाइम हम डिसाइड कर सकते हैं कि ऑर्गन डोनेशन की बात उठाएं या नहीं।
मैम, मुझे लगता है कि फैमिली को अभी ब्रेन स्टेम डेथ के बारे में समझने में थोड़ी मुश्किल होगी।
एक से है ना पल्लवी, उसको रोक लो एक बार। हाँ।
Yeah, now I've stopped it. So as you saw, they are sitting together and planning what conversation they will have. The first they took some time to understand the family dynamics, and then they decided what each one of them will say, and depending on how the family will react, what they will do next. So it's a very planned approach, and that is how. And in fact, much more time needs to be spent. It's just a simulation. It's a film. So, but before you start talking to the family, you need to know what this family is all about, who all are in the family, who do you think is likely to take decisions, what are they going to say. Nurse felt that they may not understand brain death very easily, so the doctor says, okay, we'll spend more time doing that and we will not bring up the organ donation conversation. So this is the planning stage. The next that I'm going to show you is the wrong approach of talking about organ donation, because that is what you need to do. You need to ask for organ donation, but just see if it was done properly. So the doctor has come again after their first conversations on brain death and all.
हाँ, नमस्ते, बैठिए। नमस्ते मिस्टर अरोरा, राहुल, मिसेस अरोरा। मुझे आने में थोड़ी देर हो गई, आई एम सॉरी। मुझे पता है आप काफ़ी समय से मेरा इंतज़ार कर रहे हैं। एनीवे, नर्स जैसी को तो आप जानते ही हैं, ये ज्योति हैं। तो जैसे मैंने सुबह आपसे बात की थी कि हम राजीव पे कुछ टेस्ट करेंगे उनका बचा कुचा ब्रेन फंक्शन को असेस करने के लिए, तो वो जांच हो गए हैं और मैंने उनके परिणाम देख लिए हैं, मैंने डिस्कस कर लिए हैं अपने सीनियर से, अपने कोलीग से, और मुझे आपसे कहना है कि उनके ब्रेन ने काम करना बंद कर दिया है। आई एम वेरी सॉरी।
ब्रेन ने काम करना बंद कर दिया? ये आप क्या कह रही हैं डॉक्टर साहब? मुझे तो कुछ समझ में नहीं आ रहा।
इसका मतलब है वो ब्रेन डेड है।
मुझे तो विश्वास नहीं हो रहा।
एक मिनट रुको बेटा, मुझे नहीं लगता कि वो किसी भी दर्द में है। ऐसा लगता है कि जैसे वो अभी सो रहा है।
You're right, पापा। यहाँ तक कि नर्स ने कहा सब कुछ ठीक है, और अब आप हमें कह रहे हैं कि वो नहीं रहा। और इस ब्रेन डेड से आपका क्या मतलब है?
मुझे पता है ये समझना मुश्किल है। राजीव का दिल धड़क रहा है, वो वेंटिलेटर पे है, पर कानूनी तौर से वो ब्रेन डेड हैं और वो बच नहीं सकता है।
मैं इसके बारे में कुछ नहीं जानता और मुझे कुछ समझ में नहीं आ रहा।
इस सिचुएशन में मुझे एक बात और आपसे करनी पड़ेगी। हमारे हॉस्पिटल की पॉलिसी है कि ब्रेन डेड पेशेंट की स्थिति में हम फैमिली से अंगदान की बात उठाएं।
अंगदान?
मैं अब वो नहीं सुन सकता। बस बहुत हुआ।
So what was happening here? You saw that, the doctor has come. There was not even an extra chair. She was standing as if, I don't have time for this. I just want to say what I want to say and I'm going to leave. She kept talking about brain death, legally dead. But at no point did she help the family understand what brain death is and that it is death, So the family is clearly in denial. The father is saying, it looks like he's sleeping, all of that. And knowing that the family is in denial, she brings up the topic of organ donation. And in such an apologetic manner, we are under these circumstances, we have to bring up this topic. So obviously this family will not take to this conversation very well. This is going so wrong in every which way. So let's see how this whole situation can be recreated and done better.
नमस्ते मिसेस अरोरा, राहुल, मिस्टर अरोरा। आप सब मुझे जानते हैं, जैसी से भी मिले हुए हैं। मैं आपको ज्योति से मिलवाना चाहती हूँ।
हेलो मिसेस अरोरा। हेलो।
ज्योति हमारे डिपार्टमेंट में काम करती हैं और ऐसे समय में परिवारों की सहायता करती हैं।
If you notice in the previous time, she didn't even say who Jyoti is. Why suddenly one new person has come in the whole conversation, and there was nothing to explain, why she's here. Here, they're not talking about her as a transplant coordinator. She's not being introduced as a transplant coordinator. She's introduced as a counselor who works with families in such difficult times.
सुबह मैंने आपसे कहा था कि हम कुछ टेस्ट करेंगे, वो हो चुके हैं। मैं ये जानना चाहती हूँ कि अभी तक की स्थिति को आप कितना समझते हैं। मुझे पता है कि आपने कई लोगों से डिस्कशन की हुई है।
मुझे पता है डॉक्टर कि राजीव के ब्रेन में बहुत ब्लीडिंग हुई है और अब कुछ टेस्ट भी करने जा रहे थे ये देखने के लिए कि उसका दिमाग अभी भी काम कर रहा है या नहीं। क्या ये सही है?
हाँ, ये बिल्कुल सही है।
तो क्या हो रहा है डॉक्टर? टेस्ट कैसे हुए? वो ठीक तो हो जाएगा ना?
तो मैं आपको इन टेस्ट के बारे में थोड़ा बताती हूँ। असल में इसका मतलब क्या है। दरअसल हमने बहुत ध्यान से राजीव के दिमाग की हरकतों की जांच की है, लेकिन अनफॉर्चुनेटली हमें कोई भी प्रतिक्रिया नहीं मिल रही है उनकी तरफ से, यहाँ तक कि गहरी स्टिमुलस देने पर भी नहीं। हमने 10 मिनट के लिए वेंटिलेटर को डिस्कनेक्ट किया, लेकिन इस दौरान उन्होंने सांस लेने का बिल्कुल भी प्रयास नहीं किया। आखिर में हमें ये पता चलता है कि उनके ब्रेन के फंक्शंस हमेशा के लिए चले गए हैं। वो कभी सांस नहीं लेंगे, वो कभी कॉन्शियस नहीं होंगे। मुझे बहुत दुख है, लेकिन राजीव की मृत्यु हो चुकी है। ही हैज़ डाइड।
उनकी मृत्यु हो गई है? मैं इस बात पे विश्वास नहीं करती।
मुझे समझ में नहीं आ रहा, इसका कोई मतलब नहीं बनता।
सही कहा पापा। यहाँ तक कि नर्स ने कहा सब कुछ ठीक लग रहा है और अब आप हमें कह रहे हैं वो नहीं रहे, वो मर गए।
आई एम सो सॉरी, राजीव मर चुके हैं। देयर इज़ नो ब्रेन फंक्शन। इस स्थिति को पलटाया नहीं जा सकता। वो कभी वापस नहीं आएंगे।
ये आप क्या कह रही हैं डॉक्टर साहब? उन्हें कभी होश नहीं आएगा और आप कुछ भी नहीं कर सकती।
कुछ तो तरीका होगा आपके पास, आप कुछ तो कर सकते हैं। उसको आप ऐसे नहीं छोड़ सकते।
देखिए, हम जानते हैं कि जब दिमाग में खून का बहाव नहीं होता है, इवन फॉर अ फ्यू मिनट्स, तो इंसान बहुत जल्दी मर जाता है। ऐसे में राजीव के दिमाग में भी खून का बहाव नहीं है, और वो भी कुछ घंटों से। उनका दिमाग मर चुका है, राजीव मर चुके हैं। वो सिर्फ वेंटिलेटर से कनेक्टेड हैं, और इसीलिए समझना और मानना बहुत मुश्किल है, क्योंकि उनका शरीर अभी भी गर्म है, उनका दिल धड़क रहा है। बट इट इज़ वेरी क्लियर कि राजीव मर चुके हैं।
ये क्या कह रहे हैं डॉक्टर साहब? मैं ये नहीं मान सकता कि आप कुछ नहीं कर सकते।
हे भगवान, मैं बच्चों को क्या बोलूँगी?
मुझे समझ आ रहा है कि ये सभी के लिए बहुत ही मुश्किल है, और मुझे लगता है कि आप सबको आपस में कुछ समय साथ बिताना चाहिए, और हम कुछ समय बाद फिर मिलते हैं। So as you saw that this family was taking a lot more time to accept and understand, and the wife seemed to have understood that the death, she said, "What will I tell children?" So that means there was some understanding that the wife had kind of accepted it. So the conversation of organ donation, I'm not showing the rest of the film because there was very little time given to me, but so we don't have to rush with that conversation, is what we are trying to prove with this film. You give a family enough time to understand and accept death. Organ donation conversation can happen a little later. Some families may not need so much time. They may, there are times some families, we give them the news of death, the acceptance is so stoic that sometimes in another 5-10 minutes, we are, even though it should not happen the same time, we start talking about eye donation and other things and move to organ donation. So I'm happy to share the entire film. It can be shown in some other forum, but if there are any questions from the audience, I'm happy to take it.
So we have actually done well so far. I think I would say that to chairpersons, because we still have a few minutes. If there are no questions, obviously we'll move forward. But I think it's a good way to show that what Dr. Kafri asked, not to hurry up things, how to decouple, let the family take time before they decide about organ donation. That conversation, that support to the family needs to continue. Even if they say no to organ donation, as Pallavi says, that support needs to continue with the family. And many families in that kind of denial will not say yes, but eventually once they understand the reality of the situation, then many families will turn around and say, please go ahead with organ donation. Believe me, don't take no as a no. Just keep them supported and don't ask for organs after that. You ask once, your conversation stops. You just keep the family supported. That's very, very important.
Sure.
Make sure that you are doing the best for the family. That's very important. That's the key in the whole organ donation counseling technique, to be able to, get the trust of the family and to keep the family supported in their decision to donate. That's the most important thing. Don't be like a vulture. Don't be greedy. Don't be hungry. Don't get into the pressures from your managers that organization करना ही है इसमें. It doesn't work like that.
Doesn't work like that.
Thank you, Professor Sraf, for just highlighting everything. And I would like to thank Pallavi Kumar for such a nice video and when to talk, when not to talk, and the transplant counselor role is there. So we'll be having lots of discussions in the panel discussions. Now we'll be moving forward, and I would like to invite Sumit Acharya. He is from our Dharma Bhakta Center, that's the transplantation center. You will be to take or not to take the kidneys, the indications and contraindications.
Good afternoon, respected chairpersons, seniors, and dear colleagues. I am Dr. Sumit Acharya. I am going to discuss about whether to take or not to take the kidney in brain dead kidney transplantation. Ideal donor, when we have consent available, age less than 60 years, serum creatinine within normal range. There is no history of chronic kidney disease. Serology tests hepatitis B, C, and HIV are negative. There is no evidence of sepsis and no evidence of malignancy. Donor not eligible for donations are the age greater than 70 years, age 50 to 69 years with history of type 1 diabetes for more than 20 years, polycystic kidney disease, glomerular sclerosis, about 20%, terminal serum creatinine greater than 4, there is chronic renal failure, and there is no urine output for 24 hours or longer. We have to exclude some specific infection, active bacterial infection, active viral infection, active fungal infection, active parasite infection, and active infection. And the disease we have to exclude are aplastic anemia, granulocytosis, current malignant neoplasm, except non-malignant skin cancer, previous malignant neoplasm with current evidence of metastatic disease, history of melanoma, hematological malignancy like leukemia, lymphoma, or when there is a living donor. There is much more time to test the kidney and plan the surgery. Sometimes even the living donor kidney do not function well in the short or long term, but the risks are greater with diseased donor to use marginal kidney with informed consent. This is also true for our region because there is lack of awareness and we only get few disease donations. So we may land with marginal kidney as well. Marginal or expanded criteria donor means users of suboptimal quality cadaveric kidney graft, non-heart beating donors, and donor with some acceptable medical fix. Regarding the expanded criteria donor, the donor age is over 60 or over is 50 with history of high blood pressure. Definitely, about 17 out of every 100 kidney now used in transplant come from this donor. Although the short and long-term outcome with such graft were inferior to normal criteria kidney, it has significant survival advantage over the waitlisted dialysis patient. We can see the Kaplan-Meier curve where the line of the disease donor is above the survival line of dialysis patient. Standard donor kidney in 1 year. About 5 out of 10 expanded donor kidney are still working at 5 years compared to 7 out of 10 as usual donor kidney at 5 years. So when the kidney is allocated, so everyone talk about how good is a donated kidney, but we have to keep in mind all the kidney from disease donor are not the same. Most disease donor of any kind have less than perfect kidney. There are no brand new kidneys. All the kidneys are used and many disease donor have had medical problems that may have affected their kidney functions. And should we accept all the kidney? No. Transplant center may not affect kidney from accept kidney from some disease donor if the doctor has doubt about the quality more, such as low blood pressure or clotting in the blood, long-term medical problem in the donor that might have damaged the kidney, and how long the kidney has been kept out of body after it has been removed from the diseased donor with old goods when the organ is transported from region to region. So there is always some uncertainty in choosing a diseased donor kidney. It may be hard to be sure of quality of many diseased donor kidney. The doctor cannot always predict how well a kidney will work after it is transplanted. Some kidneys that work well may not, and some that are not used for a transplant might have worked well. So they have come up with kidney donor profile index. It is a numerical measure that comes 10 donor factor in B. What first of the kidney donor risk index is calculated, and a tabulated mapping is done to calculate kidney donor profile index. The parameter which is used are age, height, weight, ethnicity, history of hypertension, history of diabetes, cause of death, serum creatinine, HCV status, and donation after circulatory death. So what is good KDPI? The majority, 65% of the diseased donor kidneys have KDPI between 21 and 85% and are expected to function for about 9 years. And KDPI exceeding 85% are expected to function for more than 5.5 years. Identification of the potential donor, early confirmation of brain death, consent, prompt notification of retrieval team, careful and intensive management of the donor, and rapid retrieval of the organ. So with this, thank you.
Now I quickly go over to the Professor Sunil Shroff regarding the kidney retrieval, bench dissection, and transportation. Now we have started the disease, liver transplantation in this country as well.
Thank you. Am I audible? And can you? Sorry.
Yeah.
So I was just wanting to know, I hope, in Nepal, many more,
full screen.
Many more urologists are starting to look at disease donation and are getting involved with transplant program. I don't know what the number currently is. In India, I know that with living kidney transplants, the number of urologists involved in the kidney transplant program was a lot less compared to now. With disease donation happening, many young urologists are getting into the program with a lot of interest in this whole program. So I urge all the urologists to start looking at kidney transplantation as a subspecialty and start working towards getting trained if they're not trained already in kidney transplant. The way to go forward would be to start asking your nephrology colleagues to start giving you some fistulas to do and get trained in some vascular techniques, and then you can start doing transplant. So I'm going to briefly talk to you on surgical techniques for retrieval, bench surgery, and transport for disease donation. If you look at the global organ transplant activity in 2018, there were 95,000 odd kidneys which were transplanted of the 146 odd solid organ transplants in the world. There was a 6% increase. If you look at the Indian transplant activity, we have been going up from 2013 gradually, and we today have 8 per million, 8.8 or 9 per million donation rate in the country of all organs, kidney, heart, liver, lung transplants. And if you look at the global figures for 2019, India did the highest number of kidney transplants in the world. After that, only it was US and other countries. So we have a lot of experience in India, but mostly it is with the living kidney transplant. The disease donors kidney transplant also in the world, as far as numbers is concerned. I'm not talking about per million. India is among the top 10 countries in the world today. So India has a very large experience, and the surgical skills for the last 50 years have improved. We do a lot of lap and robotic donor nephrectomies, robotic transplants as well. A lot of experience has been gathered over the years. So what should you do before you start retrieval of kidneys? You must, as a surgeon, make sure that the donor consent from the family is there, it has been signed. Organs for which consent has been obtained is there. You must check the brain death certificate. You must check the hepatitis status, blood group, and also check the last few hours of hemodynamic status and urine output of the donor. That will determine if your kidneys are going to work in the recipient or not. In the case of medical legal case, make sure that the forensic team is involved, especially if there's going to be a post-mortem. Make sure there's no money demanded by the family members for organs, and ask the coordinator to take histories like dog bite, drug abuse, and so on, which may be missing. Make sure the form, for brain death has been signed by the required people. Look at it yourself. Make sure the consent form has been signed. These are all very important, so that you don't miss out anything. If there's a lean and thin patient, long midline incision from Zifi sternum to pubis is good. If in multi-organ retrieval, if there's heart, liver going and so on, the incision can go to suprasternal notch and you can split the sternum. You can get the help of your cardiothoracic friends. But if you're doing kidneys alone surgery, only kidneys in an obese patient, then you can either give bilateral rooftop or a cruciate incision, a crisscross incision to take out the kidneys. And these are the key steps. Before I show you the video, I want to just take you through some key steps of kidney retrieval. So these are 10 steps. First is the mobilization and control of the suprarenal portion of the aorta and the intravena cava. Then there's mobilization of the infrarenal section of the aorta and IVC, followed by cannulation of the aorta and IVC and use of heparin. Then there's in situ perfusion we use in India mostly STK solution. And then you need to also vent out the blood. Mostly we vent it out in the chest or through the IVC. Then removing of the kidney from the abdomen, followed by bench dissection and separation of the kidneys, and then perfusion of the kidneys on the bench to check for any leaks before you give them for transplantation. And then you can also remove lymph nodes and spleen so that you can get some lymphocytes in case your blood is not adequate for cross match. Then you need to, if you're sending a kidney to another center, then you need to pack the kidneys and then do documentation and then transportation. These are the steps. So when you do a laparotomy, first we need to open the abdomen, make sure, look at the organs, make sure there's no peritonitis. Sometimes you can get surprises. Liver can be fatty. You may have a horseshoe kidney. You may have double ureters. So look for that. The next step is exposure of the retroperitoneum. This is a key step in your dissection. And you need to move both the colon and small intestine, both the right side and left side. And you need to divide the mesentery from DJ flexure right here, divide it down, come down and bring your incision down, just like the red line is showing. And then extend the incision around the, appendix, and then move towards, the lower border of the liver and join it with the DJ flexure. And then you go around the descending colon. So this is your incision line on the peritoneum, which you need to do so that you can go into the retroperitoneum. Once you've gone into retroperitoneum, look, the avascular plane opened on both sides and the ureter is identified lower down above the iliac crossings. It is dissected out and taped. You need to cauterize the duodenum. Then you must make sure there is enough fat around the ureter. And then posteriorly, the kidney can be mobilized by dividing the urotas. Once you mobilize the kidneys, then you put a lot of sterile ice slush, pack it around the kidney for surface cooling. Remember that just to recapitulate the anatomy of the aorta, it enters at T12. It lies medial and posterior to the esophagus. This is the esophagus, and it is medial and posterior to the esophagus, the aorta. Aorta here is in blue, not in red. Remember that. This is aorta here. It enters the abdomen behind the median cruciate ligament, and so To reach the aorta, you have to mobilize the abdominal section of the esophagus, encircle it with the tape. This needs to be encircled with the tape, the esophagus. You need to divide the left triangular ligament of the liver, and the crust of the diaphragm should be divided before one can encircle aorta comfortably with a right angle. So this is the crust of the diaphragm, which you need to divide to encircle the aorta if you want to encircle the aorta. You need to use a deaver, or a self-retainer to visualize this section of the abdomen, which is deep inside, especially in an obese patient. Then you do the infrarenal section of the aorta and IVC. You divide the inferior mesenteric artery and vein, expose the aorta to bifurcation, sometimes to the left common iliac artery. Blunt and sharp dissection is done. Aorta is encircled in the infrarenal section. Then the IVC is similarly encircled. And then you put the cannulas, and then those cannulas into the aorta and into the IVC. Don't, push the cannula too much, otherwise it'll go into the chest. So you must just put it so that, it is just below the renal artery. And then you can put a DeBakey clamp, make a small arteriotomy, and you should have a non-collapsible cannulas if you want. Doubly ligate, especially for the artery, otherwise it tends to slip. Do the same kind of maneuver for the IVC as well. So having told you all this, let me take you to a video to show you how it works. So in this video, what you're going to see is incision for kidney alone and also for multi-organ. Because most of the times these days, because the liver is taken, you will be involved with multi-organ, retrieval. So you need to know both the steps. So I've tried to capture 2 videos into one video to show you more or less both the steps. So this is the incision you'll use in a lean and thin patient for kidney alone retrieval. So, leafy sternum to pubis, as I said, go around the umbilicus, midline incision, and you open the abdomen.
Midline incision.
And now, in the multi-organ retrieval, the incision goes right up to the chest, as you see here.
Starting from the sternal notch to the pubis is made. The sternum is divided, and the thoracic organs are exposed.
If you have a cardiothoracic surgeon, it's good to have him even if you are doing kidney alone retrieval, because he will help you to open the chest, and it is very easy to vent out the IVC into the chest rather than putting a cannula into it.
Retractor can be used, and the pericardium is divided to expose the heart and the pericardial cavity. The falciform ligament is divided. The right colon is mobilized.
So this is, sorry. Let me take you to a independent video 1 second. Be easier for me to show you control the video that way. Please bear with me. Let me share it again. You can see the video. I'm going to now control it better.
Left renal vein can be seen. The superior mesenteric artery and the colon, along with the small bowel, are rotated medially.
So this is the step I told you that you need to rotate the. I showed you those red lines.
The superior mesenteric artery should be up.
So the superior mesenteric artery is the key artery, especially for multi-organ retrieval. But if you are only doing kidney and non retrieval, you will not see the superior mesenteric. You can avoid it.
Reflected superiorly, the superior mesenteric artery should be isolated at its root and encircled with a vessel loop. The inferior vena cava and the left renal vein can be seen.
So now, this is the key step in multi-organ retrieval, but only if you're doing kidney alone retrieval, then you don't need to do all that. You do a suprarenal control of the aorta, you do an intrarenal control of the aorta, and get on with seeing the kidneys and looking and removing it, either together or individually. So this is a retroperitoneal, dissection. You'll see the IVC and the this inferior mesenteric artery and vein which is being divided. And now you see the aorta and this is the aorta here, and there's the inferior vena cava here. And you see the tapes.
Left lobe of the liver is mobilized to allow.
And now you are going to the suprarenal portion to
for exposure of the supraciliac aorta. This is done by division of the gastrohepatic ligament. Care should be taken to palpate for an accessory left hepatic artery as shown here. Cruces of the diaphragm are divided, and the stomach is reflected to the left to allow for exposure and isolation of the
this is a slightly difficult step because you're not used to that area. So you can take a little bit more time to dissect this area, especially to identify the crust. If you have done vagotomy, then you can encircle the aorta and use the tape to move the aorta away, move the esophagus away, and then you see the crust of the diaphragm, and then you need to divide the crust. You can actually feel the aorta, because heart is still beating in this situation, as well as in non-heart beating, where the heart has stopped and heart has been taken out, you won't feel it. But when you do kidneys alone retrieval, the aorta will be still pumping blood, so you can actually feel the aorta, and then take the crust and divide it, feeling the aorta also. You can do that.
Ciliac aorta.
Once the suprarenal control has been done, then you can clamp your aorta, make a small incision, put the cannula for in situ perfusion. So I got the ligatures inside. See the pumping of the aorta, and now you'll see the cannula going in. These are the non-collapsible, cannulas which you can get from your cardiothoracic surgeons, and then push it in. And then double tie it. And then once you're done that, perfusion will start. And same way you do for the vein. If you're not venting out in the chest, then you suck out all the IVC vein, and then you start running your fluid for perfusion, inside to perfusion, till the kidney start getting pale. And now here you can see these kidneys are gone pale, and then you start dissecting the kidneys, and this is the IVC. So if you are initially, you can actually take out the kidneys separately, just like you do in a nephrectomy, living donor nephrectomy, same way. You can see here the two branches of the renal vein here. You can see the two kidneys. So if you want, you can individually also take out each kidney and do the separation on the table itself. But once you get experience, then you can take it out en masse and do the separation without letting it get warm on the table also. But remember that you can put a lot of ice and slush, so the kidneys are already cold here. So you don't have to worry too much. Divide the interior and posterior wall of the IVC. When you're dividing that, be careful that you don't divide the right renal artery, especially when you're dividing the posterior section of the IVC, where the artery will be right behind it, the right renal artery. So be careful about that. There's a lot of tissue which you need to divide before you actually remove. You can remove the kidneys, because posteriorly, and a lot of lymphatics which you need to divide. Just remember that. You can see all the ostium or the kidney when you divide the aorta anteriorly, and then you can divide posteriorly. Keep enough patch available for the aorta. On the aorta for both sides, see I'm dividing here both right and left. So you see so much of patch is there, and you can see the ostium here. So that when you actually use the kidney, you can have a good spatulation and a good patch on the aorta, so that your stenosis chances and all are so less. And if you have multiple arteries, then all can be on one patch. I've had almost 3 or 4 arteries sometimes on one patch, and we have actually put the whole patch on the external iliac artery. Once you're divided both the aorta, once you divide the aorta and the IVC, then you just remove each kidney and bring it on your bench. I hope there is some clarity with this, as much as I could show you in this short time. You can also do end block removal. It's a similar kind of situation, but here you have to divide the gastrohepatic omentum with the portal vein, bile duct, and hepatic artery to expose aorta and IVC. And then you can also do an end block dissection and take out both the kidneys together. Since we don't have time, we just go to the bench dissection. Once the kidneys are on the bench, it is important that you separate there are 2 steps here. One is that you must make sure that the kidney is well perfused on the table. If it's not well perfused, get the kidney perfused, and then you start doing the bench. And the idea of bench is that you should have enough length of your vessels, both the artery and vein, so that you are able to do a proper anastomosis on the patient. If there are 2 arteries, you can do all your bench work and make sure you can make them one by doing a pantolin or whatever you want to do. Same thing with the vein. So that's the whole idea of bench. On bench, the kidney is in ice. Even if you take half an hour, it doesn't matter. Even if you take 45 minutes, it doesn't matter, because the kidney is in ice. It is still cold. It is not warm. So it takes your time on the bench. Normally in living donation, we don't do a lot of bench work, but in deceased donation, since you don't know the anatomy beforehand of the kidney, it is very important to do the bench work. And I use a lot of mosquito artery forceps to feel for extra vessels and so on. I don't use so much of scissors. I use scissors very gently in this situation. Be very sure that you don't inadvertently divide some artery or vein. And after you've done this bench work, after you tie the smaller vessels, then what I normally do is I will perfuse the kidney again, and I look for leaks, especially in the vein. I will pinch the vein with a forceps and see if there are any leaks. If there are any leaks, I tend to make sure that all those leaks are tied before I take the kidney onto the patient to do transplant. One more thing which I want to stress about is how you pack the kidney, especially if you're sending it to another location. You must remember that the inside pack should only have cold solution and not ice. Many people put ice inside the bag, and that will freeze the kidney. It will harm the kidney more. So make sure that if you are using, if you are sending the kidney somewhere, or if you're packing the kidney, let me see why this video should work. So you see, I have put it in a nice thick polythene bag, and in the inside bag there's only saline, only the perfusion fluid, and then we'll tie it in such a way that there's no air inside, so that the kidney doesn't get warm. Only after I put this,
your slides are not moving. Sunil, your slides are not moving.
My slides are not moving?
No.
1 second. Can you see it now? Can you see the slide now?
Not seen.
Yeah.
No?
Yeah, now it's okay.
Just now it is okay.
Make it
Now it is
full
okay.
screen.
Yeah. So you see that it is going inside a polythene bag, thick bag, with only the perfusion fluid inside. No ice, please. If there's one message I want to give you, a very strong message, is you don't put any ice inside the kidney. Only cold perfusion fluid. Ice will go outside. So you can either take sometimes if you don't have polythene bags, take a sterile container of steel, just like you have the tiffin box, like that. And that is a very good container which can be sterilized quite easily. So put a lot of perfusion fluid in that, put your kidney, close the lid of the container, and then put the container into another bag with a lot of ice like this, a thermocol bag or something like that. And then you can transport it to another center or keep it in your own center or whatever you want. If you want, if when you are sending it to another center, you must make sure that you give all the details of the patient: age, date of admission, what is the history, what is the cause of brain death, what is the time, what is the hemodynamic status, what is the blood group, what is the virology status. All this should be documented in a form. You should also give what is the bun creatinine, very important at the time of admission. And in inter-hospital coordination, you can take a lot of time, and you especially do multiple organs. The coordinators and the state office can be very busy. And if you are sending it to another center, you must inform them in advance so that they can start doing their cross match. You can send the blood also of the patient so that they can do the cross match. If a cross match is positive, they can get another patient and so on. So it is very important to use a lot of communication if you are sharing your organs. And WhatsApp and SMS is a great help. And as your program matures, you can devise a common form for organ sharing, which contains all the details of the donor and which kidney side it is, the dimension of the kidney, like weight, the length, the breadth, how many vessels, and so on. And then if you want to transport in another center, make sure that you write human kidney for transplantation. What is the address in the hospital where the kidney is going to go? And then whomsoever letter, if the package has to go through some security in the airport and all of that. Sometimes some blood is missing, and so on, but that is another story. Let's not get into it since we are short on time. I just want to end with saying that's why, because the process of organ donation is so complex, that's why you need coordinators, good coordinators, well-trained coordinators. And we at Foundation have been training coordinators constantly. We have trained some from Nepal also, because they are the ones who give the trigger for donation with the conversation with the family. As I said, we do the training, and we've trained a lot of these coordinators into various aspects: medical, legal, grief counseling, and transplant coordination. So if you wish to train your coordinators, you can always send them to us. We have experience in a large hospital in Chennai where our Mohon Foundation coordinators are there. And in 10 years, they identified 299 brain deaths. 291 families said yes to approached. And of that, 190 said yes to donation. And we had 66% conversion rate with a trained coordinator. So many organs from one hospital. So if you wish, you can get your coordinators trained, and it will help. We also do retrieval workshops in Bangalore in wet lab. We are doing it constantly with with Dr. Sunal Asthana. We have trained many surgeons in these retrieval labs. These are some of the surgeons who got trained in a retrieval lab. Let me just show you. And we had one surgeon who had never done a heart transplant. He got trained in our lab in from Madurai, and he went and did a heart transplant. So if they can do heart transplants, I'm sure our surgeons can do kidney as well. Thank you. All the best.
Professor Sunil Shroff for just highlighting the retrieval bench ejection, transportation. Apart from that, so many other aspects of the kidney transplantation, coordinations, and everything. So we have already 30 minutes behind the schedule time. So this is a time to go for the panel discussion, the cases with the surgical issues. The moderator will be the Vikas Jain. So Dr. Vikas Jain, will you take over the burden of the moderating? Doctor,
are you there?
Can I contact? Yeah. Vikas Jain ji. So we have the panelists are Prem Raj Gewali, Dibya Singh Shah, Anant Kumar, Ajay Oswal, Arun Kumar, and Jamal Rizvi. So over to Vikas Jain for the panel discussions. So we have only the 20 minutes time for the panel discussions.
Okay, sir. Can you see my screen, sir?
Yes.
Yes.
I first of all, I would like to thank Dr. Shroff and Naus for giving me this opportunity to conduct this panel discussion with deceased organ donor with surgical issues. And these are the esteemed panelists with us: Dr. Ajay Oswal, Dr. Anand Kumar, Dr. Arun Kumar from India, Dr. Dibya Singh Saha from Nepal, Dr. Jamal Rizvi and Dr. Prem Gewali from India and Nepal, respectively. Shall I start the first case, sir?
Yes, I think
Can you hear me?
I think you can take a little bit longer if the audience is interested.
Okay, sir. Right. So,
Well,
Dr. Adios, also, this case is for you. Can you hear me?
Yes, yes.
Dr. Oswald, this is the look. Have a look at this video. You have received this kidney from another center.
Frozen.
Yes.
Because this seems to be a frozen dessert.
जो मैं बोल रहा था ना retrieval में, packing में.
What is the feel of this kidney? Is it cork ball hard or
Yes,
normal
correct.
consistency?
Hard kidney. It's a hard kidney, as you correctly said. And Dr. Schroff has clearly mentioned in his presentation that this is a frozen kidney. Now,
This is a
you
frozen
accept, you
kidney.
reject.
I think I would reject it. It is of no use. And what could have gone wrong is this kidney was probably packed with ice around it rather than the preservation solution around it. Probably.
So that is what I want to bring to everybody's notice and re-emphasize what Dr. Schroff has just explained. Packing of the kidney is as important as retrieval or any other things. If you don't pack the kidney, your entire exercise of retrieval and everything is gone. It's a wastage of the organ which we cannot afford, sir. So, as you correctly said, so what is in your practice? Who packs the kidney? Either you do it when you retrieve it, your assistant does it, some resident does it, or transplant coordinator does it, sir?
No. Whosoever does it, it is all supervised by the senior-most person in the team, that is myself.
Okay.
If
And
we are
you make-
retrieving it, all aspects of that retrieval are supervised by me.
Okay.
My colleague may be examine and then explore the recipient, but earlier practice was to explore the recipient straight away and then open the package. But after we have learned some lessons like injured vessels or injured ureter or even injured parenchyma, we have changed our practice. We now examine the organ, perfuse it and pack it again. Once we have accepted
Okay.
the organ, then we open the recipient.
Okay. The message is very, very clear that once you receive an organ from a center, you open it, examine it, and probably do the bench dissection there, repack it, and then you explore the recipient. Otherwise, you will have surprises and you will be, you will regret that why did you open the recipient without seeing the kidney? Is it right, sir? That's what the message we want to-
Yes, that's what I want to say. Or otherwise, the person who has retrieved, say, in another hospital, has to be a very close friend whom you can trust with all the findings blindly. Say, because you have retrieved it and you have communicated to me very clearly about the findings, then only I should open the recipient first and box later. Otherwise, the standard practice should be open the box, examine, take a decision, perfuse the kidney, pack the kidney again, then open the recipient. That should be done.
So the message is very clear from this first case, examine first and then open the recipient. I'll go to Anand Kumar, sir, for the next case. Anand Kumar, sir, are you there, sir?
Yes, yes.
So you received this right-sided graft.
Yeah.
You can look at the renal vein. There is hardly any. Sir, what do you do?
I can reconstruct this vein if there must be some tissue.
Accept or reject?
Accept.
Sir, what could have gone wrong during retrieval? So very important that you have to tell us, sir.
This was the cadaveric donation. I don't know what they should have had the IVC cuff, but I don't know. They probably cut at the junction or just distal to it. But this can be used. There is no problem in using it. Maybe I can use the without any reconstruction. But if it's still not going there, then probably I might take the saphenous vein and reconstruct it and do it.
Okay. So what are your reconstructions? Once you said it's a saphenous vein, but sometimes you have some grafts available from the previous cadaver donors. Do you have that practice, sir?
Yeah, if there is a vein graft available, then I will use that. But if it is not there, then still I don't have. We can use the saphenous vein nicely. Some people have used the ovarian and testicular vein, but I don't use it because you need to have a good quality vein for long-term results.
Sir, suppose somebody is retrieving an organ, the right side vein, right side graft, sir. Usually the liver surgeon, they try to take as much of IVC as possible, and you don't get a cuff of IVC. That is why this happens. So do you want to be available at the time of retrieval when it's a multi-organ retrieval, or you just tell the liver surgeon to go ahead, sir?
I don't think so. Even in liver surgeons, they will be taking the IVC just above the renal vein. They don't take the IVC with the renal vein. Even if the IVC is cut flush with the renal vein, you can still get the part of the cuff, and some length you can always get it. And the part of the IVC which is gone to the left can be reused for the reconstruction of this vein also. So I don't think liver surgeon, yes, they are very close to the renal vein, and sometimes they injure it. That is the one thing they can do it. But they always leave the IVC just flush with the renal vein.
Okay, so that is what, sir, important point that you said. We got this kidney. Probably the liver surgeon were a bit more enthusiastic, and they did not give us the IVC cuff. And as you correctly said, we used the saphenous veins to reconstruct this right renal vein, and we were able to complete the transplant without any issues and had a good outcome. So it is very important. Through this case, I want to give a message that whenever you receive such a graft, you should have all the reconstruction options available to you. You should be able to exercise these options. And one of the commonest option is to have two important options are, one is you have a graft from the patient, the donor itself, or if you don't have that, you can use the saphenous vein of the recipient at the time of transplantation. So these are the
because Dr. Jamal needs to be added as a panelist. He is waiting and raising his hand, and he has requested that he be added as a panelist because he doesn't seem to be on the panel.
Can we ask someone from the
I've just been added. There is audience for this.
To say one thing is that in cadaveric donation, there are always a lot of IVCs available, even if the part of IVC is below the renal vein. That part of the IVC can be nicely used for reconstruction of the renal vein.
But sir, the problem is that you receive this kidney from other center. Probably they have not sent you all this. Then you have problems, sir.
Yeah, I'd just like to add that as part of the retrieval process for multi-organs, the iliac arteries and veins should also be procured every time.
Yes.
And usually one side will go with the liver, but at least one side should go with the kidneys. And this should be standard practice for all of us. The two kidneys, each kidney may not get it, but if it's there, it can be a lifesaver in a difficult situation.
Sir, this is important. Actually, if you are doing the retrieval at your center, you will have all these grafts with you. But whether to send it to the other center where you're sending the graft is important.
No, this should be protocol. I mean, there should be vessels accompanying at least one side of the vessel should go with kidneys.
I want to make a very quick comment here, if we be permitted by the permission. Because why, training of surgeons on organ retrieval is so important. And the right kidney should be easier to transplant than the left kidney, because right kidney should come with a part of the IVC, and it should be divided with the where the left renal vein is. A patch of left renal vein is given, and then the whole of IVC should come with the right kidney, so that you can reconstruct the vein and have a nice long length of vein along with artery. So the right kidney in cadaver should be easier to transplant than left kidney should be the message. And that's why all surgeons need to be going through training program.
Correct, sir. So retrieval has to be done properly, because problem with the retrieval will ultimately have bad outcome on the recipient side. We go to the third case, sir. Dr. Jamal, are you around?
I'm here.
Sir, 55-year-old male brain dead donor. You received this kidney with a 2 into 2 centimeter mass. It's hard nodule. You accept or reject, sir?
Right. So the short answer is that I will accept it.
And what's your plan, sir?
Now, the rationale behind accepting it is that there's literature to show that in kidneys which are known to have a small renal mass, it's fairly safe to do a partial nephrectomy and repair the kidney and transplant. This is also analogous to the fact that after partial nephrectomy, not in the donor situation from small renal mass, recurrence and metastasis are a very, very remote chance. However, the flip side of this is that these are all in patients who've been worked up and who've had thorough imaging and CT scans. We know that they don't have any tumors elsewhere. So there is a small risk. There may be another small focus somewhere else. But if pre-op imaging has shown a single lesion. There's a single lesion visible here. You can even use a surface probe and look at the rest of the kidney. I will accept the kidney. I will counsel the patients that they're getting what is otherwise a good kidney with a small lesion, which we'll remove. And there's a very minuscule chance of a recurrence happening. You can go with standard immunosuppression. Everolimus has anti-tumor activities, and that may be used in preference to other immunosuppression. And follow-up will be with long-term imaging.
Sir, so you don't do frozen section, and if it comes out to be RCC, how do you counsel the recipient? That's more important.
It depends on many things. It depends on how much time you want to give to this. It depends on availability of frozen section.
Okay.
Suppose your frozen section turns out to be, there are two scenarios. It turns out to be something benign, it turns out to be RCC. I think let's focus on if it turns out to be RCC. I still think in this situation, this kidney should not be wasted. And if you can convince the family that the chance that any risk from this thing is very remote, one can proceed with transplant.
Okay. Professor Prem Gaili from Nepal, are you around, sir? Dr. Gaivali from Nepal. He is one of the panelists.
Yeah, he's around because his name seems to be there.
But are you okay, Dr. Jyoti Saha from Nepal? Dr. Saha? No. Sir, anybody has got difference in opinion in accepting these kidney?
I can, because
sir, Anand sir, yes, sir.
Actually, I have even accepted very small tumors like 1 centimeter, 1.5 centimeter tumor, even in live related program, which we have seen in CT angio, and we discussed with the family, took it out, partial nephrectomy and transplanted. Until now, I've done in 4 such cases, even in live related program, and none of them had any problem in follow-up.
What is the longest follow-up that you had, sir?
I think the longest one is a 5-year follow-up.
And there has not been a single problem.
You have to do a good partial nephrectomy with negative margins. So like I will take 1 centimeter margin all around, repair it nicely, and then do the transplant. I have done 4 times in the.
Okay. Dr. Ajay Oswal, sir.
Yes, sir.
Sir, suppose you excise this, it comes out to be RCC. Hello?
Yes, because I am listening.
If it comes out to be RCC, sir, and your patient, you go and tell your recipient that there is a cancer in that kidney, and are you ready to accept? And if they say no, what is your call on that, sir? You have one recipient.
See, final decision has to come from the recipient and his family. This proposal is not entirely risk-free.
Correct.
He is taking the risk of developing a cancer in his transplanted kidney.
Okay.
Whether he wants to take that risk or not. I will counsel him properly, scientifically, in a calm and quiet manner, explaining all the pros and cons of getting a cancer-bearing, although excised tumor, cancer-bearing kidney versus remaining on dialysis versus cancer-bearing kidney having recurrence or distal metastasis and different protocol of follow-up for this transplant. But final decision has to be his after counseling. I cannot force upon him to accept this cancer-bearing kidney. If there is another recipient in the waiting list, that is fortunate. Otherwise, I have no option but to send this organ, unfortunately, to histopathology.
Okay.
Just remember one thing, you should offer it to another center, because if you have some blood left for cross-match, you should offer it to another center. Remember, with kidneys, you can wait up to 36 to 48 hours. The ischemia time is quite long. So, that you still have time on your hands. So you should explore all possibilities to place this kidney into some other center. There may be an elderly patient who may be willing to take it instead of a younger patient. So there are all kinds of combination possible. There is a literature available out there of large series of these patients where there was only one recurrence out of, I can't remember, 50 odd patients. In the
Sir, yes, 1 out of 187. There is one literature, sir.
Yeah, so if there is someone else who is willing to accept it, as Professor Shroff said, well and good. But it cannot be forced upon any recipient.
So the message is very clear. So these kidneys are acceptable kidneys. The long-term outcome is no different from the patients who don't have these tumors. and we should not force the patient to accept this kidney. They should be willingly accept from their own will. And if they are not ready to accept, we should be offering this kidney to other centers where you may find some recipient who will accept these kidneys. So this is a very important message. There is no change in the immunosuppression. Long-term follow-ups have been there and which have proven that they are very safe kidneys. We'll go to Dr. Arun Kumar. Dr. Arun Kumar, you are there? Dr. Arun Kumar, one of the panelists.
Arun Chawla is there.
Dr.
Arun Chawla.
Dr. Arun Chawla, sir?
He's there. His name is there.
Sir, can you hear me?
What happened to Dr. Our Nepal friends also are there. Prem, where is Dr. Prem? Wali. Subhash? I'm sorry, Pawan?
Sir, I don't know where. Okay. I'll give this case to you only, sir, as there's no one else.
Anant Kumar.
Okay, go ahead.
Sir, this is 65-year-old male, head injury, deceased, brain dead, hemodynamically stable. He had history of diabetes, hypertension, CAD and CABG. Creatinine is around 2.5 after 48 hours of listening. So this was done for NCCT scan of the abdomen was done for suspected blunt abdominal injury. I want you to look at the CT scan, which I am going to play right now. Look at the vessels, sir, closely. Look at the vessels, sir. The atherosclerosis, the amount of atherosclerosis of the renal arteries. I want you to look at this picture on the right side, sir. And also on the left side. So basically this is a brain dead donor with severely atherosclerotic vessels. Even the renal arteries and their segmental branches are extremely atherosclerosed.
They seem to be calcified.
Calcified, actually. Complete calcification.
Yeah.
Sir, you accept or to retrieve or reject, sir?
How are the liver vessels? I was wondering if they're going to retrieve the liver.
But even the
calcified vessels are going till the peripheral branches.
Correct, sir.
We usually don't see. I'm just wondering, is there anything wrong, or because cortex looks okay, but I don't know. That looks very, very unusual. Usually atherosclerosis seen, which is in the ostium or in the proximal part.
Correct. If you look at this picture, sir, this is entirely atherosclerosis, sir.
Right kidney especially.
Yes, right kidney especially, sir. Look at this kidney, sir.
But even left side also it is there.
Left side also has it.
Yeah, so it's very, very unusual. I might can take out the kidney and look at it and then
So you still will be ready to retrieve, sir. That is.
I'm just because I'm wondering whether it is a part of the contrast which was given for some reason.
It was plain CT.
Plain CT.
It's a plain CT, sir.
Maybe contrast was given and it is not known or something.
No,
I don't know.
That looks like.
So maybe still, I'm very curious what kind of this is. I will still, if possible, I'll take it because if the liver, other organs are.
I have discussed this case.
Look at it.
Okay, sir. Sir, who will retrieve this kidney? Any of the?
You must retrieve the kidneys and you must put it on the table. And if you have an elderly recipient, you can kind of give it to the elderly recipient because this kidney may not have a long-term kind of, it may not last very long. But even if the patient is dialysis free for 3-4 years, it will be very good.
Okay.
Especially left kidney can be used, I think.
So anybody who doesn't want to accept this kidney, retrieve these kidneys.
I would like to make a comment on that, not retrieval.
Okay, Dr. Oswald doesn't want to retrieve at least.
Because sometimes in India also remember that 70 years could be 80 years also. So age is a factor which is again very deceptive when a patient somebody gives age. But having said that, to be honest, I won't go by the X-ray. I'll always feel it on the table and see how the kidney looks, how the aorta looks, whether I can perfuse it well, and I'll take a decision on the table. I will not reject it, to be honest, because kidneys are so precious.
Okay, sir.
At least creatinine was 1.5. You know, the baseline creatinine was 1.5. So this kidney still has some life, according to me.
One thing is unusual. You can see that aorta is not so badly calcified.
Yeah.
Before and after, it is the only that part. So that's something. Look, it's a medial calcinosis or something different thing.
Sir, if you look at the aorta in this picture, sir,
This extensive.
sir. If you look at the aorta in this, it's extensive.
The right side is bad. I think the left side is still doable.
So suppose you have only one recipient. This is AB positive, who is 4-year-old male. Now, will you be giving it to this kidney to him? Dicey, sir.
Dicey because he's too young. Because this kidney is not going to give him a long. You know, he 24 years needs a kidney which will last at least 10 years. I can't guarantee that with this kidney. Not more than 2 or 3 years, maybe 4 years max, if he's lucky. Perhaps it's very difficult to predict.
See, another unknown variable in this patient is, in spite of hemodynamically stable, he is hemodynamically stable, no vasopressors, no sepsis. Then why his creatinine should have jumped from 1.5 to 2.5?
Poor management again.
Okay.
So my concern is not so the 2.5 that he's jumped to. My concern is the 1.5 that he started with.
Okay. Even that is not good.
Significant diabetic nephropathy.
Yeah. His GFR maybe one day about 30 or something like that.
He's almost on the borderline of CKD himself.
You're right. That's
possibly.
And if you look at the kidneys, they are not looking good, bulky, solid young kidneys. The cortex has suffered aging. The kidneys do not look normal. If you do renal volumetry, you will find that these are low volume kidneys.
Okay, sir. Okay, I've been asked to wind up because we are running short of time. One final question to Dr. Anand Kumar, sir.
Okay, go ahead.
What is the special technique in atherosclerosis vessel during recipient surgery, sir? Just give few tips before we close, sir.
Yeah, atherosclerotic vessel, there are two. One is that recipient, which is most common. In that part, one has to be, if it is very bad, then you have to make sure that how to put the clamp. So what we usually put the vessel tape and then do the rumal cannula. Take a figure of 8 and then push the rumal cannula. And then do not put these metal clamps over that because that can crack the artery. And most of the time we might have to put 2 rumal cannula, which most of the cardiac surgeons use proximally and 1 distally. And with that, we have been able to stop the blood flow of 99%. Some trickle is always going on, which you can keep managing. And second thing is that sometimes that you have to use that special needle which cardiothoracic people use that which can pierce the atherosclerosis nicely. That is the name of, I'm just forgetting the name of the needle. And you can always get from your cardiothoracic surgeons, and that nicely go through the calcified vessels. And third important thing is, especially external iliac artery, make sure that intima is not dissected. So to avoid the dissection, you should take a bigger bite in external iliac artery.
Okay.
When you take a bigger bite all around inside out, so intima will get fixed and it will not dissect. And if you have atherosclerotic artery into the the donor one, most of the time it is there and you can excise part of it and then you get the normal artery. And otherwise, if it is there and you have excised and it is still there close to the multiple branch arteries there or the donor, you have got another artery from the cadaveric donor, then you can use it. But receive donor arteries have never found so much a problem. Yes, recipient artery, and I remember one case in Newcastle, and artery was very bad, like a pipe stem. So I called the senior consultant who was the liver surgeon. He came and he put the clamp and it cracked and there was bleeding. They tried to control it and we lost that patient on table and nothing could be done. So that always I remember that case.
So, sir, important point, you use the Rummel's cannula instead of clamps, and you take bites inside out, use that cardiothoracic needle that you have mentioned, and try to fix the plaque, the atherosclerotic plaques, so that it doesn't move and intimal dissection is avoided. Yes.
And use I use most of the time 5.2 aortic punch. That cuts the artery very nicely and make sure the intima is not dissected. If intima is dissected, then it should be fixed separately from both the needle, both the side needle, and go inside out both the needle and just tie it so it nicely get fixed.
Okay. Right, sir. Thank you so much.
Dr. Vikas?
Did you use his kidney, by the way?
Sir, sir.
Or you rejected it?
Dr. Vikas, we are.
Yeah, yes.
Finally,
Finally,
so
thank
would
you
you
so
like
much.
to wrap up or this case
Yes,
discussion?
thank you so much. This is my last slide.
What
Again,
happened to
thanks to all the panelists.
Vikas, what happened to that patient?
Which one, sir?
That which you were showing, this one.
Sir, when Dr. Ajay Oswal Center, he did not retrieve this.
Liver was retrieved and transplanted. Liver recipient did very well. Kidneys were not retrieved.
Kidneys were not retrieved, sir.
Okay.
Okay, thank you, sir.
Thank you so much, all the panelists, and Dr. Pawan for.
Thank you. Thank you.
Thank you, Pawan.
Thank you, sir. So hopefully we'll share you the good news that we also started the disease donor program at Kathmandu, at least in Nepal. You have been very helpful, and it's inspirational for all of us because we have done so many these sessions, training with the help of Mohan Foundation in Nepal. Our critical team, nephrology, Nuts of SARC, they are also been very keen and they are very helpful to start this program. And hopefully in this time, I need to thank especially to Dr. Sunil Sharaf, Mohan Foundation, Dr. Pallavi Kumar, Dr. Subhas Acharya, Dr. Sumit, and my friend Dr. Vikas. He is very extensive in taking all those cases and very good input from the panelist, Dr. Anand Kumar, Ajay Oswal sir. So we had a very informative session last year with us, along with Anand Kumar sir in our update series. We're also very thankful to Arun Kumar, Jamal Rizvi, and our chairperson, Rishi Kumar Kafle sir. If I miss any name, so please pardon me. So and Bolaraj Joshi sir. So thank you very much. Stay safe because the time is very difficult for all of us. So we expect that we could meet physically at Kathmandu, but it's very difficult. And we could meet on this virtual platform. Thank you, sir. Thank you very much.
Thank you, Dr. Pawan. Thank you. Only my one request is to Dr. Sunil Sharaf. Can we make similar film in Nepali version?
Yes,
So that it will be easy to understand to the public.
Sure, we can do that. But why do you need public? This is more for the training for coordinators.
Okay, nice. So we can use that training with the Mohan Foundation so that that type of
we have made it in Hindi, sir. Hindi is quite easily understood by most of the people in Nepal. So we are now making more Hindi films. We'll share it with you.
But we can make it in Nepali so that it will be more understandable.
Sure, sure.
Yeah.
You need to take a copyright from Dr. Sunil Sharaf and Mohan Foundation. We can do it. Don't worry. Media people will nicely do all the editing and the translation.
Make it, sir. Make it in one in Nepali.
But you need to take a copyright from them.
Okay. Thank you, Dr. Sunil.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Ajay, Dr. Sunil, Dr. Jamal, Bikash, and everyone. Thank you.
Bye-bye.
Respected seniors and colleagues, a very good evening to you all. Finally,